A very good my friends. Good morning, Arjuna Sada ma'am. Welcome to IDS. So we start with the 6th International Diabetes Summit, and due to COVID pandemic, this year we will be virtual. On behalf of Dr. Unnikrishnan sir and team IDS, I welcome all of you for the scientific program from the best hall. I am the hall coordinator, Dr. Vedavati Purandare, and I have my colleague, Dr. Shweta. Good morning, all the faculties. So we have first interesting session related to type 1 diabetes today. Management of type 1 diabetes towards an Indian perspective. And whole day we will be discussing various aspects of type 1 diabetes, and we have stalwarts in the field to give their sessions, and we have experts in the field to chair the session. So we start with the first lecture, introductory aspects of type 1 diabetes, and to chair the session, I will invite Dr. Jaideep Revade.
Yes, ma'am, I'm there. Yeah. I'm there, ma'am.
Yes, sir. You can start the session.
Okay. So, good morning, everyone. So, we have Dr. Archana Sarda from Aurangabad, leading diabetologist.
And CV slides projected, please, for the chairpersons and speakers.
Yeah.
Next slide. For Dr. Jaideep Revade and Dr. Archana Sarda ma'am. Dr. Jaideep Revade. Next slide. Yes, so Dr. Jaideep Revade is renowned diabetologist in the city of Satara, and he is founder director of Diabetes Nutrition Awareness and Diabetes Center, and he is a very enthusiastic and very popular doctor, and he has delivered n number of lectures in various international and national conferences. So welcome, Dr. Jaideep sir, and over to you. You can introduce Dr. Sarda madam.
Yeah. Can we have an introduction of Sarda madam? Yeah. So good morning all, and to start with, we have a very interesting talk by none other than Dr. Archana Sarda, madam, who is an eminent diabetologist from the historic city of Aurangabad, and her special interest includes endocrinology, diabetes, metabolism, insulin therapy, blood sugar monitoring, diabetes foot problem, and specifically type 1 diabetes. Dr. Sarda has organized and conducted very systematic program for the management of the large number of underprivileged population of type 1 diabetes. And her work for the type 1 diabetes is commendable, and she is having very high passion for type 1 diabetes patients who are underprivileged, and which has been widely appreciated across the country and worldwide also. So I request Dr. Archana Sarda madam to deliver her talk. Madam, over to you.
Thank you so much. Thank you, Dr. Revade, and it is such a pleasure to be here. Thank you, Dr. Uni, Dr. Veda, Dr. Shweta. I think to have this entire day talking about type 1 diabetes, all its aspect and the Indian scenario is a treat. I think in 20 years of practicing with diabetes, this was a vision, this was a mission, and it feels so good today that the entire hall, entire faculty, entire topic is dedicated the entire day to type 1 diabetes. This is much needed, and my compliments to the IDS team for organizing this. So today I'm the opening batsman, and I will be taking you through the epidemiology. So the topic given to me today is the type 1 diabetes in India epidemiology. Just at the onset, I am not an epidemiologist. I myself am learning, but as founder of UDAN, I work in the rural areas. I'll just make this full screen. Is this full screen now? Is it visible?
Yes, ma'am.
Yes. So when we work, I work in the rural areas of Maharashtra, that is Marathwada. And today, UDAN supports more than 900 underprivileged children. And we are fighting for a place in the type 1 community, in the area, in the city, in the town, the state, and then the country. And that all makes us think that if we are not part of a bigger group, if we are not represented, if we are not documented, then there is a way that our voices are not going to be heard. And with that thought becomes a very important topic of epidemiology in India is something that is going to be relevant for every clinician. Why epidemiology? So I was just thinking that, okay, we had our preventive and social medicine in college, probably not the most, very few people were very enthusiastic about it. And today when we are in our clinics, we are so much passionate and we are so aggressively working to take care of our patients clinically, taking care of them, trying to get good outcomes, that somewhere we lose the interest when it comes to the documenting them, when it comes to presenting papers on them, when it comes to actually knowing what is happening as a group in the entire country. So if we look, I looked up the epidemiology definition for all of us who don't really work in it as epidemiology for the uninitiated in the BMJ. And I found this very interesting definition, that it is the study of how often diseases occur in different groups of people and why. So when I'm in Marathwada, I want to know why. How many more children are there in Marathwada? And what is happening to them? So this information is used to plan and evaluate strategies to prevent illness. So if we can prevent it, or as a guide to management of patients in whom disease has already developed. For example, I really want to emphasize this point here. Currently, we are in talks with the government at Maharashtra state level. Now, they ask us that why glargine? Why are you asking for basal bolus? Why can't we just do with regular insulins? Then they ask us, why do you need strips? Why do they need to more? So where is your data? Where are your numbers? So whether we talk to policy makers who can provide care at a government hospital level, what are they going to need? They are going to need studies which show that this is the right thing to do, that this is going to have a impact on large numbers in the country, in the state. Otherwise, why would they sanction funds for their care? And then again, as a guide to best practices, when I started working, I'm an adult physician. And when I started working type 1 diabetes, I wanted to know what are the best practices. So this whole platform of knowing the entire epidemiological information is what sets the base in making a country robust when it comes to good care practices and as well as policy decisions at every level. So with that thought, we go ahead and see for all the information. Today, we will start from global, and I am quoting the recent IDF Atlas of 2021, which says at a global level, numbers of new, that is incident, and existing, that is prevalent type 1 diabetes cases are increasing each year due to rising incidence in many countries and reductions in mortality. This has been observed in this year's, last year's, that is 2021's IDF Atlas, and with this, a lot of numbers and data have been shared. But what about India? Do we really have adequate studies of our own? India does not today have a national registry. So if we are all wanting to have this, a lot of talk is there and a lot of steps have been taken, and very soon in the near future, I hope we will be having a national registry. But currently, not having a national registry gives a skewed representation internationally about numbers. So whatever IDF has estimated is actually an estimate from whatever parts, whatever representations they could find. So let us look at the numbers currently. What is the situation as per IDF? So if we just look at an overall picture in the world, just to set the stage to understand what these numbers mean, then IDF estimates that children and adolescents between 0 to 19 years in 2021, that is per annum considerations here, the total population is 2.64 billion. So that is the total number of children and adolescents in the world, 2.64 billion. Number of prevalent cases is 12,11,900. Now, such a specific number, and there are some numbers which were not figuring in it, but still, this is the current current number given, which is 12,11,900. The number of incident cases per annum, so that is the number which are detected new, is 1,50,000. So this is a global estimate. But what does IDF estimate for India? These are the India estimates. So IDF's estimation, because we do not have an India estimate from India, I mean, which is something that I feel very sad about, and we are definitely going to all together do something about it. And if we look at this per annum, number of prevalent cases by IDF for India has been 2,29,400, and as of 2021, and number of incident cases is 24,000 per annum. So these are the numbers which are given to us. But if we think about it, all of us today who are attending a type 1 symposia, which means that we are interested in type 1 diabetes, or we have some patients with type 1 diabetes, is our numbers, our patients, our children part of any pool? Are we part of any registry? Have we been reported? Are we reporting our new cases as and when they come? And who do we report to? I totally agree. So we do have a lacunae, and we are going to talk about that today. As per IDF Atlas, as a country, India now has the highest estimated number of prevalent type 1 diabetes cases of people under 80 years of age. So, I mean, we were the diabetes capital for type 2, and that was not a happy thing to happen. But in type 1, sheer numbers, this is because our population is so high that in sheer numbers, we have now surpassed any country in the world. And with this number, we are followed by USA and Brazil. So this is the largest number in the country, in the world, as far as numbers are concerned. I want to very specifically recalculate here. Let's go back and think about it. Is this number right? I mean, of course, we respect the number, but we have to rethink. So there was a very interesting editorial by Dr. Anju Virmani in Indian Pediatrics in 2019. And I will take that and talk about it in current context. So let's recalculate. So extrapolating from a prevalence of 0.54 per 1,000 population in expatriate Indians in UK, because they are very well documented. Hence, and they are of all Indian origin. So considering the same soil, the same common resources, this figure translates roughly to a prevalence of 7,56,000 in a population of, currently we are 140 crores. Assuming that all patients with type 1 diabetes are diagnosed and all survive. So what a dramatic change that if we look at this simple statistics, we are probably 7.5 lakhs somewhere, and as compared to 2.25, which has been reported in IDF. But where? So where are all these children? Where are they disappearing? So are they dying? Are they dying because they are lack of resources, not early diagnosis, not getting adequate care, especially in the rural areas, in the low resource setting? Because we also know there are a lot of studies which talk about they being on the higher numbers in detection, but survival is lower. So are they dying, or are they simply undocumented? This is a point where I would like to pitch in and say, for example, my children in the rural Marathwada, I have today 970 children, families, but they are not part of any Indian registry. So that 1,000 children in a 2 lakh is a very significant percentage. And how many more of us are there? So again, to emphasize a point that we are underdocumented, underreported, our incidence and prevalence needs to get really robust. But let us look at what we have. What is the data we have? So current data in the Indian studies, the first attempt to study prevalence was in Chennai. 30 children were identified, and the prevalence was 0.26. Then a diabetes registry was then done between 91 and 94. This was with Ramachandran et al. And overall incidence was found to be 10.5 per lakh per year. So this was the earliest study done, and which gave us the numbers and something to look into. And then more study, it inspired other people to study. And another study, another robust study that we have is dramatically opposite. Like this is from south, we have right in north in Karnal in Haryana district by Dr. Kalra et al. And this was a hospital-based prevalence study. Here, overall prevalence of 10.2 per lakh population was found. A very interesting aspect was found that there was a very wide rural and urban divide, as well as a male and female divide. So while the urban was 26.6 per lakh population and the rural was just 4.7 per lakh. The boys, the male gender was 11.56 per lakh population, while the females were 8.6 per lakh population. So at the time, this is 2010 study, it was thought that maybe the rural children did not get access to care. Did they die? Did they not reach the hospitals? Was that the reason? Again, a bias for the male child. We know that in some communities it is very, very high. Was that the reason? So all these factors confounded it, but this was one study which is very prominent that is available. Two more studies are there. One was very near to Chennai, and that was in Karnataka. It was a multicentric study, and over 13 years registry data was collected, and it reported an incidence of 3.7 per lakh in boys and 4 per lakh in girls. Again, a recent study, we can't call it very recent, but this was 2015, was by Government of India in schools, where in UP, MP, and Rajasthan, they had one site each and conducted school surveys. And they found the potential burden of type 2 of childhood diabetes at 1.46% out of the 30,000 school children surveyed that was suspected to have diabetes. Now, this had both type 2 and type 1. So this is all. I mean, I have just given you 4 studies, and these are probably the only 4. So there are few more studies, but very small and scattered. But the entire review of literature, entire working reveals just a handful of studies when it comes to incidence and prevalence in India. So data is now urgently needed. I think today, while I'm talking about epidemiology, my main focus is that how urgently we need data for effective planning. Given this enormous burden of controlling diabetes, today we can't prevent or cure it as of now. We need to give attention and resources to the healthcare provider, community, administrators, and industry. What do we focus upon when we do not have data which tells us how to plan, how to go forward? So this is an urgent need. Once we have seen the numbers, you can see it was just a handful of studies, then we are also looking at, obviously, how are these children doing? So do we have many studies? Sadly, not many. I have picked up 4 prominent studies which are available, which have been published, but small studies here and there would be existing, but we do not have a large number of studies, as would be expected in a country like ours with such huge numbers and such a robust medical practice. So one of the studies is in 617 type 1 children with onset below 20 years. This was by Ramchandran et al. And reported a retinopathy of 13.4%, nephropathy in 7%, sensory neuropathy in 3%, ischemic heart disease in 0.5%, and peripheral vascular disease in 0.5%. So these gives us, when you have a study, it gives us an idea, and we can set benchmarks. We can understand what is happening in our own clinics, in our own data. Jevlikar, this was very recent et al. In a series of 577 patients. They had walk-in all the patients that they had. 87.4 children with type 1 diabetes and 8.5 had type 2 diabetes. This was before 18 years of age. But what they found very interestingly was that the duration of diabetes more than 2 years was only in 36.6%. And yet, they had retinopathy in 10% of the patients, nephropathy in 13.4% of the patients, and neuropathy in 6.2% of the patients. So this is a very high attrition rate. And that is something we need to look into. What are the factors? Bhatia et al. From Lucknow in 2004, this was one of the early studies, reported that out of 160 diabetics, the mean HbA1c was 8%. So that is a tertiary care center and considered for optimum care, and HbA1c was 8%. Ketoacidosis and severe hypoglycemia in 2004 were 5 and 3.3 episodes per 100 patient years. And with mean disease duration of 10.2 years, retinopathy occurred in 22%, nephropathy in 18%, Mortality was high at 7% over 823 patient years of follow-up. So this kind of data, when we have, we understand what to look for. We understand where to focus. We understand what are our targets for glycemic control. What to expect is how the child, how the population with type 1 diabetes is going to behave, and where to spend our energy, time, money, resources, where to appeal to the various contributors in taking care of a child with type 1 diabetes. But the last study was very interesting because Dr. Bhatia's study was followed up later from Lucknow, and this had 512 patients because that was in 2004. And from 1991, where they started, to June 2015, they published in Indian Pediatrics, and the mean HbA1c was 8.3. Severe hypoglycemia was 3.9 episodes per 100 patient years. Hypertension was now seen in 11.7% patients. Microalbuminuria in 10.3, gross albuminuria in 3%. They found a very significant reduction of retinopathy over the years in numbers, but mortality rate was still very high at 1.1 per 100 patient years. Now, this is something, the deaths were mainly related to diabetes. At least 6 out of 10 deaths were related to diabetes, and mostly out of renal failure. 2 patients committed suicide in the 3rd decade of life. This also gives us an insight again, when we look at what are the causes of death in all the pediatric population, or as they grow, or as we see in the 3rd decade of life, are we really even looking at mental health? So this whole follow-up was an eye-opener. But again, it's just a handful of studies. If we look, we might find just a couple more, but these are the only few. So we were talking about numbers, we were talking about outcomes, and we just have a handful of studies in our country. But the learnings are great. They have shown us that the best of centers, glycemic control is not optimal. So that's a wake-up call. Today, we are going to be in this conference. We're going to learn how to take care of our children with diabetes, and as they grow older, and we have to focus because we know outcomes are changing. Again, comorbidities like hypertension are very common. Complication and mortality is still high. We still have to deal with severe hypoglycemia. But when we look at this, it also gives us hope, because as many of these issues are today can be tackled. They can be tackled with neuroinsulins, they can be tackled with education, they can be tackled with technology. But it will only happen if we recognize the need, and hence the absolute need of epidemiological studies where we can focus that, yes, we need a CGMS, we need more glucometers and Smbg monitoring, we need more education systems. So where are we going to emphasize until we have data which tells us that lack of it is leading to worse outcomes? So this is a learning. We go with the sad parts, but with hope that we have resources to make it better. So a positive outlook is that India is definitely changing. The situation seems to be changing. On ground, if we don't look at numbers right now, because they're not that reported, we still see around us, we see there's reduction in poverty, there's better communication and technology, greater awareness amongst the healthcare providers, and more trained specialists. So definitely we have earlier diagnosis, increased survival. We are seeing it in every part, but it is not getting reflected in our data. And that is very important. Even with this, we have miles to go. We have so much to do. The national registry has to happen. That is the only way we can have a health policy change. We have to know all the comorbid conditions, the celiac disease, hypothyroidism, everything needs to be known so that average clinician will be able to look into it and have a guideline on what to do and have resources. The need for technology needs to be established. The social determinants in India are so different from across the world. They need to be factored in somewhere. And the cause and effect, simple few cases reported, for example, the milk, the camel milk offering protection, or the difference between the A1, A2 milk. All these factors need to be documented to bring a change which could be specific to an Indian child. So I would just like to end here in the last 2 slides by saying that children with type 1 diabetes continue to fight for their rightful place under the sun. This was an article by Kumar et al. And Dr. Kalra, and this was like in 2012. This is 2022. Today also, children with type 1 diabetes are still fighting for their rightful place under the sun. Yes, we have more resources, we have more technology, we have better care, but is every child in the country able to access that? One of the reasons we are not able to bring that dramatic change, in spite of our interest, in spite of everything being available, is not having adequate epidemiological data, which we can analyze and present and come back with it. So my take-home message from the epidemiological talk is that let us document, let us contribute our data, enabling solutions in care and influencing the healthcare policies. Every child matters. And this is one way, wherever 5, 10, 15, 20, where we are, let us contribute to the mainstream of Indian data. Thank you so much.
Thank you so much, Dr. Archana Sarda.
Thank you.
Yes.
Go
Thank
ahead.
you. Thank you very much. Yeah, thank you, ma'am, for a really eye-opener lecture on the, as an opening batsman, you have created a very solid ground, and you have actually put the reality of type 1 diabetes and Indian registry is lacking. And as a clinicians, we should look ahead and we should take a strong action to form the registry for the Indian type 1 diabetes patient. So I have just one question for you. Is there any epidemiological data in terms of the survival or the life expectancy in type 1 diabetes, specifically in India?
No, recently, no. There was one long back, and that was, I think, 40 years was what it said. But Indian data currently in last 15 years, I have not come across.
Okay. Because I do remember one.
Yes, please.
Yes, you go ahead, ma'am.
Go ahead, please. Tell me.
Yeah, because I do remember one patient shared by Professor V. Mohan on social media that living up to 90 years.
Oh, yes. Oh, yes. See, today I have, we all have patients. I think Dr. Mohan did a beautiful program where there were all people who survived more than 50, 60 years of type 1 diabetes presented, although they were still not a large number. But even in our part, we have, I have a type 1 person who is more than 40 years of type 1 diabetes, so many above 25, 30 years of duration, but we do not have a study which tells us this is possible. Hence, the consensus in an average non-type 1 treating doctor is that they don't survive very much, which is again what they tell the patient and their family, which again demotivates them as well as the family. So when I started work, everyone used to tell me that, why are you doing this? They don't survive long anyway. So why put in so much an effort? So that is what we need data for, because we know they are surviving, but we don't have documentation.
Yeah, I think one study you shared that it has shown that there were the 2 suicide cases. So I think that must be because of that depressive talk from the medical fraternity. So thank you very much, madam. It was really eye-opener, and hopefully throughout the day there will be more pearls in a type 1 diabetes, and we'll soon have a type 1 registry.
Yes,
so
totally looking forward to today's seminar all day. Thank you so much.
It was fantastic talk.
Thank you so much.
So I think we are ready to move to the next talk. Yeah. So next talk is on a diagnosis of type 1 diabetes Indian perspective. So we have an eminent speaker, Dr. Sukanti Kumaran. She is a consultant physician at the Chelaram Diabetes Care and Multispecialty Hospital. She has done her graduation from Madras Medical College, and she is the MD with in a good Samaritan Hospital, Ohio, USA. And she's been practicing medicine for more than 20 years. So huge experience in a various settings, both in US and India, and which include the private practice, occupational health, and as a consultant physician. So, ma'am, over to you.
Thank you, sir, for the wonderful introduction. I have my presentation as a recording, which you'll be seeing soon.
Diabetes Summit, 6th meeting. I'll be talking to you about Indian perspective on the diagnosis of type 1 diabetes. The agenda for my talk is a brief introduction, epidemiology, pathophysiology, diagnosis, presentation, conundrum of type 1 diabetes diagnosis, investigations, how to differentiate or what are the differentiating features from type 1 diabetes and monogenic diabetes, differentiating from type 2 diabetes, and the last slide being take-home messages. Let me start with the case. This is a 28-year-old male with a BMI of 25 kilograms per meter square. He's seen by a physician because he is complaining of fatigue and blurry vision. On questioning, he states he has polyuria because he sits in the air-conditioned room. He always has a habit of drinking a lot of water. However, he did have 5 kg of weight loss over a 3-month period, which was unintentional. His blood glucose values, fasting was 200 milligrams per dl and postprandial 300 milligrams per dl with a HbA1c of 10%. Routine urine exam showed both glucose and ketones. Ultrasound abdomen was normal. So which of the following tests need to be ordered first to help with the diagnosis? Is it C-peptide? Is it anti-GAD antibody? Is it genetic testing? Or A and B, both C-peptide and anti-GAD antibody? We'll come back to the case after the discussion of this session. So as everybody knows, type 1 diabetes is characterized by insulin deficiency. Why? Secondary to the beta cell destruction. How does the beta cell destruction happen? Either due to autoimmunity or idiopathic cause. If it is autoimmunity, secondary to autoimmunity, which is the case in 85% of the cases, it is called type 1A. If it is secondary to idiopathic causes, then it is called type 1B. Although the onset is frequently in childhood, it can occur in adults. So moving on to the epidemiology, the International Diabetes Federation December 2021 statistics shows that there are about 1.2 million type 1 diabetes individuals between the age of 0 to 19 all over the world. About 10% of the people with diabetes are type 1, and the incidence is increasing every year by 3 to 5%. In 2015, the incidence of type 1 diabetes in India was 3 per 1 lakh children, age of 0 to 14 years. About pathophysiology, brief words. Type 1 diabetes is the culmination of lymphocytic infiltration and destruction of insulin-secreting islet cells of pancreas, as a result of which hyperglycemia happens. About 80 to 90% of the beta cells are already destroyed at the time of hyperglycemia presentation. This happens in genetically susceptible individuals. So it's a combination of several things. In genetically susceptible individual, viral infection like enterovirus triggers the immune response to the viral protein. However, this cross reacts with the beta cell protein, resulting in the autoimmune destruction of the beta cells. About 85% of type 1 diabetes have circulating islet cell antibodies, most common of which is anti-GAD antibody, which is an enzyme. Glutamic acid decarboxylase is an enzyme present in the beta cells of the pancreas. Obviously, antibodies to this enzyme is going to destroy the beta cells. Now, talking about the diagnosis, what is the criteria? As per American Diabetic Association, the fasting blood glucose more than or equal to 126 milligrams per dl, 2-hour plasma glucose value of more than or equal to 200 milligrams per dl after 75 gram oral glucose tolerance test, or a random blood glucose value more than or equal to 200 along with the classic symptoms of hyperglycemia like polyuria, polydipsia, weight loss, or even hyperglycemic crisis, and HbA1c of greater than or equal to 6.5%. There is a little trick in this value. For type 1 diabetes in younger population, there is a study from Germany which had shown that the value as low as 6.35 also detects the diabetes in the younger population. So saying that HbA1c value can be checked if the patient do not have the classic symptoms and there is a doubt that the diagnosis may be type 1 diabetes. What is a classic presentation? Usually it's abrupt onset. All of a sudden, a young child gets admitted in the hospital with a probably history of polyuria, polydipsia, polyphagia, and weight loss. Usually the admission diagnosis is always diabetic ketoacidosis because it's an abrupt onset and the patient is in a very critical situation. Sometimes they may also have fatigue, nausea, and blurry vision. So let's talk about the conundrum. Why do we have difficulty in diagnosing type 1 diabetes when they don't have the classic presentation? Adults with a new onset type 1 diabetes, they may either present acutely with the 1 to 4 weeks of illness or more gradual or slowly evolving process when the diagnosis may be confused with type 2. If it's a monogenic diabetes, it's very common, especially less than 25 years of age. So it'll be hard to differentiate if the patient is less than 25 years, whether it's type 1 or whether he is type 2, a monogenic diabetic patient. In older adults with pancreatic cancer, the presentation itself is weight loss and diabetes. Another latest emerging issue, a new issue, is the presentation of hyperglycemia and DKA, which is diabetic ketoacidosis, because of insulin deficiency in individuals treated with immune checkpoint inhibitors. As we all know, immune checkpoint inhibitors are nowadays used for treatment of cancers like melanoma and lung cancer. It is really producing good results with the cancer. However, these patients can develop diabetes as early as 3 to 4 weeks once starting these immune checkpoint inhibitors. This is one of the new emerging factors, issue that people need to be aware of while diagnosing type 1 diabetes. Now moving on to the islet antibodies, islet autoantibodies. As I said earlier, glutamic acid decarboxylase antibody is the primary antibody which has to be checked. If it is negative, then we move on to the next couple of antibodies, either islet tyrosine phosphatase, which is also called IA2, and or zinc transporter 8 antibodies if the facility is available. However, let's say these both are negative and the individual was diagnosed with type 1 with the age less than 35 with no clinical features of type 2 diabetes or monogenic diabetes. As I said, even though the antibodies are negative, still it does not change the diagnosis. He is still type 1 diabetic. Why? Because 5 to 10% of the people with type 1 diabetes will or may not have the autoantibodies. And also as the age progresses, the antibodies may not be present. Now moving on to the next slide, few slides, next 3 to 4, 5 slides, I'm going to talk about C-peptide. Why I'm stressing more on this? Because we are going to use the criteria after testing the C-peptide to diagnose type 1 diabetes, especially in adult patients who are newly diagnosed. This is as per the statement, consensus statement, which was published in September 2021 by both ADA as well as the European Association for the Study of Diabetes. Now, what is C-peptide? As we all know, it's a connecting peptide. It connects both alpha and beta chains of proinsulin. The proinsulin is divided into insulin and C-peptide in equimolar concentration after being stimulated by the glucagon or secretococcus or the glucose. Now, what is C-peptide primarily going to do? It helps with the assessment of the insulin secretory reserve in patients with diabetes. A fasting C-peptide value less than 200 picomoles per liter or less than 0.6 nanograms per milliliter is consistent with beta cell failure and patient needs insulin therapy. So plasma C-peptide is generally recommended for testing. We do not do the urine C-peptide. Why? Because if there is abnormal kidney function, it is going to affect the urinary C-peptide. If urine C-peptide creatinine ratio is measured, less than 0.2 nanomoles per mole indicates severe insulin deficiency. If a random plasma C-peptide is done, let's say with a concurrent glucose administration or after the patient is done eating, within 5 hours after he is done eating, that is one of the tests that is usually recommended. If that value is less than 200 picomoles per liter, then we know for sure the patient has type 1 diabetes. Now let's classify or talk a little more detail about the age and the diagnosis. If the adult of age less than 35, no features of type 2 diabetes and monogenic diabetes, has a C-peptide level less than 200 picomoles per liter, diagnosis is type 1. So the key is C-peptide less than 200 picomoles per liter. If persistently the C-peptide is always about 600 picomoles per liter, diagnosis is type 2. Let's look at an adult with age more than 35. We are not sure about the classification. He has some features of type 2. We give him a trial of non-insulin therapy. Then we recommend a C-peptide testing again after 3 years. Again, if the level is less than 200 picomoles per liter, diagnosis is type 1. If it is intermediate, let's say it's between 200 to 600, then it's still indeterminate. So what do? We repeat the C-peptide again after 5 years. So let's move on to the flow chart that I was talking to you about. Adult with suspected type 1 diabetes, first test that we do is islet cell autoantibodies. Positive, type 1 diagnosis. As I mentioned earlier, 5 to 10% may not even have the antibody positivity. Still, we cannot ignore that they are not type 1 diabetic. So what do we do then? We try to classify depending on the age. If the age is less than 35, what do we do? I'll see in the next slide. And more than 35, again, I'll talk about it in the next slide. Age less than 35. Do they have features of any monogenic diabetes? Yes, then we still test the C-peptide. If it is more than 200, there is a possibility the patient has monogenic diabetes, so we send them for genetic testing. However, as I said, the number is less than 200. C-peptide less than 200 picomoles per liter, diagnosis is type 1. Let's say less than 35 years of age, but they do not have features of monogenic diabetes, but they also do not have features of type 2, then obviously the diagnosis is type 1. Now let's go to the patients with age more than 35. But before that, if their age is less than 35 and they have features of type 2, then again we cannot say they are type 1. More than 35 years of age, classification is not clear. Again, what do? We give them a trial of non-insulin therapy. Then we check the C-peptide. After 3 years, if the number is less than 200, type 1. More than 600, diagnosis is type 2. Between 200 to 600, they fall under the indeterminate category, which means we have to repeat the testing after 5 years, C-peptide. So what is the genetic testing, or when is the genetic testing recommended? Molecular genetic testing is generally recommended irrespective of what age the patient comes to see us, if they have been diagnosed with diabetes when they are less than 6 months of age. Why? The chances of them having monogenic neonatal diabetes is high. In fact, 80% of them will be positive or may have monogenic neonatal diabetes. In that case, why is it so important? 30 to 50% have ATP sensitive potassium channel mutations. What is the advantage of this? Because we can stop insulin and start treating them on sulfonylureas. They will respond very well. So obviously that is the reason why we need to have genetic testing done in these patients. What is monogenic diabetes? Earlier it was called maturity onset diabetes of the young, MODY. What are the characteristic features of monogenic diabetes? Age of diagnosis less than 35. Usually diabetes is not that bad. HbA1c is only 7.5 at the time of diagnosis, and one of the parent may have diabetes. And they may have other features of monogenic cause, like it may be associated with renal cyst or partial lipodystrophy. Because of the partial lipodystrophy, they may have severe insulin resistance in spite of not being obese. They may also have maternally inherited diabetes, deafness. So molecular genetic testing, when should it be considered? If the antibodies are negative and non-fasting C-peptide is more than 200 picomoles per liter. Why? We know for sure C-peptide less than 200 picomoles per liter, diagnosis is type 1 diabetes. Now let's see the differentiating features, or what is giving confusion between type 1 and monogenic diabetes. Monogenic diabetes is generally found in age group less than 30. So 4% of those diagnosed with diabetes before 30 probably have monogenic diabetes. The likelihood increases to 20% if the autoantibodies are negative and the C-peptide secretion is maintained. So commonly it is mistaken for type 1 because of the young age of onset. The differentiating type 1 from type 2 diabetes. When does the confusion occur? When the newly diagnosed diabetes individuals present at an older age but they are thin or not much obese. Or if the diabetes is diagnosed in a young adult who is obese, then we are confused with type 2 diabetes. Even though DKA, diabetic ketoacidosis, was pathognomic for type 1, nowadays, or at least there are exceptions, type 2 patients also have ketoacidosis, especially when they are ketosis prone. Over 40% of those developing type 1 after the age of 30 are initially treated as having type 2 diabetes, especially because of the overweight or the obesity. Rapid progression to insulin requirement, which is less than 3 years, diagnosis is type 1. Again, there is a controversy which exists in the latent autoimmune diabetes of the adult called LADA. It's a discrete subtype and it's a milder form of type 1 diabetes which has a mixture of some individuals with type 1 characteristics and others with type 2 diabetes. So now let's go back to the case. Here is the patient who is not that obese, but he is overweight, young individual, less than 35. He has the features of polyuria, polydipsia, and weight loss with a high blood sugar. HbA1c is 10%. Usually in monogenic diabetes, it is not that bad. At the time of diagnosis, it's 7.5. And urine does show ketones. So obviously he has ketosis. So what do we have in mind? We are thinking more in terms of type 1 diabetes. So the first test, or at least the most important test that needs to be done, is C-peptide and the anti-glutamic acid decarboxylase antibody. So obviously the answer for this is D, which is both A and B. If the C-peptide is normal and the autoantibodies are negative, then we would recommend checking a genes or genetic testing is recommended to look for monogenic diabetes. So the take-home message is type 1 diabetes constitutes 5 to 10% of diabetes, secondary to insulin deficiency because of destruction of beta cells of pancreas. Classic presentation is a young children with polyuria, polydipsia, polyphagia, weight loss, abrupt onset with the DKA. And of course, we need to be aware of the new emerging issue, the profuse insulin deficiency causing hyperglycemia in patients treated with immune checkpoint inhibitors. These are the ones which are used for cancers nowadays for a better outcome. Of course, we have to remember islet cell autoantibodies, C-peptide, and genetic testing, which are very useful in the diagnosis of type 1 diabetes. This brings me to the end of my talk. Thanks again for patiently listening.
Thank you. Thank you very much, madam. It was very clear talk, and most of the diagnosis confusion. I hope there is no confusion now how to diagnose type 1 diabetes. So I would like to just ask one question to you. If you have to choose only one test, which test you will choose for the diagnosis of diabetes, type 1 diabetes?
Type 1 diabetes. First, I would go with C-peptide because that is easily available in most of the places. And islet cell autoantibodies is a specialized test, so it requires further sending it outsourcing such things. So first test I would probably do would be C-peptide. Fasting and provoke or after food also is good. And as mentioned in my slides, if the level is below 0.6 nanogram per ml or 200 picomoles per liter, then the diagnosis is more consistent with type 1 because of the beta cell failure and insulin therapy is needed at the time. So to answer your question, C-peptide, plasma C-peptide.
Okay, that's great. Another question, because I think we have some time for the next talk, so we can have a couple of questions. So in a differential diagnosis, I think we should add FCPD also, because FCPD cases also do present with the same like weight loss and classical symptoms of polyuria, polydipsia. And I think that should be added in a differential diagnosis, because sometimes these cases are also mistakenly treated or labeled as a type 1 diabetes. I do remember one case, as we have clearly mentioned, that almost 30% cases are mislabeled as a type 1 diabetes and they are treated with the insulin. I do remember one case was actually young onset type 2 diabetes, but just only because of the age, that girl was treated for almost 13 years with the insulin. An unfortunate part on her part. So when she came back to us, then we took the history, and because history taking is very important, I feel, in any type 1 diabetes or whether type 2 diabetes, before we jump into the diagnosis, the proper history taking will resolve most of the issues. So that was a very fantastic presentation, ma'am. Thank you very much.
Thank you, sir. Thank you so much for your input.
Thank you so much, sir, Dr. Reddy, sir, for your valuable time and for sharing your experience with us. Thank you so much. Moving on to next session on glucose monitoring, I would like to invite.
Thank you, Dr. Jedi.
Thank you, sir. Pleasure.
For next session, I would like to invite Dr. Amit Deshmukh. Can we see the CD slide? Dr. Amit Deshmukh is a panel consultant at Smbg Hospital, Gupta Hospital, and Shaisha Hospital, Pune. He's a general pediatrics interested in neonatology and infectious disease. Thank you, sir, for joining. And the next doctor is Dr. Rahul Jagirkar. He's a professor and pediatric endocrinologist, Bharati Vidyapit University Medical College, Pune. Even he works in the Sanjiti Hospital, Pune, Aditya Birla Hospital, then Surya Hospital, Pune. He has 25 publications in national and international journals, and he's a guide for pediatric endocrinology fellowship. Thank you, sir. Thank you for joining the session.
Nice to meet you all, doctors. You can start by introducing the session.
Now I'd like to invite Nupur Lalwani, the founder director of Blue Circle Diabetes Foundation. She is living with type 1 diabetes since last 25 years. She is certified diabetes educator. She is certified insulin pump trainer. She has run marathons and ultra marathons. Now I would like her to speak on glycemic and keto monitoring in type 1 diabetes.
People with type 1 diabetes should have an assessment of their glucose level with their healthcare professional as often
I hope everything is good in hall, the best hall. Okay. Welcome, Dr. Rahul and Dr. Amit Deshmukh.
Hello, sir.
I've heard a lot of good things. Of course, Dr. Amit Deshmukh is known to me, and I've heard a lot of good things about Dr. Rahul.
Hello everyone, I am Ms. Nikita Sarkar, diabetes educator from Shelaram Hospital, Diabetes Care and Multispeciality Pune. We'll be talking on glycemic monitoring in type 1 diabetes with Ms. Nupur Lalwani. We'll be talking on ketone monitoring. People with type 1 diabetes should have an assessment of their glucose level with their healthcare professional as often as clinically indicated, but at least annually. The agenda of my talk for glycemic monitoring is HbA1c, capillary blood glucose monitoring, and continuous glucose monitoring. Glucose in the blood is attached to the hemoglobin. Hemoglobin is a part of the red blood cells which carries oxygenated blood from the lungs to the rest of the body. The average lifespan of RBCs is about 8 to 12 weeks. Hence, HbA1c reflects the average blood glucose controlled in the previous 8 to 12 weeks. Diabetes Control Complications Trial is a landmark that provided wealth of information about HbA1c. It's correlated to the blood glucose levels and a specific treat to target A1c goals. Glycemic variability represents the glucose excursion occurring at different times of the day, which is intra-day variability, and between different days is inter-day variability. Condition causing increased red blood turnover like blood loss, hemoglobinopathies, and pregnancy. HbA1c does not reflect the average blood glucose accurately. In such cases, self-monitored blood glucose will help with a better control of plasma glucose value. Successful intensive diabetes management requires self-monitoring of glucose at least 6 times a day to identify pattern and adjust the diabetes treatment accordingly. On the left side, you can see the picture of a logbook wherein blood glucose monitored throughout a day with a handheld meter. However, even with frequent blood glucose monitor, most people with type 1 diabetes will have undetected and unacceptable high frequency of hyper and hypoglycemias. Keeping a record of a glucose values or downloading a memory capable glucometer can be helpful in observing patterns of hyper or hypoglycemia and allowing the person with diabetes to reflect on insulin dose adjustments. In the slide, we have a picture which tells in the red color triangle indicates the hyperglycemia and a green color with the normal glucose level, that is target provided to an individualized person with the diabetes. Continuous glucose monitoring uses a minimally invasive device that measures subcutaneous interstitial fluid glucose every 1 to 15 minutes. An alarm will alert the wearer to a glucose value projected to fall below or rise above the target. Newer devices have a similar accuracy to that of capillary blood glucose meters. Picture here is a showing child is wearing a continuous glucose monitor from Abbott. Also, we have a Nupur. She wears the sensor throughout to manage her lifestyle. Currently, there are 2 types of continuous glucose monitor devices available. Hospital use sensor is intermittently scan sensor, and a personal use sensors are real-time sensors. Real-time CGMs, which is beneficial in reducing the burden of hypoglycemia in older adults with type 1 diabetes. Here we have 2 pictures showing daily patterns, and a second picture reflects how many percentage a person has spent in the time above target for improving time in the target range. In the slide, we have a different continuous glucose monitoring devices. In the first picture is a Medtronic Guardian Connect sensor with a transmitter. Second picture is for Abbott sensor and a readers. On the top of that, you have a Dexcom G4 transmitter with receiver. Also, we have a Dexcom G6 transmitter receiver with a sensor. The choice of the device should be based on individualized preferences and circumstances a cost consideration can also play an important role here. By glycemic monitoring, you learn more about your diabetes and what gets the result. That's where the detective part comes in. Type 1 diabetes. A hero is an ordinary individual who finds the strength to persevere and endure in spite of overwhelming circumstances. At last, knowing your blood sugar levels help you to manage your diabetes and reduce your risk of having serious complication for now and in the future. Here, I welcome my friend Nupur Lalwani for Ketone Monitoring talk. Thank you. Over to you, Nupur.
Thank you, Nikita. That was a wonderful presentation, and I really liked the part about being a detective because I also, live with type 1 diabetes, and I often feel like a detective trying to find out what happened and why my sugars went up or down. Next slide, please. So I'm going to be talking about ketone monitoring today. And like Nikita introduced me, my name is Nupur Lalwani. I live with type 1 diabetes since the past 26 years. And I'm also a certified diabetes educator. I'm with the Blue Circle Diabetes Foundation, which is a support group for people living with diabetes. And I just want to say a quick thank you to Dr. Unnikrishnan and the whole Chelaram team for having us here and for creating these platforms for learning for everyone, including for people with diabetes. Next slide, please. So here's a quick agenda of what I'm going to be talking about. Ketone monitoring is a really important part of management of type 1 diabetes, but as we know, it's an often overlooked part. We're going to also look at the types of ketone monitoring that are available in the market. And then we're going to kind of reassess when is it necessary to check for ketones and why is it necessary to check for ketones and the fact that they can help prevent diabetes, ketoacidosis. And finally, what the difference between ketosis and ketoacidosis is. Next slide, please. Thank you. So here on the screen, the picture with the blue background is a blood ketone meter. This is actually also a reader by Abbott and is used along with the consumer version of the Libre. So the reader doubles up as not only a reader, but also a glucometer and a ketone meter, a blood ketone meter to be more specific. So the pink test strip that you see, that indicates that it's a ketone meter. The glucometer has, the glucose strips are blue in color. So what you see on the screen is the ketone value, and on the right side, you see urine ketone testing strips, which are the old school method. Now, the difference between the two is that the blood ketone meter is definitely a more accurate way to check for ketones as compared to the urine ketone meter. However, when we keep in mind the cost consideration, the blood ketone meter is works out a little bit more expensive, even running cost wise as compared to the urine ketone strips. However, that being said, it's really essential for everyone living with type 1 diabetes, all the families that have people with type 1 diabetes in them, to have at least either one of these options in their house. And in the next slide, I'll tell you why. Next slide, please. Thank you. So when should we test for ketones? The fact, like Nikita was mentioning earlier, blood testing is so important, and it really helps us find the missing puzzle. It doesn't have to be a mystery anymore, and we can be a detective that finds the missing puzzle, piece of the puzzle. So what often happens is that because we have a huge focus on blood testing, which is definitely very important, we do tend to forget the ketone testing part of things. So when to test? Three main points. One is when the blood sugar is high, when it's over 240 mg/dL. Two is during a sick day, or when the person with diabetes is not well. So whether it's a small fever or it's food poisoning or anything, that's when the body is acting differently. It's essential to keep a track on not only the blood sugars, but also the ketones. And finally, and this is, I think, a relatively new situation. If somebody is on SGLT2 inhibitors, they are automatically more at risk for euglycemic decay. In fact, in March of 2015, the FDA had issued a warning saying that, SGLT2 inhibitors are associated with decay. So it's vital that people who are on these medications need to be more mindful and check their ketones, even if their blood sugars are in range. Next slide, please. %45%. So if you're wondering what that statistic is, this data that is on the screen here is from an ADA paper back in 2017. 45% of people with type 1 diabetes from that data set reported never checking ketones when they had a fever or when they were unwell. Now, that's a huge number. It's literally half the population that is not testing for ketones. This reinforces the fact that we need to have a renewed focus on ketone testing. We need to remind the people living with type 1 diabetes that ketone testing is essential. I must mention that ketone self-monitoring as part of this study was much more common among very young children or people who were very newly diagnosed. And that, I think, is a logical outcome of how the condition is. But for adults or for people who had type 1 diabetes for a long time, this study goes to prove that they eventually don't focus as much on ketone monitoring, and that's something that gets left behind. So when the blood glucose is high, when the person is feeling nauseous or like vomiting, and when there's fever, they're not checking their ketones. And we all know what could happen in that case. That could be, if we check ketones at home, that could essentially save us a trip to the hospital or to the emergency room, where we would then have to go if we land up in diabetic ketoacidosis. Next slide, please. So my final point for today is that nutritional ketosis and diabetic ketoacidosis are two different things, and we must remember not to confuse the two. Just because we notice ketones, it is not a reason for us to panic. As people with diabetes, sometimes we have a very emotional reaction or a very panic sort of a reaction to the word ketones, and if we hear it or see it, we might get alarmed or scared. So there is no need to panic, because ketones are a byproduct of the human body. Even the non-diabetic human bodies produce ketones, so it's an absolutely normal process. So when is the point that we need to have an alarm bell, and when is the point that we need to really take some action? So this image on the right shows you when nutritional ketosis begins, and at what point do we need to really raise that alarm and do something about having high ketones and take some action so that it prevents us from going into diabetic ketoacidosis. Next slide, please. So on the screen right now are two images, and both of these images were taken around 2 to 3 minutes apart. So first, and this little experiment was done on me, by me. So the first image is when I tested my ketones with the pink color strip, and my ketones were 1.2. Now, if you see on the reader, it says high ketones. So the next logical step for me was to check my blood sugar, and on the right hand side you see the blue strip which is inserted into the Abbott reader, and my blood sugar at that point in time was 97. So if there is normal blood sugar, can you still have slightly elevated ketones? And the answer is yes. It depends on a lot of background situations. So in this case, the background was that this was my fasting reading. My previous meal was around 14 to 15 hours prior to this. I also am on low carb, and with a reading of 97, a ketone reading of 1.2 is not alarming. Nutritional ketosis and diabetic ketoacidosis being two different things. Next slide, please. So with this, I would basically like to, wrap up, and I would like to say that ketone monitoring is essential for people with type 1 diabetes, just like glycemic monitoring is important. We must remind the people living with type 1 diabetes to check their ketones as and when required, and we must assure them and give them that sort of reassurance that it's nothing to panic, and along with the right education and along with the right support, people living with type 1 diabetes can easily manage even a situation when they do have ketones and high blood sugar, and they can prevent hospitalization. Thank you so much.
I think Dr.
Rahul, sir, you're not audible.
Still not audible. I think there is some problem with the audio.
Sir, can you try disconnecting your headphones, please? Please unmute yourself. Not yet audible, sir. So try removing the earphones and speaking through the laptop speaker, laptop mic.
Is it okay now?
Yes, you're audible.
Thank you so much. Sorry for that technical glitch. Thank you, Nupur and Nikita, for a wonderful talk and covering both the aspects of glucose monitoring and ketone monitoring in type 1 management, which is the cornerstone of management. Ms. Nupur, like you rightly said, the slide of 45% was really hard hitting. And that is what we actually see in our patients who are newly diagnosed, who follow very meticulously the instructions of ketone monitoring and glucose monitoring. But in adolescents and late diagnosed type 1 diabetes, the ketone monitoring definitely goes down. In one of your slides, you had mentioned about difference between ketosis and diabetic ketoacidosis. So what would be your opinion in assessing urinary ketones in management of DK? Ms. Nupur, if you could take that question, please.
Sorry, I didn't get the question, Dr. Rahul.
So the significance of monitoring urinary ketones in patients of diabetic ketoacidosis to analyze the resolution of diabetic acidosis. So what would you recommend, urinary or the serum ketones to go about with?
So I think Ms. Nikita, you want to answer that question? Ms. Nikita? So whether to monitor urinary ketones or serum ketones, so it can be answered in two settings. One is a hospital setting,
right?
Where in our hospital, we almost exclusively do only ketones in the serum or blood.
Right.
But also in settings, I'm sure Dr. Rahul, Dr. Amit, we are all in the big cities, but also to doctors listening in smaller cities where serum ketones and plasma ketones may not be available. Nikita, I would like to suggest.
So urine ketone can be easily available in small settings where we can just ask patient or attendant that they can carry a urine ketone box home, and whenever sugars are more than 250, it can be checked easily at the urine ketone. And nowadays the Libre reader, which we are asking patients to carry, that reader can also be used as a ketone meter. So in that case also that reader will be useful.
Thank you for the answer. Just to add to that, would there be a difference in indicating the resolution of acidosis going by urinary ketones? So that was my intention of asking this question.
Yes, absolutely. So when there is excess conversion to beta hydroxybutyrate,
yes, sir.
The situation can worsen, but the ketosis may dramatically get better. in the blood, but the patient can worsen. Similarly, when beta-hydroxybutyrate gets converted to the other acetone and acetoacetate, the situation may get better and the ketosis may look worse. So there may be a discordance between the blood ketones and the urine ketones and the patient's condition. So we usually go by serum ketones. But I think, one thing I'd like to add is that the most important situation is the clinical recovery of the patient. So once the patient has started eating, walking, the dramatic recovery. In fact, during the pandemic, we had some adult patients with ketoacidosis. So these patients came with ketoacidosis because there was nobody, they stopped their insulin, maybe they had nobody to look after them, older people. They came typically with such bad acidotic breathing that they were new patients. So we thought that this must be something else. And then when we do the sugars, we found it high. They were, type 2 diabetes patients who had stopped insulin. So I think all these people, the clinical recovery is, to my mind, the best time when you start. So today evening, we have Dr. Pankaj Shah. He's from the Mayo Clinic. He's going to give a detailed lecture on diabetic ketoacidosis, the pitfalls of management. So that's coming up in the evening, I think 5:30. Thank you. Very good questions.
Thank you so much, sir.
Thank you, Ravani and Nikita Sarkar, and thank you, Dr. Amit Deshmukh and Rahul Dandura, sir. Now, moving on to, I would like to invite Dr. Rajesh Jawherani to talk on principles of continuous glucose monitoring with special reference to type 1 diabetes. He is a consultant physician and intensivist at Victor Hospital, Goa. He was an ex-consultant physician and intensivist at Chelaram Diabetes Institute, Pune. And he has various publications at national and international level. So now moving on to lecture.
Good morning, everyone. And at the outset, I would like to thank Unni sir and the team of IDS to invite me and giving me this platform to talk on principles of continuous glucose monitoring and with special reference to type 1 diabetes. Actually, right now I'm live at my parent institute, that is Chelaram Diabetes Institute, and I'm very excited about it. I'm just trying to share my slides. Are my slides seen?
Yes, yes.
Okay. So thanks, Nupur and Nikita. That was a wonderful description of use of glucose monitoring. And in fact, Nupur has been using continuous glucose monitoring for quite some time. And it's very interesting to see how she's been using it and managing her type 1 diabetes. In fact, she has a added Bluetooth on the CGM, which connects to the to her mobile. And she can continuously monitor her blood glucose levels, and especially when she has a marathon runs. So she can later on give a good insight and practical experience of use of CGM, especially in patients with type 1 diabetes. So my agenda is going to be what is CGM, principles of CGM, role of CGM in type 1 diabetes, some clinical evidence and case studies. So what's a CGM? So basically it's a device that measures glucose in real time every 5 to 15 minutes. Now, over so many years, over decades, glucose monitoring has evolved from just doing a fasting and a postprandial blood glucose levels in HbA1c and a random blood glucose to a glucose monitor with a glucometer at home. But now with the CGM, the management of diabetes has become very easy. So what does a CGM does? It provides data about trends in glucose levels. So not only just it tells you whether the glucose levels, the readings of the glucose levels, but it also tells you the trends, whether there are hypos or hypers. It also provides alarms for high and low blood glucose levels. And that's Nupur on my slide. And just to add to some diabetes humor, when curious people ask, what is this thing on your arm? She says, it's my Wi-Fi hotspot. So basically, yes, it is a hotspot which tells you your blood glucose levels. So what is the journey from Smbg to Cgm? When we use self-monitoring of blood glucose with a glucometer, you're only doing glucose values, some stat values, point of care values at certain period of time. But it does not give you a correct profile. It probably misses some of the hypos and hypers. So when you use a continuous glucose monitoring, it actually tells you the trends when the glucose levels are going up, when glucose levels are going down. So basically a lot of glucose readings which could have been missed by a traditional glucometer way of monitoring, CGM would actually be an advantage to tell you the other values of glucose which perhaps could have been missed by a glucometer. So these are some of the types of CGM. So we have two basic types. One is an intermittently scanned CGM, which is convenient to use, affordable, and it shares data. And then you have a real-time CGM. The advantage is that it transmits data continuously, like the Dexcom CGM, and now with the Libre CGM, which is also a real-time CGM. It also offers alerts of hypers and hypos, and both of them can actually share data. So all this while, we've been monitoring HbA1c to actually see the glucose trends in patients and look at the glycemic profiles. But does HbA1c tell us the whole story? Well, you can see that you may have a normal, or you may have the same HbA1c in 4 different patients, but when you actually look at the CGM, you'll find that their profiles vary. So which means CGM is just an average of the glucose values that a patient has in last 2 to 3 months, but it misses out on a lot of hypos and hypers, glycemic variability. So the utility of A1C is actually enhanced when you use a CGM as a complement to it. So when you use a CGM in patients with same HbA1c, you can actually see that the glucose profile is quite different because of their different glucose variability. So definitely CGM has an advantage over A1C in trying to understand the glycemic control of the patient's diabetes. So when we look at the CGM, it's very important to understand, analyze a CGM. In fact, it's all a learning experience that we've been doing over the last few years. And there have been some standardized metrics for clinical analysis. These are a few of the metrics that I'm going to highlight on. One is the Cgm wear time. So it's recommended at least to have a Cgm worn for 14 days to have a better analysis of the glycemic variability, which could be intraday and interday. Percentage time CGM active. That means if a patient is scanning the CGM, at least 70% of the data from 14 days should be active. That means the more the patient is trying to monitor, the better you would have a picture of his glycemic control. Then looking at the mean glucose, and then you have something called as glucose management indicator, also called a GMI. Now this term actually has replaced the term which was earlier called as estimated A1C on the analysis of the CGM data. I will tell you in another slide why is it so. And then we look at the glycemic variability, which is measured by coefficient of variation, which is calculated by standard deviation, which is divided by mean and multiplied by 100. You should have a glycemic standard coefficient of variation of less than 36% to reduce the glycemic variability. And then we have something important called as time in range. So these are some of the metrics that we analyze. Now let's look at what is glucose management indicator. So this resembles the estimated A1C. If you look at the CGM data analysis, you would find that it always highlights estimated A1C, which actually may not be what it does not actually resembles the HbA1c which you get it from the lab, because this estimated A1C is only looking at the data which is there for the last 14 days. It's a measure derived from the glucose values which is picked up from the CGM data. If you need to understand the formula, it's 3.31 plus 0.02392 into mean glucose, and that's how you get the glucose management indicator, which is also the estimated A1C. In general, each 25 milligram per deciliter increase in mean glucose corresponds to a GMI increase of 0.6%. So as your average mean glucose increases, your GMI also increases. If you have a mean glucose levels of around 200, it corresponds to an estimated A1C of 8.1%. which means that your glucose controls are not good. Then coming to time in range, this has been a very in thing now, where all of us have been talking about time in range, and it actually tells us the fantastic way of judging the glucose profile. So how to make best use of CGM is to look at time in range. What is it? It refers to the percentage of time that a person with diabetes spends within their target glucose range or above or below that target. So you may have a patient where you would want a target to be the glucose levels to be between 70 and 180. Of course, it varies between different profiles of the patient. In, for example, if you have an elderly patient where you may have a slightly higher targets, and then you look at the time below range where you look at the hypos, and then you look at the time above range, which are the hypers. So this is how you look at how many times, how much time the patient is spending his glucose values in time in range. So this is something very important. So the time in range metrics provide more actionable information than A1C alone. It includes 3 key measures, looking at the percentage of readings and time per day within target glucose range, time below target glucose range and above target glucose range. And the primary goal for effective and safe glucose control is to increase the time in range while reducing the time below range and time above range. So the more time the patient spends in range, the better is the glycemic control. So these are some of the recommended time in range targets for different diabetes population. So if you look at an average individual who's got type 1 and type 2 diabetes, you would have perhaps a target range of 70 to 180, and at least 70% of the readings throughout the day, it should be in range. And that's when you say that, okay, you would perhaps have an estimated A1C or a GMI of at least 7% or less than that. If you have a patient with a older or a high risk type 1, type 2 diabetes, you would have a time in target range of 70 to 80, but you would at least have to 50% to 70% of the values, because you don't want more hypos and more such events. In pregnancy and type 1 diabetes, in a younger individual, you would perhaps have a target range which is much more narrower, between 63 and 140, and at least more than 70% of time, you would want the glucose values to be in time in range. And again, with pregnancy and gestational and type 2 diabetes, you would have a narrow range of 63 to 140, and more the values, more than 70, 80, 90%, if the values fall in the target range, the better the outcomes. Now, how do you analyze the CGM data? We need to have a structured report approach. So whenever you have a patient coming to you in your OPD on a follow-up, and he's just come up with the CGM data, we need to analyze in a proper way. So if you go step by step, you need to look at the individual daily profiles. You need to break the CGM traces into overnight, fasting, pre-meal, post-meal phases. And finally, you need to look at the impact of other factors such as exercise, diet, and work patterns other than the insulin doses and doses of oral anti-diabetic drugs. So if you go step by step, the important is to look at the user history. Now, before we actually look at the CGM data, it's important to know how much percentage of time the CGM is active. We need to aim at least for a minimum of 70% of the time. So looking at the data of 14 days, the more the patient scans the CGM, the better you can have an analysis. We also need to analyze what kind of insulin the patient is on, multiple daily injections or insulin pump, basal and bolus doses, the amount of correction boluses that the patient has been using, the kind of physical activity, working on non-working days, and any kind of sick days, paid days with illness, or if the patient is on additional therapy like steroid treatment. So this is a very preliminary important thing before you actually start analyzing the CGM curves. And then you look at the first thing that is called as an AGP, or an ambulatory glucose profile. So this profile immediately gives you an idea of how the glucose has been aiming over the last 14 days. So we need to first focus on the time in range, where you would perhaps individualize this according from patient to patient, but generally you would have a glucose range from 70 to 180. And you need to aim for a time in range of 70%, which represents an HbA1c of 7%. You need to look at time below range, because that's again important, because that's the time when patient is spending in hypoglycemia, and also looking at the severity of the hypoglycemia. Also, time above range, we need to aim to spend less than 25%, that is 6 hours per day with glucose over more than 180 milligrams per deciliter. Now, this is how AGP looks like. So if you look at a snapshot, you need to first look at the sensor data captured on the left side of the screen. You would see that almost 93% the patient has scanned. So that means that's a good data that the patient has captured over his CGM. And then you look at the average glucose per day, which looks at about 159 milligrams per deciliter. But whereas if you look at the time in range, this person has the glucose values about 63%, where we would where an estimated A1C is about 7.2% or the GMI of 7.2%. So we need these patients to have a better glucose values in lasting in time in range. And but then not to also forget the time below range. So he has spent some events in with low blood glucose levels. But if you look at the median overnight, if you break it into phases, overnight phase, the pre-meals phase, and the fasting in the morning time, post-breakfast, post-lunch. So the median overnight has been quite fine, except there are some outliers. Overnight, the glucose values have not gone above the range. But the moment the patient has a breakfast and a lunch, the median starts climbing up, and even the outliers start climbing up. And this, you can actually look at the individual profiles to see whether how the individual profiles are matching up with the AGP snapshot. So if you look at even the daily profile, you'll find that the overnight glucose values each day have been quite fine, almost in the time in range. But the moment patient has his morning meals and his lunch, that's the time when you can find the glucose values actually going above time in range, above the target levels. So this is how you would look at and you would understand an AGP, and looking at the daily profile, you would analyze the AGP2. Without symptoms, and level 3 is a severe hypoglycemia, which denotes a cognitive impairment. But mind you, when you're trying to assess hypoglycemia on a CGM data, you need to have the readings below the threshold for at least 15 minutes because of the lag period between because you know the CGM is actually looking at the glucose values in the interstitial fluid. So what you look at the values is perhaps 5 to 15 minutes what it must have been in the blood. So you need to have at least these readings over 15 minutes to say that, yes, there is a hypoglycemia. So to summarize the key AGP points, we need to reinforce the key messages from the CGM data. That means looking at the time below range, looking at hypoglycemia, we need to prioritize minimizing hypoglycemia. That's important, not just trying to look at the time in range and the target range, and then focus on time above range. And of course, look at the variability. It could be an inter-day or intra-day variability, where you would try to manage by looking at the carb counting, the meal boluses, the exercise, and the stress. And then you probably need to avoid initiating change without clear patterns. That means not just by looking at some of the daily profiles, you would come to some kind of a decision making. You need to have more and more data to have initiating some kind of change in the treatment by looking at more and more data from the daily profiles and the AGP. So let's look at the principles to be followed for safe CGM use. Now we know that CGM is looking at the glucose values in the interstitial fluid. So are we ready to manage the therapy? Could be diet, could be the insulin therapy, or if in a patient of type 2 diabetes, the doses of the type 2, the doses of the oral anti-diabetic drugs, but just by looking at the CGM use. So we need to have certain principles to be followed for a safe use. So if you are having a CGM where you're using as a non-adjunctive CGM, which means you are not calibrating with a glucometer, or you're not trying to confirm some of the values with the glucometer, or you're just trying to look at the CGM values and adjusting the therapy. So some of the guidelines to be followed if you're using a non-adjunctive CGM use, definitely if possible, you need to calibrate the CGM. Of course, the latest real-time CGMs are factory calibrated, but as and when possible, you need to confirm at least twice a day, thrice a day with your glucometer reading, so you know how much the difference is in between your CGM readings and your glucometer readings. The CGM systems are generally somehow less accurate with higher MARDs, that is the mean differences in the sensor glucose values and the glucometer values. And generally on the first day of sensor insertion, you will have less accurate, and probably by the second and third day, the glucose values are much more accurate. There may be some amount of interference by some drugs, and the common drugs in children, especially who are type 1 diabetes, they commonly use acetaminophen for normal cough, cold, fever, which may cause falsely high CGM glucose values. And some of the interesting things are, suppose if the patient is sleeping in the night time and there is a pressure on the sensor if he's sleeping on that particular arm, and it may cause a compression effect leading to a false hypoglycemic alarm. So one need to also look at some of these things to be and then make an analysis about from the CGM. When you're looking at the CGM, if you have a Dexcom use or even a Libre real-time glucose monitoring system, always look for directional arrows for treating high and low glucose values. Now, why is it so important? So suppose if you have a patient whose stat glucose values, which is seen on your CGM, is showing 202 milligrams per deciliter, and your arrows are actually showing down, you may perhaps avoid using a correction boluses. Because if your arrow is going down, that means in the coming minutes, your perhaps glucose values are going to go down. And if you correct this glucose values with a correction bolus of insulin, you would perhaps end up with a hypoglycemia. But instead, if you find that the arrow is going up, then you know that in the coming minutes or coming time, your glucose is actually going to climb up. And that may perhaps let you correct this glucose values with a correction bolus. So looking these directional arrows is actually helps us to give insulin therapy. So the rate of change of glucose may be as important as is the actual glucose value in determining the optimal treatment. Now, as I said, because the CGM is looking at the lag time needs to be considered. We need to consider lag time when you have actually a rapidly falling glucose values. So suppose if your glucose hypoglycemia has been actually quite rapid, there you may perhaps the lag time may cause problems there. Or suppose you have a patient with hypoglycemia and you are rapidly correcting with a probably injectable dextrose or a high carbohydrate simple sugar, there the lag time needs to be considered. So where you need to always confirm with the blood glucose values. Now, when you are using a non-adjunctive CGM use, that means you're not using a glucometer to monitor your glucose, you're just probably relying only on the CGM values, you may perhaps end up using repetitive doses of correction insulin, and that may lead to insulin stacking and an increased risk of hypoglycemia. So whenever you have the glucose values rising, one way to look at it is to look at the arrows where it will tell you perhaps whether in coming time the glucose values are going to go up. There you could perhaps use a correction insulin bolus, but otherwise you would perhaps end up having a risk of hypoglycemia. So you need to perhaps confirm with a glucometer before you try using a correction bolus of insulin. Let's look at the non-adjunctive consideration in pediatrics. Again, remember the CGM use is being done by the patients themselves, the parents or the children themselves. So definitely this education of parents and the patients is very important, and the guidelines to be given them properly so that they could guide the insulin doses according to the CGM data. And the general guidelines are that to at least calibrate the CGM data along with the glucometer twice daily, and to look at the use of acetaminophen, which can falsely elevate CGM value. If you have a meal-based correction boluses, you need to have the CGM value in the range of 80 to 250. If Cgm values are less than 80 or more than 250, you need to confirm with a finger prick blood glucose values. So these are some of the guidelines that have been recommended by some bodies, but definitely in your own clinical practice, you could develop your own guidelines. Before I go to clinical studies, one more case that I would like to say that I was back in Goa, I was treating a type 1 diabetes patient. That patient came with diabetic ketoacidosis, and I ended up using a continuous glucose monitoring for that patient. And I was trying to titrate the insulin doses. And this patient, even on the 4th day or 5th day or 6th day, the ketone bodies were still positive. And I thought, and I remember speaking to Uni sir, and then we thought whether we are dealing with whether we're using a lot of saline, so it is perhaps hyperchloride acidosis. But then we realized that perhaps because we were ending up giving less doses of insulin, and that's when the ketone bodies were not getting corrected, acidosis were not getting corrected. And we started measuring the glucose values with a glucometer. So perhaps in patients who have DK, definitely, or patients in intensive care unit, one has to be very watchful when you're using a CGM to monitor the glucose values. So let's look at some clinical studies. So these all real world studies show that definitely the more you scan a CGM, the more better is the control of HbA1c. So this is a study which is done in type 1 and type 2 diabetes patient, which shows the relationship between the scan rate and the time in range. And the objective was to investigate the relationship of scanning frequency to glucose metrics. And what we found was that as the scan rate increased from lowest to highest scan groups, the estimated A1C decreased from 8.2% to 6.7%. And also the time in range increased by 43%. So which means that the more the patient is scanning, the more the increased frequency of scanning, it is associated with improvements in glycemic measures, including decreased mean glucose and improved time in range. One more study called the IMPACT study, which is a multi-center randomized control study showing increase in time in range and the hypoglycemia and type 1 diabetes. And this was a study which compared the freestyle Libre versus an Smbg in reducing hypoglycemia in patients with type 1 diabetes. And if you look at the analysis data, they found that there was an increase in time in range. So every 5% increase in time in range was associated with clinically significant benefits, the less chances of hypoglycemia, the better A1C control. So definitely, the more the patient used the CGM, the freestyle Libre CGM system, which increased the time in range versus Smbg in well-controlled type 1 diabetes. Let's look at the two cases. These are just cases who have come to us after using their CGM for a follow-up. So this is a Master X who's a 16 years old type 1 diabetes on basal bolus insulin. And this is a snapshot where you look at first the sensor data, which is captured, which is about 91%. So anything above 90% is a good data that has been captured by the patient. Then you look at the average glucose, which is about 159, which resembles to the estimated A1C or a GMI of 7.2%. And if you look at the time percentage in target, which is between 70 and 180, it is about 66%. And time below target is about 2%, which is acceptable, with an average duration of 131 minutes, which were the low glucose events, which are about 4. And time above range was about 32%. If you look at the median fairly falls in time in range, I mean the target range. There are some some days where, or we call it as outliers, where the glucose values have fallen out of range on some days. So you need to look at the daily profiles to analyze the AGP. And you look at the daily profiles, on quite a lot of days, the sugar values are okay. But at some days, of course, the outliers days, you will find that there is a lot of days with hyperglycemias. And where you see the red line, that's the days with hypoglycemia. So definitely you should always add on to the daily glucose profiles when you are trying to analyze the AGP. And thereby you could perhaps adjust the doses of basal and bolus insulin to have a better glucose profile. This is another patient, 20 years, type 1 diabetes for a follow-up. Again, you look at the snapshot, you'll find that more than 95% of the data has been captured. And here, if you find that the time in range in target is about 59%, that is low, with an estimated A1C of 7.3%. The average glucose values falling to about 163. There have been quite amount of hypoglycemic events and almost about ranging to 10, and the time below target has been 6%. Now, if you look at the sub-analysis, now on my right is the screen, you can see these are the days and the number of scans that the patient has done. So you can see the average glucose values on that particular day, which is about 144, 147, 154, and the amount of time, number of times the patient has scanned. So that is about 13 times, 17 times, and so on. So this is another number of days where you can find even the hypoglycemic events, which is marked with red, and the mean glucose values. So this is how you get a CGM data, and that is how you start analyzing. And as I said, if you want to have some kind of a change in the insulin doses or change in the diet and the carbs that the patient has been consuming, you need to have more and more data to analyze that. And so this is how you go ahead about looking at the CGMs of patient coming to you. So these are the daily profiles of the same patient. You'll find that there have been instances which is marked with red. Those are the hypos. And there's been a lot of glycemic variability, a lot of fluctuations throughout the day, which is called as inter-day variability. So to summarize, CGM has revolutionized the management of diabetes. Use of CGM has to be encouraged for better glycemic monitoring. So definitely to add on to the glucometer values, you need to have a look at the CGM data also for a better glycemic monitoring. You need proper education for using the data the right way. Now, this is very important. The education for a treating physician as well as the patient who's using the CGM at home, and the relatives or the parents of the patient who would have a proper education on using the data and trying to make any kind of amendments or changes in the insulin doses. Time in range has become a better metric to understand glucose control. It is looking at the daily profiles of the patient, and the more the glucose values fall, time in range, the better is the outcome. So definitely if you compare with HbA1c, the TIR is a better metric to analyze the glucose profile. And definitely use of CGM has led to better glucose control outcomes, where the clinical studies have showed up that if a patient is using a CGM on top of a glucometer, the HbA1c values are much better. The incidences of hypoglycemias are much better. And this helps to prevent the microvascular and the macrovascular complications in patients with both type 1 and type 2 diabetes. So with that, I would like to thank you all for a patient listening, and I'm open for discussion. Thank you so much.
That was a very wonderful talk, Dr. Rajesh. You very aptly covered the basics of CGM and the practical use of that in day-to-day practice. There was one question which was asked by Dr. Vasanti, and she wants to know what is the normal range of what is the normal range in CGM monitoring. I take it that she wants to know the glucose levels.
So normal range, so the target range, as I said, should be maintained between 70 and 180. Now, it all depends on the patient profile. If it's an elderly patient with gestational diabetes, or patient with type 1 diabetes with pregnancy, so there you would perhaps have a narrow range where you would keep it between maybe 60 to 140. And the more the patient spends the time in that range, the better is the outcome. So that's how you try to keep the glucose values in range in a CGM data.
Rahul, do you have any other questions? Dr. Amit?
Yeah, so I would like to thank Dr. Rajesh for a very wonderful presentation, and take-home messages were very good. I have a question. I would like to ask, nowadays some of my patients are using the GLIMP software with the Freestyle Libre Pro to calibrate it. I want to know, is the GLIMP software as accurate as the Freestyle Libre Pro, and has it any further advantages?
I think Nupur, she has used GLIMP app a lot, during her screen. I mean, while trying to analyze the glucose. If Nupur is there online, maybe she can throw a light on it.
Good morning. Thank you, Dr. Rajesh, for that wonderful talk. Yes, I do find GLIMP to be a slightly more accurate for the reason that it can be calibrated. So on the top right of the screen on GLIMP, there's a plus button wherein one can put in the glucometer value, which is not currently possible with the reader. So for this, I find it a little bit more accurate. Thank you.
Okay. Thank you.
So thank you so much, Dr. Rajesh. It was excellent presentation, and thank you, chairpersons, Dr. Amit as well as Dr. Rahul. Now to start the next session, I hand over mic to Dr. Shweta.
For the next session, the topic is on insulin therapy, for which we have someone who has been polishing carbons like me into the field of medicine, and she's been showering us with the pearls of her wisdom since over a time, and guiding us to become a better doctor. My mentor, Dr. Smbg Kanetkar, she is a professor and HOD at the Department of Medicine at P.Y. Patel Medical College. She is a unit in charge in medicine unit and geriatric OPD, and she has many publications, various national and international in journals. So, and I would also like to invite Dr. Rajesh, who is the consultant physician and intensivist at Victor Hospital, Goa. He is an ex-consultant physician and intensivist at our Chalaram Diabetes Institute, and he has published original research on Cgm during hemodialysis. So I would like to welcome Ma'am Smbg Kanetkar, Ma'am, and Dr. Rajesh.
So, yeah. Thank you for the introduction. Can we move ahead with the sessions?
Yes, ma'am.
Yeah.
So I would like to invite Dr. Shehla Sheikh. She is a DM endocrinologist. She is working as a consulting endocrinologist in many reputed hospitals in Mumbai. I would like her to invite to talk on basal insulin therapy in type 1 diabetes. So welcome, Dr. Shehla.
Thanks a million. First of all, good morning to each and every one of you all out there. And it gives me great pleasure to be a part of this meeting, an absolute pleasure being over here. I would also like to personally thank Unni for making me a part of this prestigious event. It's always a pleasure being over here. Today, the topic which has been assigned to me is actually a very, very, I would say, interesting topic. And the reason I'm saying very, very interesting topic is because conventionally, when we talk about diabetes, we always think more in terms of type 2 diabetes. When we're talking about initiation of therapy, we talk in terms of basal insulin. Most of our guidelines, most of our thought processes are geared towards type 2 diabetes. But we all know that when we are actually looking after our type 1 diabetics, we need a key change in our thought process. And the reason we need a key change in our thought process is because we know that type 1 diabetes actually implies a complete destruction of the pancreatic beta cells. And when we are looking at a complete destruction of the pancreatic beta cells, which we conventionally thought was occurring more in children and adolescents, but what we are now realizing that it can occur at any age, especially now post the COVID pandemic, we know that we are seeing a much higher incidence of type 1 diabetes. I think we all need to sit together and try to understand from each other how we need to manage our type 1 diabetic patients better. When these patients come to us at a younger age, they may come to us directly with decay. They come to us with a classical picture of decay, which I'm sure everybody over here is familiar with, because there's a rapid rate of beta cell destruction. But interestingly and increasingly, we are also seeing a number of adults coming to us with type 1 diabetes, but without the classical ketoacidosis presentation. These patients may have sufficient insulin secretion to prevent ketoacidosis for many years, but at the same time, these patients are slowly evolving type 1 diabetes. Another very interesting segment which we are now seeing is, for example, if you have a patient with type 1 diabetes, and you evaluate the relatives, you evaluate maybe a sibling, you evaluate maybe a twin, and you realize that these patients have antibodies. And especially if these patients have 2 antibodies, where there's a high risk of this patient subsequently developing type 1 diabetes and is in constant surveillance, you may pick up hyperglycemia much earlier than what you would do in a patient with conventional type 1 diabetes. Our thought process is geared to thinking about type 1 diabetes and decay. But we need to move away from that and keep our index of suspicion much higher when we are now thinking in terms of our type 1 diabetic patients. My purview today is going to be about talking about basal insulin in type 1 diabetic patients. When you talk about basal insulin, you know that basal insulin is actually the insulin which is required to restrain release of glucose from the liver, and free fatty acids from the adipose tissue, so that you do not have hyperglycemia and ketosis. So it is the insulin which is going to act basically in between your meals and overnight, so that you do not have any kind of hyperglycemia. What is very, very important, and we all know the biggest problem when we are treating our patients with diabetes is the issue of hypoglycemia. So we need a basal insulin which will not only prevent hyperglycemia, but will also minimize that risk, continuous risk of hypoglycemia. In type 1 diabetes patients, friends, we all need to understand a very important thing, that basal insulin can never be used in isolation. It is always going to be used with prandial insulin. So basal insulin is going to take care of your interprandial and your overnight insulin requirements, and your bolus insulin is going to take care of your meal requirements of the calories which are accrued by the patient during the meals. At this point of time, we do have a choice. When we were residents, or when we were maybe 10 years back, we did not have a choice where, as far as basal insulin was concerned. All of us uniformly continued using Nph, but we know the last decade has changed the entire scenario of basal insulin. And now you do have a choice. This choice could vary according to the situation. It could vary according to what is the patient's preferences. Of course, when your patient is paying from the pocket and it's a lifelong disease, cost makes a very, very important influence on that decision. The PK/PD profile of the insulin makes a very big difference. And most importantly, your patient's lifestyle does decide a lot of things when you decide which basal insulin to initiate. Now, what is the ideal basal insulin? What kind of insulin would I really want? I would, of course, want something which gives me great efficacy, great predictability, no side effect, and very, very simple to use, something which is almost like a cakewalk, sounds like a dream come true. Now, when I look at an ideal PK/PD profile, what am I looking at? I'm looking at a practically peakless insulin. My insulin should be absolutely flat. Definitely very, very minimal variability. Truly, which acts for more than 24 hours, because we know I will further talk about the issues that we've been having with what we've been using and try to understand where we are going. And of course, efficacy is something which is of paramount importance. Now, this has been our journey as far as basal insulins go. When you look at it, where it all started, we all know this. Last year, we celebrated 100 years of insulin. Nph insulin is as old as actually almost like a pre-independence insulin from 1946. And the basic method to prolong the insulin action was addition of a basic protein, that is Nph. Subsequently, 2 decades back, we had insulin glargine. The basic principle of increasing the insulin action in insulin glargine was where you reduce the solubility at a physiological pH, and that prolongs the action of insulin. Subsequently, 2005, we had insulin detamide, but again, because insulin detamide, I will talk about, had a shorter duration of action, most of us did not take it up in a very, very big way. 2013 led to acylation of insulin and insulin degludec, detamide, and icodec, which is the once-weekly insulin. And in 2015, we had the more concentrated form of insulin glargine, that is U300. So we, at this point of time, do have a number of molecules that you and me can use according to, as I said, a clinician judgment and a patient's preference. Now, though, and I would say in a certain segment of population, we do not use Nph insulin, we need to remember that in our population with the increased incidence of type 1 diabetes and cost constraints, we should know about Nph insulin, because almost, even at this point of time, almost 30% of my type 1 diabetes, because of cost constraints, in spite of us adopting patients trying to provide insulin, it is often not available in the interiors, in rural areas. They do use Nph insulin. And then when they are using Nph insulin for a variety of reasons, we need to see to it that we understand enough about Nph insulin to be able to use it successfully in our patients where it is required. Now, this insulin basically is a suspension. When it is a suspension of insulin, protamine, and zinc, what clinical information it gives us is that it should be mixed before injection. So when you are using this injection, apart from using it at room temperature, very important that you mix it before you use it. This is something we should not forget. In view of its half-life, which I will get to in a few minutes, it needs to be administered at least twice daily. Now, when you are giving it twice daily, we need to understand when the peak action of it is at 4 to 6 hours. For example, if you give it at 8 a.m. in the morning, its peak action is going to be around 12 to 1. If at this point of time we do not consume food, there's an increased risk of hypoglycemia. I use it to my advantage in children. For example, if you're using it at 8 a.m. in the morning, at 12 noon, we sometimes miss the short-acting insulin, the bolus insulin, if Nph insulin is covering that meal. So we just give a meal instead of giving a bolus insulin before lunch. So you can tweak the usage of Nph insulin according to your requirements. If you are giving Nph insulin, and you have to give Nph insulin twice a day because it does not cover your patient for 24 hours, when you give it in the evening, we prefer giving it with a relatively early dinner so that your patient can have a bedtime snack, again, subsequently around 4 hours down the line, so that you do not have any kind of nocturnal hypoglycemia. Because the biggest issue with Nph insulin, more than efficacy, has been the issue of hypoglycemia, friends, which we definitely do not want in our patients. One area where Nph insulin we've used a lot in the last 2 years has been on patients who have been added on steroids. So because the action of Nph insulin very closely matches the onset of action of prednisolone, it is one area where Nph insulin was used very, very extensively, especially on an OPD basis in patients where steroids were initiated. So as I said, the basic challenges which we faced with Nph insulin was insufficient basal insulin coverage. We needed multiple injections, need for resuspension, and of course, a significant day-to-day variability. And these issues led to the first generation of long-acting insulins, that is insulin glargine. We all know that insulin glargine precipitates in the tissue, forms hexamers, and as a result, absorption is delayed and there's a prolonged action. You would wonder why we've never had pre-mixed insulin glargine in any form. The reason we cannot have pre-mixed insulin glargine in any form is because it is acidic. And because it is acidic, it cannot be mixed with rapid-acting insulin, and because the kinetics of the glargine and rapid-acting insulin will be altered. And that's the reason insulin glargine has always been only a basal insulin, friends. Though it has no appreciable peak, per se, if you look at the PKPD profile, it has no peak. But even then, there is greater glucose lowering effect in the first 12 hours than the subsequent 12 hours. Yes, definitely less nocturnal hypoglycemia. There is no questioning that. Because the duration of action is usually 24 hours, and that's why we can give it once a day. But in our type 1 diabetic patients, we've also noticed, because the half-life is 12 hours, you may actually almost in, I would say, 25 to 30% of patients need twice daily dosing. So if you have a patient, for example, you are using this insulin at bedtime, or you may be using this insulin, say, at 10 or 9 or 10 p.m. in the night, because when you're using insulin glargine 100, you cannot afford to change the timing. So if you're using it at a particular time and you realize that next day, by the time, for example, when you check the sugars before the next injection, your patient is invariably in hyperglycemia, you realize that actually the dose which you're giving is not giving you true 24-hour coverage. And in these patients, we do use twice daily insulin glargine also. So a lot of individual titration, a lot of individualization goes when you are using basal insulins, even in situations where you think that, no, this is a 24-hour insulin and I really don't have an issue over here. There are two situations which can lead to pre-insulin glargine hyperglycemia. A, if your insulin glargine is truly not acting for 24 hours. B, we often see situations, for example, the patient has taken insulin pre-dinner, your bolus insulin has been the short-acting insulin taken pre-dinner, and actually when you're giving your insulin glargine may coincide with 2 to 2.5 hours post-dinner, and that may be the time when you're checking the blood sugars, and you realize that at that point of time, the patient is actually having hyperglycemia. A, maybe the basal insulin glargine is not acting till there. Or B, you should be checking these patients you may have to recheck these patients pre-prandial insulin requirements, look again at carbohydrate counting, look again at the insulin sensitivity index, recheck the requirement for that meal, because it may be actually the bolus dose which may be inadequate, and as a result of which you are thinking that it is actually a pre-glargine dose which is inadequate. So whenever we are, as I said, whenever we are looking at situations, we need to look at them very, very critically, understand things more in detail, look at sugar points over the last few days, and then make treatment decisions as to what you think could potentially be wrong with your patient. Because what you may end up doing is actually increasing the glargine when that does not require to be increased, and potentially creating nocturnal hypoglycemia when it is actually the pre-prandial bolus dose, that is the pre-dinner bolus dose that needs to be increased. And that is a very important message that I want to give across over here. Insulin detamine, we all know, again, an acylated insulin. There is again a noticeable peak, but you need to give twice daily injections to be able to give good basal rate coverage and optimal glycemic control. Higher doses are associated with a longer duration of action, but it rarely lasts more than 24 hours. So when you look at the long-acting insulin, that is the glargine 300 and detamide, which you and me have been using over the last 2 decades, compared to Nph insulin, what kind of advantages do you get? As far as HbA1c is concerned, mind you, there is still a lot of variable data. And the reason I'm saying variable data, because some meta-analysis show that, with some amount of criticism, show that yes, there is an improvement as far as A1C levels go. And some trials show that no, there is no real improvement as far as A1C goes. So that is an area where we are still a little unsure about how much of improvement of A1C is actually seen. But what we are definitely very sure about is less weight gain, definitely, decreased glucose variability, 100%, and most importantly, decreased episodes of hypoglycemia. Hypoglycemia has always been the limiting factor as far as management of our type 1 diabetes goes. Everybody who manages type 1 diabetes knows this very, very well. One of the limiting factor, the patient, it becomes a very, very important limiting factor for the patient, because the patient gets more and more worried. And we all know that hypoglycemia begets hypoglycemia, and we all worry about hypoglycemia unawareness at all points of time. But most of this comparative data was not CGM based. CGM has been very recently started being used in clinical trials. We now are starting to have trials where we're using CGM data, and we are now starting to look at trials where you have much more inclusive data. But at a point of time when we were comparing glargine or detamide with Nph insulin, we do not have CGM data. So we really are not very, very sure about how much of reduction of hypoglycemia was occurring. But yes, definite data which shows that there was reduction of hypoglycemia. So what was the issue? I mean, do we have an issue with first generation analogs? We do. We do. because in spite of all the advantages, as I said, they may not be truly once daily. They are not truly peakless. Nocturnal hypoglycemia keeps on worrying you and me. The dose timing was very fixed. You are dealing with adolescents, you're dealing with children, you're dealing with young adults. And these patients do not like that absolute constraints of time that, oh my God, I have to take my insulin. And of course, the variability involved with this insulin. So in spite of progress, we were still not there. We were still not where we wanted to be. And that's where you would realize glargine U300 does have some benefits. It's a higher concentrated version of glargine U100. We all know precipitates after subcut injection 3 times but larger than glargine U100. And we have insulin degludec, which are actually hexamers, albumin binding. These are the molecular structures of these two molecules, which I won't go into great detail over here. But yes, what you realize is when you look at insulin degludec, the advantage it gives me as a clinician is mainly the long duration of action. And when it gives me a long duration of action, it gives me a certain flexibility. And this flexibility is very important for me when I'm treating the children with type 1 diabetes, when I'm treating the adolescents with type 1 diabetes, because they know that they can use this insulin with that flexible window in mind. Another very big advantage of insulin degludec has been that, yes, you can combine it with rapid acting insulins. We do have co-formulations. And we do use these co-formulations intelligently in our type 1 diabetic patients also. If you think that potentially you can maybe reduce one insulin, especially if one meal of theirs is relatively simple and relatively easier to replicate from day to day, and it results in the same amount of increase in the postprandial blood sugar levels. So with close monitoring, we have been able to, in some patients, use this for one of the major meals along with, because we all know the combination will have a short-acting aspart along with the long-acting degludec. As far as our type 1 diabetic patients go, we all know they need bolus doses with each meal. And we all know that the number of injections do make them very, very, it's like very, very demotivating when they have to take so many injections. So if we can potentially maybe tweak a little and manage with this, it does help our patients. Steady state insulin concentrations are attained in 3 to 5 days, friends, and you would monitor accordingly. So in a nutshell, this is what I have. I have my Nph insulin with a peak of 4 to 6 hours and a duration of action of 12 hours. So I need to give it every 12 hourly. I have my U100 with a half-life of 12 hours and approximate duration of action of 20 to 24 hours. If you on evaluation realize that the duration of action is not lasting for 24 hours, you would use it twice a day. U300, a more concentrated form of U100, which again has an approximate duration of action of 20 to 24 hours. You can use it with a 3 hours window period. Insulin Determinants, a half-life of 5 to 7 hours with an approximate duration of action of 6 to 24 hours. And insulin degludec with a half-life of 25 hours and approximate duration of more than 24 hours. When we are working in clinical practice, we need to know this absolutely, because it is on the basis of this that you are going to decide which insulin, how you would use it, where you would use it in your patients of type 1 diabetes. Insulin icodec, to be honest, we are involved in trials with insulin icodec. Very, very fascinating. And I am really looking forward to this insulin being marketed, to be very honest, because it reduces my patients' injections from 7 to 1 per week. And that does make a difference to the quality of life of my patient. When the patient is taking only one basal, maybe on every Sunday of the week, it does create a lot of happiness for a patient. The quality of life of the patient definitely does make a difference. As far as data goes at this point of time, the reduction in A1C was similar in both the groups when they were comparing it with U100. This was to 47 patients, of course, type 2 diabetic patients, but I just put it up here for us to realize that, yes, we have insulin icodec around the corner. Hopefully by this year end, we should have it available if everything goes on track. Mild and clinically important hypoglycemia was more common in the ICODEC group, but did not reach statistical significance. Now, friends, coming to some practical usage about how you would incorporate basal insulin in your patients, how you would start basal insulin in your type 1 diabetic patients, how would you titrate basal insulin in your type 1 diabetic patients, and how would you take it up further as your patients progress in their journey of diabetes. We all know a huge number of our patients come to us in DKA. Now, once the DKA is resolved and the patient is absolutely stable, you would then plan to shift this patient to subcute insulin. A very important point that I want to put across over here is please remember that start the basal insulin at least 2 to 4 hours before you stop the IV insulin drip so that you do not face that rebound hyperglycemia. You often have your resident ringing you up saying, ma'am, we stopped the drip. You told us to stop the drip. We stopped the drip. And now the patient's next sugar has gone up to 350 or some odd number like that. And the relatives panic, ma'am, the sugar was 100 in the morning. It's become 300 again. What is happening? We cannot afford to forget this golden rule that you need to overlap your basal insulin with your IV insulin, especially if the patient has been NBM for the past 24 hours and you are deducting the insulin requirement from those 24 hours and you are gradually shifting the patient to oral diet. There are some studies that show that if you start actually a glargine regimen, once the patient has stabilized within 12 hours of the IV insulin initiation at a dose of 0.25, you may still further contribute to reduction in rebound hyperglycemia. But I still feel that this should be done only when the patient is absolutely stable, not at all when the patient is unstable. Now, what dose would you give? What subcute dose? You decided you want to switch the patient to subcute basal. What dose are you going to use? You are going to use 80% of the dose of the IV dose, which was used in the past 24 hours for your patient as far as IV insulin goes. Of course, when you're using this, be careful about hypoglycemia. If you're using insulin glargine or insulin degludec, you're using 80% of the dose as a single dose, that's fine. If you're using NPH, then that basal dose you divide into half, use 50% in the morning and 50% 12 hours later. As I said, if you're using NPH, you may not require rapid-acting insulin pre-lunch. So be careful, be very, very particular about hypoglycemia. Monitor your patient closely. Monitoring is going to be the key of you making this very smooth and successful switch from IV to subcute insulin so that it is a very smooth journey for both you as a clinician and your patient. The other way of actually understanding the doses when you decide to start oral intake for your patient, or when you decide, or if your patient actually has not come to you in DK and has just come to you with severe hyperglycemia and maybe just ketosis, your daily insulin requirement can be calculated on the basis of this formula where you use 0.55 into total weight in kgs. Whatever number you get after this multiplication, 40 to 50% of that dose would be your basal dose, and the rest 40 to 50% would be your bolus dose when you are using a long-acting insulin like glargine along with your insulin, short-acting insulin or insulin analog. At the other end of the spectrum, friends, if you're using NPH, then you would divide as 1/3, 1/3, 1/3 and adjust accordingly. The reason I said a dynamic process because we need to keep our index of suspicion very high as far as hypoglycemia goes. We need to understand that there is going to be a lot of individual insulin sensitivity. A patient may have a higher dose requirement in the morning and a much lower dose requirement in the evening or midday because the sensitivity is different. Your requirements may differ according to whether for example, the patient came to you with an infection and as the infection resolves, your insulin requirements may go down. So you need to be aware that you need to up titrate or down titrate the dose according to your glucose measurements. And how would you titrate basal insulin? Every second to third day for insulin glargine, we would do it very rapidly in our hospital setups. My residents will be absolutely hyperactive and they would want to change the insulin glargine dose every day. Ma'am, not doing well, let's increase. Ma'am, not doing well, let's increase. But we need to understand that you need to titrate every 2 to 3 days for glargine and detamine, and every 3 to 4 days in case of patients who are on insulin degludec and insulin glargine 300, so that you actually minimize the risk of hypoglycemia, friends. As I said, insulin glargine 300 can be injected 3 hours before or after regular insulin dosing time, and insulin degludec can be dosed at an interval of 8 to 40 hours. And most importantly, a very, very important point which I want to bring across over here is that we also need to take into account the circadian rhythm, because you would realize that when you give glargine in the morning, the activity is more from 0 to 12 hours, and evening the activity is greater from 12 to 24 hours. So these finer nuances of basal insulin usage should be kept in mind when you are using it in your patients. As I said, one of the biggest issues when you're using insulin is hypoglycemia, including basal insulin. And poor hypoglycemic awareness becomes a very, very common problem with the longer duration of type 1 diabetes. You need to look out for it. You need to be aware of it. You need to screen it. And over here, there's a simple rule of 15, which I'm sure everybody knows when you're treating hypoglycemia, which I won't go into details in the interest of time, but this is what you would do when you are treating hypoglycemia. A very interesting problem you often face in your patients when they are on basal insulin is also fasting hypoglycemia, which we have always called the dawn phenomenon. But we need to understand that sometimes when you're looking at the dawn phenomenon, you need to again have a closer look at glucose profiles from at least the last 3 to 4 hours after the last meal, that is dinner. Sometimes patients get up in the middle of the night because they may not be actually having a dawn, they may be having a Smbg, they snack, and you realize that you're having a fasting hypoglycemia. Or it could be that the nighttime snacking or the evening snacking, we are not covering sufficiently with rapid-acting insulin, and again, that is causing a fasting hypoglycemia. We need to take cognizance about all these different factors which can influence your fasting blood sugar levels. Monitor your patients, monitor them overnight, monitor them with whichever means you have to be able to make the right kind of decision as far as your patient is concerned. One of the common problems which we have with our basal insulins can also be weight gain. My type 1 diabetic patients are the smartest patients in the world. My adolescent type 1 diabetic patients are, mind you, still smarter. And I have realized that when they want to lose weight, that party where it's very important to look for your weight to be lost, that wedding where it's very important that I fit into a particular dress, my patients simply become non-compliant. And the moment I see that kind of weight loss, I know adherence is a problem. Yes, with newer insulin analogs, this is much lesser, but we need to keep these fine points in mind when talking to our patients to understand what is the thought process, because when you are treating your type 1 diabetic patients, we need to be aware of their mental health also, because we need to be aware that these are adults, these are adolescents going through a lot of pressure when they are dealing with the insulin requirements, with daily testing, with daily dosing. And we definitely need to be empathetic, make them independent, make them understand that this is not limiting, but at the same time, give close attention to these small pointers which could tell you potentially that, yes, there could be an issue somewhere around there as far as the patient's control goes. Blood sugar monitoring, we all know, before meals, bedtime, additional if hypoglycemia. CGM is been a boon in some ways, especially in a type 1 diabetic patients, young patients increasingly are using CGMs with readers, but it also leads to a lot of over-basalization. I've also realized when they look at trends, they adjusted themselves, they're taking a lot of correction doses also on their own, and they're also resulting in a lot of hypoglycemia also. So we need to also teach them how to use the CGM data intelligently. The last 2 or 3 minutes, I'll just go to quickly run through some slides which talk about some of the actual data which we have as far as basal insulin goes in type 1 diabetes. Only 1 or 2 studies which I'll go through. This was the switch 1, in which we know that these were patients of type 1 diabetes, around 501 patients who were on either degludec or glargine along with aspart, and then was switched at 16 weeks to the other insulin, be it degludec or glargine. What is very, very interesting in this study is that as far as hyperglycemia goes, as far as attainment of HbA1c goals go, they match more or less. Where actually degludec makes a difference is as far as hypoglycemia goes. As far as hypoglycemia goes, you would realize, especially nocturnal hypoglycemia, there is almost a 36% lower rate with degludec, and also with severe hypoglycemia, 35% lower rate with degludec. So that limiting factor, which I spoke to you about, friends, as far as management of our type 1 diabetic patients is taken care of to some extent by our ultra long-acting basal insulins at this point of time, including if you look at the hypodec trial, which is a Danish trial, again, treatment with insulin degludec resulted in significantly lower all-day CV primary driven, mind you, by nocturnal CV. Now, as I said, if you look at the reduced frequency in nocturnal hypoglycemia, this happens also in patients with previously recurrent hypoglycemic episodes, which are patients with the most, where you really get worried about hypoglycemia episodes, because we all know hypoglycemia begets more hypoglycemia. This is again the Young 1 study, which shows that not only did IDEC give you a long-term glycemic control, which was equivalent with similar rates of hypoglycemia, but most importantly, hyperglycemia was also significantly reduced. What I love about IDEC is the fact that it gives me flexibility. And if I summarize, I've tried to stick to time. Management of type 1 diabetes, friends, is a dynamic process. Believe me, it's a dynamic process. We need to have those conversations with our patients. We need to tell our patients what they need to do. We need to make patients understand that insulin is their best friend. And we need to, most importantly, I'm going to use this platform to tell each and every one of you, please, at all points of time, reiterate to your patients that you need to be on insulin. Insulin is your best friend. Please do not get taken in by all the quacks out there, by all those fantastically stupid stories that you read on the net, where a number of so-called unethical people have made their patients go off insulin, and you and me know these patients come to us with DK. Each and every one of us can be an ambassador to reach out to our type 1 diabetic patients, to reach out to their families and tell them that no, this child or this adult needs to be on insulin, which is becoming easier and easier and easier to use. Adequate basal coverage with insulin without glucose fluctuation, with that means without hypo or hyper, is the key to successful management. We all know newer insulins have made our job much easier because they do reduce the risk of hypoglycemia, especially nocturnal hypoglycemia. But I would love to see the ideal insulin. I still think we have a long way to go. I still think we need more research. I still think we need to understand. And I still think the more we understand, the less we actually know. Thank you very, very much for your very patient listening.
Thank you, Dr. Shaila. That was an excellent presentation. Very, very clearly and nicely explained. I can see one question in the chat box. I'll just put it up. Just. It is asked by Dr. Imran. Do we get stacking up effect of U100 glargine if used BD, maybe he wants to say.
No, Imran, you don't get stacking effect if U100 glargine is used BD. You can definitely use it.
Yeah. So, thank you very much.
It was a pleasure, ma'am. Thank you. Thanks for inviting me and thanks for chairing me. Thank you very much.
Thank you.
Ma'am, one more question. During in-hospital management of diabetes, would you use degludec or U300 when you're trying to control blood glucose levels in the inpatient management?
In the inpatient management, Rajesh, I prefer using U100. I prefer using U100 because it takes 2 to 3 days for me to see the complete effect of U300 or insulin degludec. So I personally still use only U100.
Okay, ma'am. Thanks.
Thank you so much, ma'am. Moving on to next topic, I would like to invite Dr. Ganesh Zevarikar. He will talk on basal bolus insulin therapy in type 1 diabetes. He is a MD Pediatrics and he's a senior consultant in the Department of Pediatric and Adolescent Endocrinology at the Max Hospital, Delhi. So I would like to welcome Dr. Ganesh Jabal.
Thank you very much. Good morning to everyone. Thank you, Nisar, and thank you, IDS team, for inviting me for this session. My session is going to be very basic and somewhat practical. I'm trying to incorporate some of the things which I feel are the issues with basal bolus therapy as is being currently practiced in the field of type 1 diabetes. So this is the outline of my talk. I think no talk on basal bolus therapy can start without a comment on DCCT, which all of us are very well familiar with. We'll try and understand some basic concepts of basal bolus therapy and some practical aspects. And obviously there are challenges, but most of the challenges can be overcome if we have clarity that basal bolus therapy is the only way to go about in type 1 diabetes. So right from the discovery of insulin in 1920s, treatment of type 1 diabetes has undergone several evolutions in terms of introductions of Nph insulin or lente insulins, introduction of Smbg, introduction of recombinant DNA insulins, and now increasingly newer structural modifications and analogs which have really made insulin therapy closer to the physiological insulin secretion, if not ideal. So we all know that DCCT conclusively proved that multiple injections and intensive monitoring by glucose testing and dose adjustment achieves better HbA1cs and a significant reduction in the incidence of microvascular complications. And the subsequent follow-up EDIC also showed that the memory of this good control stays for a long time. So the benefits are long lasting. Historically also, right, when the insulin was discovered and before the Nph and lente insulin were discovered, patients who were treated with multiple doses of regular insulin actually had lesser incidence of complications compared to those who were treated with 2 doses of lente or Nph insulin. So this was the lesson from the history. And subsequently, all the professional societies, including ISPAD, have recommended that people with type 1 diabetes have to be managed. Please note that we have to say people with type 1 diabetes rather than saying type 1 diabetic, because that is not their identity. So intensive insulin regimens, either by multiple daily injections or pump therapy, with differential substitution. It is very clearly mentioned, differential substitution. So no professional organization encourages use of pre-mixed formulations of insulin for type 1 diabetes. Differential substitution of basal and prandial insulin, aiming to have optimal metabolic control, is the gold standard for pediatric type 1 diabetes. And I apply the same to even adults with type 1 diabetes. However, the reality is that in one of the leading government institutes, at baseline visit, 84% patients were on non-physiological management regimen. In our own previous institute, about 30%. So my institute used to cater mainly to urban and higher socioeconomic group. Even in that group, about 30% people with type 1 diabetes at the time of enrollment were on unphysiological insulin regimen. And if we see in the community, this is much wider. The main disadvantage that happens with twice daily or premixed insulin is that you have this unphysiological peak of Nph and lente Nph insulin, which can cause the compulsory need of snacking and also hypoglycemia if you do not have that snack. And the tailing effect of regular insulin, which also makes mid-meal snacking compulsory and increases the risk of hypoglycemia. Also, when we use premixed insulin, we cannot separately adjust the dose of long and short acting insulin. So that leads to problems. For example, if you see this CGM of a girl who is on twice daily premixed insulin, you can see that the lunch is hardly covered at all. And if you want to cover this lunch by increasing the morning dose of premixed insulin, you will end up causing a hypoglycemia later in the evening because you are simultaneously increasing the long acting insulin too. So this and several other problems, and clearly the long-term complication risk just doesn't serve any excuse to use premixed insulin in type 1 diabetes. So what we are trying to basically do is to mimic physiological insulin secretion by giving basal bolus therapy. So physiological secretion of insulin happens in two components. One is a small low-level insulin secretion that goes on 24/7, which basically limits the hepatic glucose output and prevents ketogenesis. So basically it preserves the protein and fat for the function which they are meant to do originally. And on top of it, there is prandial boluses of insulin, which are secreted in response to mealtime rise of glucose. So typically this insulin is secreted directly in the portal circulation and has a very short half-life. So we are trying to mimic the same, although it is not entirely physiological because we are giving it in the subcutaneous space. So what we are doing is we want to have a basal insulin component and we want to have prandial insulin component to it. Ideal basal insulin should have significantly long duration of action to permit ideally once daily or at least twice daily dosing, and relatively flat action profile. It should not have a peak. And the pharmacokinetics should be consistent. So the day-to-day variation or inter-day variation should not be significant. Whereas ideal prandial insulin should have relatively rapid onset of action, and the peak of the insulin should match the peak, that is the post-glycemic or post-prandial peak of the food. So it should better match the postprandial peak which is caused by the food intake. And the action should be relatively shorter, just like physiological insulin secretion in the body. So what are the options that we have? We have several options, and there is a role for each and every insulin. It is not that NPH is outdated. NPH also has a significant role. So this is one misconception that people often have, is that basal insulin only means glargine or detamine or degludec. It is not true. NPH, if you use intelligently, can serve as a very good basal insulin, especially for those who cannot afford the newer analogs. The one more thing that sometimes people do is they give NPH once daily, only at the bedtime. That is not enough. NPH, if you're using as basal insulin, it has to be given twice daily. Also, if you're using detamir in most patients, it has to be given twice daily. So there have been studies where nearly more than 70% patients require detamir dosing to be twice daily. With respect to glargine, one has to remember that it is an acidic solution. So therefore, often people complain of burning or stinging sensation at the site of injection. And this can be sometimes very bothering. And in that case, you could consider switching over to degludec or some other insulin. The newer long-acting and ultra-long-acting insulins have been a really great addition to our armamentarium, and it has caused, it's consistent pharmacokinetics, once daily dosing, and minimal peak is very close to what we desire for an ideal basal insulin. With respect to prandial insulin, again, every insulin has its place in the management. Traditional regular insulin can very well be used, provided you keep in mind that the pharmacokinetics is different from the analogs. So the onset of action happens after 30 to 60 minutes or 30 to 45 minutes. And therefore, that much gap has to be given after you inject insulin to start your food. So it is very important that if you are prescribing regular insulin as a prandial insulin for your patients, you have to give it 30 to 45 minutes before the meal is started. And the tailing effect or the long action that I mentioned previously as a disadvantage can sometimes be an advantage. There are people who are unwilling to take multiple doses of insulin. And therefore, in that case, the regular insulin can permit a small, please see the emphasis on the word small, mid-meal snack. It should not have a huge amount of carbs, because that will not be then adequately covered by the regular insulin. So for example, if somebody is having school from 7 o'clock to 3 o'clock and does not want to take insulin in the school, the snack in the insulin, which you are giving along with regular insulin, has to be less on carbs. If you give a huge meal in the school lunch, and if you don't cover it with insulin, you will end up with very high sugars when the child comes back from the school. The newest addition is the faster acting aspart, mainly with respect to the onset of the action. The peak and the duration of action are similar to Lispro, aspart, and glulysin. So the advantage is that you can give the insulin just before the meal, just 2 to 5 minutes before the meals also. I will be discussing about pre-meal versus post-meal bolusing later on. So how do we initiate somebody on basal bolus therapy? So we have to know what is the rough total insulin dose recommendations for different age groups. In prepubertal age, it is about 0.7 to 0.1 unit per kg. I typically start with 0.8 unit per kg. In pubertal age group, the requirement is higher. So 1 to 1.5 units per kg per day. I start with 1 and then go on adjusting upwards if needed. In honeymoon phase, the requirement comes down to less than 0.5 units per kg per day. So you have to know the total daily requirement. The basal insulin forms about 30 to 50% of this total daily insulin requirement. In toddlers, because the frequency of snacking is more, the prandial insulin proportion is almost 70% and the basal insulin is about 30%. In older children and adolescents, it is about 40 to 50%. If you're using regular insulin as your prandial insulin, it can give sort of a kind of little basal kind of coverage also. So therefore, relatively lower basal percentage if you're using a regular insulin. Whereas with analogs, it may be slightly higher percentage may be required. Remember that the basal insulins, glargine or detamine or degludec, cannot serve as an insulin replacement for any meal or snack. People often assume that because they are taking glargine, they do not need to take the mealtime insulin. It cannot cover the meal or snack. For that, you need the prandial insulin. And the prandial insulin is remaining 50 to 70% divided in 3 to 5 doses. Now here again, I want to emphasize that our goal is not to reduce the number of insulin shots. As treating physicians, we have to do what is correct. It may be a little more painful. I understand the difference between no insulin versus 2 insulin or 3, but 3, 4, 5 it doesn't make much difference. If it is going to serve the patient in the long run, if it is going to reduce complications and long-term pain is going to be reduced, our goal should not be to reduce the number of injections. We have to give as many number of injections as are required. So how do we approach the prandial insulin dosing? Often we tend to think of basal bolus therapy as 3+1, breakfast, lunch, dinner, and basal insulin once. Our Indian concept is that khana is breakfast, lunch, and dinner. What we eat in between, or tea or coffee or these kind of things, we don't consider as khana. We don't consider it as food. So that is what is very important, because our tea is also made up of milk, which has significant carbs, which can give a glycemic rise. And often we have it with 2, 3, 4 biscuits. And then we consider it as a snack, but it gives a significant rise of glucose. So all meals and snacks have to be covered, not only breakfast, lunch, and dinner. Unless there are very few meals or there are very low carb thing, if somebody is having that, for that you may not need a meal prandial insulin. But any snack that is having maybe more than 8 or 10 grams of carb may need to be covered with insulin. So what are the two approaches? One is that you keep relatively fixed insulin doses, and the dietitian designs a diet plan which keeps the carb content uniform. So for example, if the dietitian has said 60 grams of carb for breakfast, we make sure that we use food exchange list and ensure that the gram content of carbs is 60 grams. One approach is this, that you keep relatively fixed insulin doses and keep fixed carb intake. And the second approach is that you have variable food, but you count the carbs and you take the insulin with the help of insulin carb ratio and correction factor. These are the only two approaches. You cannot have one dose recommended and the person with type 1 eating anything that they want. If they want a variation in the food, they need to then learn to adjust for that variation in terms of insulin therapy. See, they understand simple logic. More food means more insulin. More carbs means more insulin. Higher the blood sugar before starting your meal, you need to take an extra correction dose of the prandial insulin. So these simple statements often make people understand that, yes, this makes sense. And it is actually more simpler to explain. We calculate the insulin carb ratio, which means the number of carbs or grams of carbs covered by 1 unit of insulin by rule of 500 or 450 in case of regular insulin. So 500 divided by total daily dose of insulin will give you the number of carbs that are covered by 1 unit of insulin. For very young children, or if there is an insulin requirement is very low, we use rule of 300. Then the correction factor. Correction factor means it is used for correcting high blood sugars. That is the amount of reduction of blood glucose with 1 unit of insulin. It is calculated by rule of 1800 or 1500 in case of regular insulin, for 1800 for analogs. So 1800 divided by total daily dose would give you the correction factor. I mentioned about food exchange list. So we can use food exchange list if we are using the earlier approach. That is, we want to have fixed carb intake for all the meals. So therefore, if I'm having one roti of 20 grams of wheat, which gives me 15 grams of carbs, the next day I want to have a little variation in that, I can have half cup of cooked rice, which also will give me same amount of carb. So I have variation in my diet, but I'm keeping the grams of carbs same. I know that this is a bit oversimplification, but we have to start simple and then build on to that. This is a very nice resource by Cheryl Salis. It's freely available on the ISPAD website. You can all refer to it. And all these food items contain 15 grams of carbs. So you have to kind of get oriented to understanding carbs and the carb content. Let us go through some sample calculations. So this is a 10-year-old prepubertal boy with a weight of 30 kg who's been diagnosed with type 1. I will calculate the total daily dose as 0.8 into weight, that is 0.8 into 30, so 24 units. And about 40% of this, that is 0.4 into the total daily dose, is the basal insulin. So this comes to roughly 10 units. So I'm giving 10 units of, let us say, glargine for this patient. And then I calculate insulin carb ratio, which is 500 divided by, again, the total daily dose, that is 24. So roughly it will come as 20. So 1 unit of insulin will cover 20 grams of carb. And a correction factor, that is 1800 divided by 24, which roughly comes to 75. So how do we practically apply this? Now this boy is about to eat his meal and he's having 60 grams of carb in that meal. So because 1 unit is covering 20 grams, I'll be needing 3 units of insulin to cover these 60 grams. And my pre-meal blood sugar target is about 100. I want to have my pre-meal blood glucose as 100. But when I check the blood glucose, it is actually 220. So I calculate the correction dose by observed blood sugar minus the target blood sugar and divided by the correction factor. In practice, we don't have to do all these calculations. There are plenty of bolus calculators which are available online to do these calculations. So this comes to roughly about 220 minus 100 divided by 75 comes to about 1.5 units. So the dose that I'm going to take is composition of carb dose plus correction dose. The correction, of course, will be 0 if my blood glucose was 100. So 3 plus 1.5, that is 4.5 units. This is what will be my dose for the meal. There will be some modifications which are required depending on if an exercise is anticipated or if there is a sickness, then we might have to revise these kind of doses. But this is the basic calculation. So for example, if I'm going to exercise, I may kind of reduce the dose slightly. If I'm sick, I may kind of increase the dose slightly. Now, one more mistake that often people make is to give insulin just before eating or after eating. So that is also wrong because it is now clearly shown in several studies. As you can see in this study that the red graph or red line is the pre-meal dosing. The blue line is start of meal and the green line is the post-meal dosing of insulin 20 minutes after the meal has begun. You can see that the post-meal peak is much better controlled if you give pre-meal dosing, and the incidence of hypoglycemia is very less if you give pre-meal dosing. So insulin has to be injected before the meals. And I'm talking about prandial insulin only. So if you're giving Lispro, you have to inject it 15 minutes before meals. If you're taking aspart in your pump, you have to inject it 15 minutes before meals. If you're taking regular insulin, you have to take it 30 to 40 minutes before the meal. So taking this improves post-meal control. These people, it has been shown in large registry-based data that they have better HbA1c values. And post-meal bolusing actually increases the risk of hypoglycemia. And you end up in that cycle of treating low, treating high, like that. So advice about timing of bolus needs to be tailored in some special circumstances like pregnancy, gastroparesis, or a toddler who is very sick or fussy sometimes. Although there also we emphasize that pre-meal dosing has to be practiced. This is one CGM which shows the effect of poor timing of insulin. You can see that this girl on glargine plus regular insulin is having the breakfast here, but you can see that there is a steep rise of blood glucose followed by steep fall. This is typically seen because she is not giving any gap between her regular insulin and the NEAT. If she gives a 30 to 40 minute gap, then you will not be seeing this peak. It is not enough just to see the best doctor and to take the most costliest insulin if you don't do self-adjustment of insulin doses. This has to be done with the help of either blood glucose monitoring, which has to be intensive. Don't try and pity the child or pity the person to say that, no, okay, why prick 4 times, why prick 5 times? No, you are doing injustice to your child. 4 to 6 times per day or use CGM. It has to be done for abnormal patterns, corrections for high sugars, exercise, and special diets, and several other situations. Now, correct the dose of, if you are giving a correct dose of basal insulin, it should maintain stable blood glucose within 20 to 30 milligrams of deciliter over a period of 6 to 8 hours of fasting. This is best assessed by overnight period. So if you're sleeping, let us say, with a blood sugar of 120, and if you're waking up within 100 to 150 blood sugar, that means your basal insulin is working fair or working okay. Correct dose of prandial insulin should give you a 2-hour post-meal blood glucose of plus 20 to 40 than the pre-meal. So if you have started my meal by 100, if my post-meal is 120 to 140, then my bolus dose is correct. If not, then I need to either make adjustment to insulin dose, timing, or food, or other factors. Now, there are several applications which are available, which can digitally download the glucometers, give you very nice pictorial representations of low blood glucose, high blood glucose, and percentage, which is within the target, etc. Please use all this technology for the benefit of your patients. Manual BG logs is a tiring work. It does require a lot of motivation. It has its own role, but use digital connectivity much more. Like in this chart, you can just pick up that there are plenty of lows before and after lunch. So either it is happening because, and there is a very high sugar after breakfast, high glucose after breakfast. So this is probably happening because the basal dose is too much or the timing of insulin is incorrect. There are mobile applications for maintaining just BG glucose loss. This is the one which I recommend to my patients, My Sugar Diary. It's very beautiful. It's free and it's very beautiful. It gives you immediate visual picture of what is the insulin dose and what are the blood glucose readings. CGM is an excellent tool. Wherever possible, we must use CGM. If ongoing basis, well and good. If not, at least intermittently. So this CGM can show you that this girl has severe or significant nocturnal hypoglycemia, which often are missed on routine Smbg monitoring. And she's been taking basal twice a day. And therefore, in this girl, we kind of managed her evening exercise and also reduced her evening basal. The CGM role has been conclusively proven in many studies. This is one of the study gold randomized clinical trial in adults with type 1 diabetes, where 161 people used. It was a crossover trial. So initially, first group used CGM and the other group used conventional, and later on, both the groups were switched over. So you can see that the group which used CGM initially had significant decline of HbA1c. And when they switched over to the conventional treatment, this disadvantage was gone. So CGM usage resulted in significantly improved HbA1c in this particular study. So there are challenges. It's not that it is totally challenge-free. There is a challenge of cost. You are using more pricks, more insulin, newer insulin. But you can very well have good control using conventional insulin. You can use NPH plus regular in the morning and evening and give a regular insulin for lunch. That's also basal bolus therapy. Intelligent use of blood glucose tests. It doesn't matter how many tests you do. If you're not using them and if you're not adjusting doses, it's useless. So therefore, use them intelligently. And saving on the cost of complications. If you have bad control and end up spending lakhs of rupees on treatment, it's of no use. Inertia by healthcare providers. We are not there to pity the child. We are there to help the child to achieve best glycemic control. And therefore, we have to do our job without getting attached to emotionally. And we have to emphasize that this is the standard. This is what you have to do. Unwillingness by patient or family can be overcome if we give uniform messages. Patient sees me, I tell 5 injections, the patient doesn't like me and goes to another doctor and who says that, no, this is okay. If you want 2 injections, take 2 injections, fine, patient-centered therapy. But this is going to do injustice to the patient in the long run. So if the messaging is uniform, they will say that, okay, I met 5 doctors said the same thing, so therefore this is the correct thing to do. Support groups are very helpful in overcoming this inertia and also the adherence issues. Peer support groups or doctor-patient support groups are also helpful. It's very important that adherence issues are generally a reflection of some issues with the mental health or some issue with the family health. Generally, you will see adherence issues in puberty, mother-child conflict or parent-child conflicts or conflicts within the parents. So they are a reflection of some underlying stress or some underlying problem. And therefore, we have to listen more often and we have to empathize with our patients. To conclude, every single person with type 1 diabetes has to be offered physiological insulin, either in terms of basal bolus or insulin pump. If you are using Nph or Determinant, it has to be given twice daily. Glargine dose sometimes may also have to be split in few people with type 1. Bolusing is for all meals and snacks, not just for breakfast, lunch, and dinner. And bolus before meals, not just beginning or not after meals. And monitor and self-adjust. And please use CGMs as often as you can. Thank you.
Thank you, Dr. Jayavrikat. That was an excellent presentation. I can see some questions in the chat box. I'll just... one is from Dr. Sanchinya. Sir, your experience on covering snacks with acarbose therapy in type 1 diabetes? That is a question.
I don't use acarbose for type 1 diabetes.
Okay. Yeah. And there is one more question by Dr. Jitendra Jain. Any differences between biosimilar glargine insulin?
Well, a large majority of my patients are on the innovator molecule, but we do use biosimilar insulin, and we do get quite good results even with biosimilar insulin. Particularly, it's very helpful to cut down some of the cost. So therefore, these factors have to be taken into account while deciding the insulin that we use.
I also have a question. What is your experience with this FIASP, the fast acting aspartate? Any advantage other than that quicker, earlier duration, earlier whatever, peaking?
Yeah. So that's the most practical advantage, ma'am, of using FIASP. I have no experience in using FIASP in insulin pump as of now. I have as of now continued with aspart or Lispro in pump, but it has been approved for pump therapy also, but I have no experience with that. Other than that, one of the practical experiences that somehow the company has priced it lower than the aspart. So, so cost-wise, it works a little cheaper than aspart.
Okay.
Dr. Jayavrikat, do you encourage giving correction boluses, or you think correction boluses lead to hypoglycemia, so you should avoid it, or in clinical practice?
I would say somewhere in between. Like we do encourage correction doses. We cannot allow blood sugars of 250 or 300, but we do not like some of the parents have a very hyper reactive kind of a response where they correct for even slight increased blood sugars. But the main thing is that if you are having to give frequent correction doses, that means you need to look at why we are having to do it. That means we need to do some adjustment. So it is not that you just go on giving correction doses. But we do not like discourage. It should be encouraged. The gap between the correction doses, like if you are giving very frequent dosing, then you may end up stacking and causing a low blood sugar. So we generally say that like 2-3 hours gap should be there between the insulin doses.
So you think the newer insulins, aspart and Lispro, are better when you want to give frequent pre-meals boluses, I mean with every meal, rather than using the conventional Actrapid or any other regular insulin?
Certainly, I feel that if we are taking insulin for every meal and snack, I would prefer the rapid-acting analogs. Regular insulin we prefer for those who like don't, I mean, who are like with analogs, it is very often nowadays I've started prescribing the analog 4 times a day minimum, like breakfast, lunch, evening snack and dinner, or breakfast, mid-morning snack, lunch, evening snack and dinner, or something like that, 4 or 5 times. If they're unwilling for that, then regular insulin is a reasonable choice.
And use of U300 and degludec in type 1 diabetes children, not.
I have limited experience with U300 glargine, but degludec I have used. One of the things that happens with degludec is it takes like 3-4 days or 4-5 days to kind of build up the concentration. So therefore, in the initial few days, the people get very hyper that you change the insulin and suddenly the sugars have gone very awry, and so we have to wait and we have to give it some time. But I feel that the need of splitting dose, etc., is not there when we are using degludec.
Thank you.
Thank you, chairpersons, and thank you, audience. Thank you, organizers, for having me here.
Thank you.
Okay, Dr. Jevalika.
Yeah. The next speaker today is Dr. Jyoti Dev, and he is very eminent speaker, MBBS and MD from Government Medical College, Trivandrum. He's chairman of Jyoti Dev's Diabetic Research Centers at Trivandrum, Kochi. He's at the National Executive Committee member of the RSSDI, and he is a senior vice president of the Geriatric Society of India, a reviewer of more than dozen indexed endocrinology journals. He is first author for Indian guidelines on vaccination, insulin pumps, and glucose monitoring. He's pioneer in cost-effective treatment of diabetes with use of telemedicine and technology. And he has delivered lectures in the American Diabetes Association, International Diabetes Federation, and many international. Sir, and I call you to deliver your talk.
Thank you. Thank you very much for the nice introduction. I am honored to be part of this special Type 1 program. And congratulations and thank you again, Dr. A.G. Unnikrishnan, for giving me an opportunity. I know that this is a very special event and this is a much sought after educational event for diabetes across the country. So let me start sharing the slides. This is on insulin pump therapy in type 1 diabetes. So these are my disclosures. The automation probably started with the use of biostat. And that was in 1974. And then it was thought that this is going to be a commercialized device. Of course, it is commercialized, but it is soon realized the intravascular sensing and intravascular insulin infusion cannot be replicated outside the hospital environment. And hence, it was discontinued. The experiments were discontinued. Only when in 1979, 2 independent researchers from 2 different parts simultaneously reported the success of subcutaneous continuous insulin infusion. And that was from Pickup and Chamberlain. And this is the same John Pickup, described now as the father of modern day insulin pump therapy, lecturing in one of our own conventions in the year 2018 in Trivandrum. So how you can program the insulin in the pump, it's very important. Whether it is a standalone old insulin pump or a modern day artificial pancreas, you need to program manually in the beginning. And for that, you have 2 methodologies to decide the dose of insulin. Either you can go by the body weight of the person, or you can go by the already existing dose. If it is well-controlled diabetes, reduce it by 25%. You can have an average, and then you will obtain the total daily dose of insulin, which will later on determine the insulin sensitivity factor, the insulin carb ratio, and so on. So always use your common sense. Always use your clinical judgment when you are calculating the initial dose of insulin in the pump. If the patient is already having recurrent episodes of hypoglycemia, go for a lower dose. If the patient is already having a persistently elevated hemoglobin A1C, go for a higher value. If there is erratic control, and at the start of the diagnosis, if you have decided to put the person on a pump or shifting from oral medications to insulin pump, then go only by the weight-based method, which is relatively safe. And once you have calculated the total daily dose of insulin, the next step is calculating the basal and the bolus. So always the basal is less compared to the bolus. And it depends upon the age of the person. Of course, this is not a hard and fast rule, but most often this works. In adults, 40 to 50% basal. Puberty to adult, 30% to 40% is basal. And in very young children, 20 to 40% is sufficient for basal, and the rest will be the bolus dose of insulin. So these are all evidences from the earlier days, and this is the same John Pickup in 2008 reporting robust reductions in the hemoglobin A1C with the use of insulin pumps compared to the multiple daily dose of injections. Greater reductions seen in those with the highest hemoglobin A1C at baseline, and again with lesser occurrences of hypoglycemia. 75% reduction in severe hypo with continuous subcutaneous insulin infusion compared to multiple daily injections. And this is again comparing insulin pumps with MDI, and this is a systematic review. Again, you can see over here, favoring the use of insulin pump for greater reductions in hemoglobin A1C and with no increase in the occurrence of hypoglycemia. So this is a registry from the US endocrinology centers, a total of 25,833 children and adults with type 1 diabetes. Again, a relatively older data published in 2012, only to document, even in the earlier days, when pumps are appropriately used and when the selection is for the right candidate, and when the infrastructure is there for training the patients and supporting them 24/7, you will get the best results for hemoglobin A1C reduction. Lower chances of diabetic ketoacidosis and for severe hypoglycemia. What about the additional advantages? Why are we promoting insulin pumps in all types of diabetes, not only in type 1 diabetes? Insulin pump is capable of providing basal insulin at different basal rates, and if properly programmed based on a retrospective continuous glucose monitoring data, especially this is in type 2 diabetes, in all these subjects, there is a reduction, minimization of the glycemic variability, whatever be the hemoglobin. So in this example, you have in MDI and in pump almost similar hemoglobin A1C, but there is a significant difference in the glucose variability in the pump users. So this is again in type 2 diabetes, some of the earlier prospective and retrospective studies, and this is a 2009 study from our own center documenting reduction in the hemoglobin A1C and substantial reduction in the total daily dose of insulin. Yes, insulin pumps when compared to multiple daily injections can result in robust improvements in all the microvascular complications such as retinopathy, neuropathy, and nephropathy. So let me now move on to the cardiovascular mortality. You know, cardiovascular mortality and use of insulin pumps need to be discussed because nowadays we are focusing on the cardiovascular benefits of therapies in diabetes. So we have lengthy discussions on the use of GLP-1 receptor agonists. We have discussions and debates on SGLT2 inhibitors and improvement in the CV mortality. Do we have any data with the use of insulin pumps and improvement in the CV mortality? Of course we have, of course. Look at the data on the correlation between the hemoglobin A1C and the occurrence of death in diabetes. Yes, even young children, even young people with diabetes of a long-standing duration are dying of different reasons. And this is the adjusted hazard ratios for death among persons with type 1 diabetes, those with uncontrolled diabetes. There is an 8 to 10 times higher risk of death. And this is in orange, you have death from any cause. And this is in red, death from cardiovascular disease. Recently, in our state, there was a death reported in a medical student. And he was hardly 19 years old. And at postmortem, it was found that it was a triple vessel disease, type 1 diabetes of a long duration. And I came to know that it was hidden from the teachers. So sad and so unfortunate. It is happening even among the educated people with diabetes. So IPT and CV mortality from the Swedish National Diabetes Register, a total of 18168 people with type 1 diabetes, of which more than 2,400 using IPT. Significantly lower for fatal coronary disease, fatal CV disease, and for all-cause mortality compared to the injection users. There is a 45% reduction in fatal and non-fatal coronary heart disease in insulin pump users compared to the multiple daily injection users, and a 42% reduction in fatal cardiovascular disease in insulin pump users. 27% reduction in the total mortality. Yes, insulin pump, again I'm repeating the word, when appropriately used, it's very important. This statement is very important. The selection should be adequate and the subject should be trained appropriately. And then only you will get the optimal benefits of an insulin pump. Yes, IPT is associated with lower CV mortality in type 1 diabetes compared to the injection users. In another study, and this is the excited clinical trial where we have shown insulin pump users documenting improvements in the pain and symptoms of neuropathy and significant improvements in erectile dysfunction. Let me now move on to a real life scenario. Again, very unfortunate. I saw him a couple of years ago, a 51-year-old gentleman, diabetes since the age of 25 years. And he himself went for an insulin pump 8 years ago, and he has upgraded the insulin pump 3 times during the past 8 years. I am seeing him for the first time. And when I asked him, he said that he had no idea about the basal profiles to be programmed with the pump. We were shocked. All the team members were shocked because the pump was not programmed. He was only administering the bolus dose of insulin. The guy has already developed coronary disease, bilateral peripheral retinopathy, hemoglobin A1C during the first visit, 10.6%. Post-COVID, currently, he is on dialysis. And I asked him what happened, because he said that he believed that insulin pump therapy is sufficient and it is going to be a solution for his diabetes. And he never went back to the doctor. He never went back to the original doctor who has deployed an insulin pump. And I asked the family, the wife, who is married. The wife said that she is completely helpless. The family members are helpless because he is so irritant. And we spent another 1 hour counseling the entire family members. This is uncontrolled diabetes, and the disease itself can lead on to depression. He has got multiple complications of type 1 diabetes. He has mood swings, and we referred him to the psychologist in our team for a counseling. What are the factors resulting in failure of insulin pump therapy? It is very important that all the criteria need to be fulfilled. When you are selecting the person for insulin pump, they should be comfortable with the use of devices with realistic expectations, in contrast to the guy whom we just met. Willing to monitor, report, remote monitoring, downloading the data, willing to follow with the team, willing for retraining with adequate financial resources, including for the accessories and for the supplies. And I would say the single most important determining factor, it can be a 7-year-old kid or it can be a 30-year-old person with type 1 diabetes. Whatever be the age, the single most important factor which is going to decide the success of the therapy will be the family support. The family support. Persons with diabetes and their care partners need to receive thorough education, both about the management of diabetes and also about the devices. Very, very important. Let me now move on to the next big happening. The next big thing in type 1 diabetes, it has already reached in India. I know that most of you have already used for your patients, and that is 780G, the insulin pump, which is an automated insulin delivery device, which is launched in India a month ago. The experience is very, very exciting. For the first time, we are using a commercially available device in India capable of automatically changing the basal rate once in every 5 minutes, avoiding both hyperglycemia and hypoglycemia in response to the sensor glucose values. And it is also, in addition to, at the stage 4 of automation, capable of automatically delivering a correction bolus, and that too, if the algorithm is deciding so. So these are the broad classification of the control algorithms which can be used in automated insulin delivery devices: the proportional integral derivative, the model predictive control, and the fuzzy logic-based systems. So what is this is the entire package. When you're opening the pack of a 780G, you have the Ketone Meter, you have the Guardian sensor, that is the generation 3 sensor with the link 3 transmitter. In some countries, now even the 4th generation sensor, that is CU sensor, which doesn't require a calibration, is available along with the same pump. So in future, we probably will be getting the same, which can be used with the same transmitter, and this connects to the CareLink app and also with the CareLink server. So I am capable of 24/7 remote monitoring. So this is the these are some of the terminologies: the Smart Guard Shield, the sensor glucose SG, the active insulin. The sensor glucose is the entity which will be deciding with the help of an algorithm the auto basal as well as the auto correction, stands for the auto bolus. What is the goal? What is the goal with this advanced hybrid closed loop system? The ulterior goal is to spend at least 85% time in auto mode. Some of the patients are successful in even spending more than 95% in auto mode. And you need to manually program every time before a meal. You have to enter the insulin, of course, the carb count, you have to enter the number, and the active insulin time also need to be programmed. So this involves a PID algorithm. So what are the basics of the PID algorithm, which is determining the dosages to be automatically delivered, stopped, or discontinued, and so on. So we have the proportional, which will be deciding how far the sensor glucose is from this set target. Integral is a measurement of length, I would say, how long the sensor glucose has been away from the target. And derivative is a measure of the time, how rapidly, how fast the sensor glucose has been changing. And if I need to know the time in target, I can just hit on the right arrow over the pump screen, and it will immediately display the last 24 hours time in range, below range, and above range. Quite exciting, quite exciting. And this is a study, a very recent one, comparing the time in range with the two devices, the older sensor augmented pump with predictive low glucose suspend and the AHCL. 67 versus a phenomenal 79.6%. 79.6%. And this is the experience across multiple countries. The performance of 780G with advanced hybrid closed loop system. At initiation, most of the countries reporting a TIR of close to 75%. So the international consensus is now recommending only more than 70%. At least 70%, which is going to correlate with an A1C is 7%. With advanced hybrid closed loop system, you will be capable of reaching an A1C below 7% with negligible time below range. And this is how you can manually program the glucose target. There are three targets over here, 110, 120, 110, and 100. And you have the active insulin time, which can be above 4 hours, 3 to 4, 2 to 3, or 2 hours. So lower the target, lower the active insulin time, higher will be the TIR. But a word of caution, requires expertise and requires time. So only in selected patients, you can move from one step to the other. The objective is to avoid hypoglycemia and then successfully reach a target which is acceptable for the individual and is safe for the individual. And this is probably the first time in our country we are reducing the gap. Remember, earlier we used to have a higher target for young children because of fear of hypoglycemia. And ISPAD and similar organizations recommended a lower target. You shouldn't be discriminating children with type 1 diabetes. You can reach a lower target for hemoglobin A1C provided you are successful in avoiding hypoglycemia. So this device is reducing the gap, and irrespective of the age, you can reach a better time in range. This is a response from our first patient on advanced hybrid closed loop system. Look at his response in the dedicated WhatsApp group. Doctor, I have slept peacefully at night, continuously for 8 hours. After 16 years, this is ever since the diagnosis of diabetes, thanks to the new device. This is life-changing. And this is transforming the care in diabetes. And these are the two screenshots from my own mobile phone, where I am remotely monitoring the patient on 780G and how the auto-correction boluses are automatically delivered even when the patient is sleeping. And this is successfully reaching a target of 99% without any risk of hypoglycemia. It is 0% below the range. So this is comparing the available two advanced hybrid closed loop systems, the Tandem Control IQ and Minimed 780G, with comparable results. There are multiple systems, and many studies have shown that these are worth for the high cost. And this is a cost-effective study. Minimed 780G is associated with an incremental gain of 1.95 calories compared to the conventional insulin pumps or pens or syringes, along with a flash glucose monitoring, with the avoidance of complications. These are the solutions to overcome the prevailing challenges: spending time with the subject, time with the parents. Never be afraid discussing insulin pumps with the patients. You should build a team along with you. You should be explaining not only the merits, but also the demerits, ensuring that there is a caregiver support. And this is my concluding remark. Never ever deny the benefits of these newer, path-breaking, life-changing technologies to those patients who are eligible and affordable. So once again, thank you very much, Dr. A.G. Unnikrishnan and the team, for giving me this opportunity. Thank you very much, dear friends.
Thank you, sir, for such an excellent presentation.
Thank you. Thank you, madam.
thank all the speakers for a wonderful session. And we would like to take up any. We thank all the speakers for a wonderful session, and all the three speakers gave us very enlightening picture of how to manage our type 1 patients. And we would like to take up any questions.
I think there is a question coming up on cost of the insulin pump. Am I right?
Yes, yes, sir.
Yeah. Okay, madam. The question is on the cost of hybrid insulin pump in India. So, you know, there are 2 to 3 types of hybrid insulin pumps. One is the basic pump. And we used to have 640G in India for the last 6 years. And the cost of that pump was around 5 lakhs. Pretty very high when compared to the older generation standalone pumps. Remember, we started with 1 lakh rupees for a pump long ago. And they were all standalone pumps. And then in 2007 came sensor augmented pumps. And those were the pumps which could be connected with a continuous glucose monitoring device. And these hybrid closed loop pumps are those who are a combination of manual and automated. And advanced hybrid closed loop pumps are those who are automated both during the day and night for basal insulin. So every 5 minutes, the basal insulin rate will keep on changing. And if in case you have not delivered the right bonus insulin, then within another 5 or 10 minutes, depending upon how the automated system that is based on artificial intelligence, it will automatically deliver a bonus as well. So both the basal and the bonus is automated in advanced hybrid closed loop systems. And that is costing around 6 lakh rupees. But the hidden cost here is there is a cost for accessories that I have described. But for those patients who are using it, there is a little manual that they should be operating with the pump. So almost everything is fully automated. But I do agree with all of you that the cost is extremely high for this common disease, because in India, it is 1,29,000 people with type 1 diabetes, especially below the age of 18 years. So we need some indigenous technologies. So it's going on in India in several parts to have some cost-effective devices at a very low cost. Thank you. Thank you very much.
So are there any Indian prototypes which are cheaper, more affordable, and which can cater to many more patients?
Yes, madam. There are prototypes, as you said. The terminology is very important. There are a couple of prototypes being developed, but they are all experimental. You know that insulin pumps, when compared to other devices where the patients themselves are using their own houses, it has been said that insulin pumps are responsible for maximum number of accidental deaths, and that is a reality. So you need to be very careful about the accuracy, about the reliability, because you know the insulin is continuously subcutaneously infused. So if the dose is wrong, then it can result in diabetic ketoacidosis. If it stops functioning, it can again lead on to diabetic ketoacidosis. And if the dose is more, it can lead on to hypoglycemia. So it's very important that you should be using some of these reliable branded devices. So when we are developing our own devices, you need an advanced pump, you need an advanced algorithm, and the third component will be a reliable continuous glucose monitoring devices. To precisely answer your question on the cost, the patient communities themselves are devising do-it-yourself artificial pancreas, which I'll be discussing in another lecture tomorrow and day after in your own convention, our own convention. And there I'll be discussing about how the patients are themselves creating their own algorithms and artificial pancreas, where the cost is very, very, very less, but they are not approved, but still used by many.
There is another question in the chat box. They are asking whether there is any correlation between PIR and coronary artery disease.
Yes, definitely, because it is supposed to be a surrogate marker. So PIR is not only correlating with microvascular complications, but it is also directly correlating with the macrovascular complications. So our idea is not to reach a TIR. Our ulterior objective is to reach probably, if possible, 0% time below range. So with these newer devices, we are successful in reaching a TAR of almost more than 70% in almost every year. And if you are managing it properly, more than 90% with less than 1% time below range. And that is where, when you are successful in preventing both micro and macrovascular complications. Technology is the solution.
I think glycemic variability also plays an important role, just not time in range. It's the variability also that leads to increased incidence of microvascular and macrovascular complications.
Absolutely, Dr. Rajesh. Yeah. So glycemic variability is measured, as you said, with the TAR. And when you are reducing the time below range, you are ultimately reducing and minimizing the overall glycemic variability. So that is where you are succeeding. And in the absence of technologies, it is not possible. And thanks to the modern day ultra rapid acting insulins and the algorithm, we are very, very successful nowadays. Thank you very much.
So I thank both our chairpersons, Dr. Shubhangi Kanetkar and Dr. Rajesh Nivani. He has come personally to take care of our session and to be with us here today. I have once again thank all the speakers who have done a wonderful job and enlightened us with our type 1 diabetes management. Thank you so much, and we move on to the next session. Thank you very much.
Thank you.
Our next session is on management of microvascular complications, management of neuropathy, nephropathy, and retinopathy. And I invite Dr. Ashutosh Pakale to chair this session. Dr. Ashutosh Pakale has done his MD Medicine. He's a consultant physician and diabetologist at Chelaram Diabetes Institute. He's done his MBBS from Latur and also his MD from Bangalore. And he has multiple national and international publications to his credit. I heartily invite Dr. Ashutosh Pakale to be the chairperson for this session. Over to Dr. Ashutosh.
Thank you. Thank you, Savita ma'am. So we will move to our next session where we are going to have a panel discussion. It is not like a presentation. Here we are going to just discuss regarding the management of a neuropathy, nephropathy, and retinopathy. For this thing, we have three guests. First is Dr. K.V. Kavita. She has done her diploma in podiatry science, BSc in psychology, and MBA in hospital management. She is associated with Chelaram Diabetes Institute since 9 years. And she has more than 15 years of experience in prevention and management of diabetic foot problems. She was formerly associated with MP Hospital, and she's a content writer and faculty for certificate courses such as diabetic foot management for doctor, diabetic foot care for healthcare professional, and ACMDC. She was awarded the best research paper at national conference, and she has authored publications in national and international journals as well. And she is a faculty in various national conferences and editorial book member in Chronicles of Diabetic Research and Practice. Our next guest is Dr. Charan Bale. He is a DM in nephrology. He is a consultant nephrologist and transplant physician at Chelaram Diabetes Hospital. He is also associate professor at Department of Nephrology, D.Y. Patil Medical College, Pune, and is an International Society of Peritoneal Dialysis Scholar in 2014. His area of expertise or area of interest are difficult access placement, chronic peritoneal dialysis, critical care nephrology, CKD, and diabetes mellitus and hypertension. Our next guest is Dr. Savita Bhatt. She is a senior consultant in glaucoma, medical retina, and phacosurgeon at Chelaram Diabetes Institute. She has completed her MS ophthalmology from CMC Vellore, and she is fellow in medical retina from Giridhar Eye Institute, Kochi. She has multiple publications in the field of glaucoma, with several publications in a leading journal as well. She has won the Best Research Paper Award at national and international conferences, including the Best Neuro-Ophthalmology Research Paper Award at a national level in January 20, and prestigious Siva Reddy Research Award at the state level in year 2009. Her paper was accepted in Asia Pacific Association of Ophthalmology 2015, and she has also participated in multinational clinical trials. So now, as I said, this is going to be just a panel discussion where we are going to enlighten the importance of neuropathy, retinopathy, and nephropathy in a type 1 diabetes. So here I would request one of each you to highlight regarding your specialties. So over to Dr. Charan.
Good afternoon. The thing is, I'll be speaking about diabetic nephropathy or diabetic kidney disease, which has been a major problem in the world and as well as in India. The thing is, for all the diabetic nephropathy, to prevent or progression of diabetic nephropathy can be deterred only and only by good glycemic control. So that's why you have to stress more about the glycemic control and your regular visits to physician, and this has to be done in the regular way. And the thing is, once there will be a increase in glycemia leading to substance P accumulation, which in turn leading to vascular complication like micro and macrovascular complication, which can be seen in diabetic nephropathy. So all this diabetic nephropathy of involvement of all the other organs can be seen after 10 to 12 years after the incidence in type 1 diabetes. So for first 10 years, we have a very good opportunity to control our blood sugar and to prevent the complications meanwhile it will be getting after the diabetes.
So I would be focusing more about diabetic peripheral neuropathy. So as you all know, diabetic peripheral neuropathy is nothing but the damage to the nerves occurred due to long-standing diabetes or uncontrolled diabetes. So generally, if the sugar is controlled, the complication can be delayed. And what all you have to look for is to check for any abnormalities like deformity, swelling. Clinically, you can also assess whether there is any calluses, corns, fungal infection between toes, overdryness, discoloration. These all contribute to the problem of diabetic foot. Since a patient with diabetic peripheral neuropathy will have symptoms such as numbness, burning, tingling, prickling, shooting, electric shock kind of sensation, sometimes they may not see due to this kind of symptoms. So often they may require some medical treatment, but the first baseline is to control diabetes. Secondly, footwear also plays an important role. In neuropathy, due to loss of sensation, sometimes if the patient is having ulcers or calluses, they won't know and they will be walking on that, which can end up in subungual hemorrhage, infection, wound can worsen. So it is necessary that all the patients with diabetes, whether it is type 1 or type 2, have to examine their feet for any problems. If anything, they have to consult immediately. Now, how to diagnose neuropathy? You may have to check a test called as biophysiometer. So biophysiometer will tell whether the patient is having neuropathy. So if the patient is able to feel the vibration, then it is considered that the patient's neuropathy status is normal, means patient don't have neuropathy. If they are not able to perceive or if the perception is delayed, then it is considered to be peripheral neuropathy. Over to Dr. Sarita.
So my specialty deals with the microvascular complications in diabetes, which can affect the eye. So if you have changes in the retina because of diabetes, we call it diabetic retinopathy. This often occurs because of a very high uncontrolled glucose. And in type 1 diabetics, we are told that you should check it after 5 years of onset. Often when the child presents with diabetes, the microvascular complications would not have set in.
When we see in our OPD, even for whether it's type 1 or type 2 diabetics, what happens is the patients are often surprised why this particular eye examination is included in their package or included in their examination part, because they say we don't have any trouble with our eyes. We go to an eye doctor separately. Especially in India, they are not aware that diabetes can cause complications to the rest of the body, whether it's microvascular or macrovascular for that matter. Especially the eye, they are not at all aware, because in the eye, what happens is it need not always affect the center of the eye and cause any diminished vision or vision related problems. It will cause a vision related problem much later. Even before that, we can diagnose and figure out whether the patient is having microvascular complication. What I do as a consultant is we do take pictures, which is done everywhere else. We go a step further, spend a little more time, show those pictures in case there are microvascular complications. Actually, the eye is actually window to all the vessels. We can actually see them, educate our patients that these microvascular complications have set in. Please do take care of your sugars in a better way. And they are pretty surprised that sometimes, there are multiple findings in their retina, whereas they are not able to feel it. They are pretty asymptomatic about it. So this goes in a step further in helping them to actually control their sugars, because next time when they come around for their next visit or a follow-up visit, I find that they are better educated, better controlled, and so on and so forth. So I'll give it to Dr. Ashutosh to go on with the next question.
So I would request the audience, if they have any question, kindly mention in the chat box. We will ask our expert faculties regarding the same. Meanwhile, till the time we get any questions, I would like to ask each of the faculty regarding why, for example, we'll start with Dr. Charan sir, who is a nephrologist. So what is the importance and why we should check regarding the kidney function or kidney parameters in a type 1 diabetes person particularly? So what is the importance and how frequently should we check in a type 1?
Right now, I'll just start with the natural history of the diabetic nephropathy part in a type 1 diabetes. So where we can see for the first 10 years, there will be not much of a thing if the patient is not controlling the diabetes. So after 10 to 12 years, there will be some amount of microscopic albuminuria will start, and then slowly it will progress to lower proteinuria, which will be of timeline of 15 to 18 years. By the end of 18 to 20 years, the GFR will start declining, and by 20 to more than 20 years, the patient will land up to ESRD and become dialysis dependent. So this is the natural course in diabetic nephropathy. So diabetic nephropathy will comprises of proteinuria, and there will be uncontrolled sugars, and there will be normal size kidney, which will be the thing. Out of this thing, 60% out of 60% of the patient who have diabetic retinopathy will progress to diabetic nephropathy, and the patient will have over proteinuria that is more than 3.5 gram per day. So this is the natural history of diabetic nephropathy. So once we have to see the kidney size, and we'll have to monitor the fundoscopy, and we have to see the quantify the proteinuria which will be there. And with that, to reduce the proteinuria, we have some more therapies which has to be given. We'll be discussing it further. Only thing is, over proteinuria is the first thing which will be the thing for diabetic nephropathy.
I would like to ask Dr. Kavita, why should we check regarding the neuropathy in type 1 diabetes particularly?
So it is important to check for peripheral neuropathy because most of the patients with peripheral neuropathy are asymptomatic. So they don't know whether they have peripheral neuropathy, and due to peripheral neuropathy, they have loss of feeling. So sometimes what happens, injuries or foot ulcer in the foot will go unnoticed. So that's why it is necessary that they should check for peripheral neuropathy. Generally in type 1 diabetes, immediately after the diagnosis, the test is not required, but the clinical examination should be carried out and they should visit a diabetic foot expert to see whether if they have any problem. It's not like if it is after 5 years, the patient has to check for neuropathy, and from then every year they have to check. If there is a presence of neuropathy, then the duration will come down, like once in 6 months, once in 3 months, and once a month if they have foot ulcer also. So basically, it will help in diagnosis early, which can prevent the complication. And if there is a problem, then we can manage accordingly.
Dr. Savita ma'am, so why we should check regarding the right time?
Like I told you before, I would like to really emphasize on the same question that usually when the patient comes to us, especially type 1 diabetics, they may not be having any microvascular complications and so on. They will not have any retinopathy either. So they should be checked at least at 5 years of stage, or type 2 diabetics at the time of diagnosis, because they may not be having any symptoms regarding that. So even an asymptomatic patient will have changes in the peripheral fundus. Bank center of the eye may not be involved in diabetic retinopathy, and it may go unnoticed. And it may even be at a proliferative stage where it requires therapy. Unless and until it is checked and treated and shown to the patient, he may not be able to understand that there are changes occurring in his fundus. As far as type 1 diabetic patients are concerned, you can have a whole range of age group in that, and they may not be very cooperative for a detailed eye examination. Nowadays, I would like to just bring this point that we have non-metriatic cameras which can click a picture, which will be giving you a fairly good picture of the retina and its surround, which will also involve the ETDRS areas which have concern in diabetic retinopathy. The other advancement in technology is that we have wide field fundus cameras which take almost up to the periphery of the retina. So even in an uncooperative patient or a young patient with type 1 diabetes, you can easily click these photographs even in a non-dilated state. So it will save us time, and in an uncooperative patient, you can get a picture very easily. That, and if they do have retinopathy, we can educate them and call them back according to the staging of the retinopathy for a further follow-up. Further than that, if you do not have support of an ophthalmologist, you have support from artificial intelligence, which can just demarcate whether there is retinopathy or not. This is inbuilt in several of fundus cameras. So this is for people who are consultant in individual physicians who do not have the support of an eye specialist to send across. So this AI platforms will all tell you whether the person has, just take a pic and you can figure out whether they have retinopathy or not. So these are advances.
And what should be the frequency of follow-up in such patient?
Yeah, so the frequency is, if you do not have a retinopathy at all, whether it is type 1 or type 2, it should be yearly, annual checkup at least. And if you do have retinopathy, depending on the stage, if you are mild, American guidelines still tell you that it should be once a year. But I usually call my patients every 6 months because they usually forget after a year, especially in asymptomatic cases. If they have moderate, it should be 6 months. If they have severe, it should be more frequent, 4 monthly. Those are the guidelines. And if they have involvement of the center, diabetic macular edema, that is, it should be 2 monthly.
Coming back to our topic regarding the management of a retinopathy. So what all treatment options we do have regarding retinopathy?
So management of the retinopathy, there are multitude of stuff available right now. So as I told you, if there's no retinopathy, you just call back the patient in a year's time. Even if it is mild, you don't really require to actively treat it, but keep the patient. But tell the patient to keep the sugars well controlled. So the most important treatment for diabetic retinopathy is the control of metabolic parameters. You should mention that he should keep his sugars under control, keep the blood pressure under control, and also keep the cholesterol under control. So other than this, if they have diabetic retinopathy which requires treatment, may not be mild or moderate. Even in moderate, if it does not involve the center, he just requires to come for a follow-up. Coming on to the severe, depending on what is the person's frequency of visits. If he is coming from a remote place, he may not present to you very fast. So you may think of doing a moderate panretinal photocoagulation. You may do a little moderate laser for him. And if he has good knowledge of it, you can just call him back for a revisit at an appropriate 4-monthly time. At this stage, at moderate or severe, if you feel the center is involved, we have in our armamentarium non-invasive technology to figure out whether the center is involved, so that we can do certain special tests to figure out whether the vision is threatened or not. In type 1, it is usually the proliferative changes which are taking over. In type 2, it is the macular edema which takes over.
Regarding the treatment part, so how we usually see the role of statins in a type 2 diabetes, we usually add the patient of a retinopathy. Is there the similar role in the type 1 as well regarding the statin?
Statins in type 1 may not have much of a role, because usually these are children who are coming to you and they do not have that kind of atherosclerotic disease or cholesterol. So type 1, like I mentioned, has more proliferative changes than macular edema kind of changes. So type 1, we usually find people who have more proliferation and they have more neovascularization elsewhere or at the disc, and they will require laser, and nowadays they also require something called anti-vascular endothelial growth factors, which are in vogue now, and there are multitude of them. I won't go into the details. And these are the treatment facilities that we have right now. If these two do not work and you have missed out treating the proliferative diabetic retinopathy in a type 1 at an early stage, it can even go into surgeries. So we rarely find deposition of too many cholesterol or exudation in a patient with type 1. If it is there in type 1, it probably heralds a disease of a nephropathy.
Thank you, Savita ma'am. Dr. Kavita, I would like to ask regarding the management of a neuropathy. What are treatment modalities we do?
So basically, management of neuropathy consists of medical and preventive management. The first basic thing is diabetes control. If the diabetes is controlled, then probably the symptoms should not occur. But in long-standing diabetes, if there is a symptom, probably there are drugs which is FDA approved, like pregabalin and duloxetine. But many a times, still when the patient is under this treatment, still the patient continue to have the symptom. So in that case, probably you can go with a non-pharmacological therapy, like anodyne therapy, which can be a last resort. We have done for a couple of patients who have mentioned that, but there are about 100 patients we have tried, but about 2-3 patients didn't have any symptom also. Apart from that, mostly we cannot do anything in neuropathy apart from the combination of drugs which we have. Basically, the diabetes control, preventive management like footwear, we have to ask the patient not to injure their feet, daily examination of foot, topical application of cream is very important, like diafoot cream, which contains allantoin and dimethicone. Many a times patient use this topical application and they also felt better regarding the symptoms like numbness, burning, tingling. Now, there are a lot of studies going on, but there are not much of improvement in that after putting on this kind of drugs.
I would like to ask, how do this type 1 diabetes patient, they would come to know whether they have neuropathy?
So if the patient has burning, numbness, tingling, all this kind of symptom, then it is said that patient is having already neuropathy. But many a times patient may not approach the doctor if they have symptoms. So once the patient reaches a physician, so physician should ensure to advise the patient that they have to undergo the foot examination, because many a times patient have loss of feeling. So they feel like Dr. Savita said, our sugars are under control. So we know we don't want to test the eye, kidney or feet. So we have to educate the patient and ask them to test for peripheral neuropathy or other microvascular complication. So for neuropathy, we have a couple of tests like hot and cold, which is also called as thermometry, in which we will find whether there is a small nerve fiber neuropathy which is responsible for burning and all. And they can also check biothiometer. Biothiometer is nothing but a vibration sense. If the patient has loss of vibration sense, then it is clear that patient is having peripheral neuropathy and they are at risk of diabetic foot related problems like non-healing wound and all. If they don't take care, it may end up in major surgeries also. So foot care plays a very important role.
And is there any difference between the treatment of neuropathy, particularly type 1 and type 2?
There is no difference, but diabetes control is very important. In type 2 diabetes, definitely with the longer duration of diabetes, the neuropathy may progress. But in type 1 diabetes, tight control of blood glucose level is very important and the management is almost same.
Okay, thank you. So I would ask Dr. Charan. So we do have a next question from Dr. Kare. So his question is for monitoring of a nephropathy, which is better, albumin creatinine ratio or eGFR? Dr. Charan.
Thank you. It's a nice question, Mr. Kare. The thing is, monitoring will be divided into two stages, that is CKD 1, 2, 3, and the other will be CKD stage 4 and 5. That is milder version of the GFR deterioration and extensive version, where 1 to 3, to where we have to monitor every 3 monthly, that will be sufficient enough, where we have to see how the glycemic control is there and how this thing is present, glycated hemoglobin levels are there. With that, we'll go for albuminuria. So albuminuria is the main thing, or the proteinuria, which will be the deteriorating the factor which will be saying that this will be the cause which will reduce the progression of the CKD. So that's why instead of eGFR, I think it's better to go for albuminuria or proteinuria as a marker. But according to KDIGO guidelines, where both have been mentioned, with albuminuria has also been given a same weightage as eGFR as well. So that's why the monitoring of this thing has to be done with the quantification of the proteinuria or albuminuria, and we have to try better control of proteinuria by one is blood pressure control, good glycemic control, lipid lowering agents has to be added, and with that there will be frequently following with the kidney functions has to be done. So with these things, I think it's better. Both will go hand in hand, but the thing is, for initial kidney involvement, the proteinuria is the marker. So I think we'll have to reduce the proteinuria, which will in turn reduce the GFR declining and then progression of the CKD.
And other thing is, how frequently should this type 1 diabetes patient they should follow in case of a nephropathy?
Even the thing is good glycemic control, and they have to follow up with a physician fortnightly or monthly. And the thing is, after if there is any involvement in kidney, that is like microscopic albuminuria is seen, then every 3 monthly we have to be seen. Microscopic albuminuria or with deteriorate GFR. So then with the GFR, the CKD stage till CKD stage 3, means the GFR is less than more than 45 ml per minute, then it's every 3 monthly visit will be sufficient. If it is less than 45 ml per minute, then we have to go for monthly visits so that we can deter the progression of the CKD.
Thank you, sir. Dr. Savita, would you like to add any other point regarding the retinopathy?
No, I would like to again emphasize that retinopathy can occur in 1 in every 3 patients who are diabetic. So it is important to check your eyes. And if it is type 1, the parents need to be more educated about it. And if it's type 2, we have to educate them with photographs. As in my case, you can always show the photographs and share the patients along with that. So it is, I think education plays a big role. And once you educate them, show their photographs that it's deteriorating and help them control their sugars and blood pressure and cholesterol, that plays a big role in management of retinopathy.
Thank you. Dr. Kavita, would you like to add any extra point?
So to conclude, so I would add that diabetes control is very important first. Secondly, foot care plays an important role. Thirdly, footwear is also an important thing because many a times patients present to us with foreign body injury. So with a good footwear and examination, we can avoid such kind of injuries. Thirdly, patient has to come for a regular follow-up, which is also very important. Thank you.
Dr. Charan, any extra point?
Yeah, the thing is, being a clinician, I prefer prevention is better than cure, where there is a good glycemic control, and I don't want patient for us to come getting the complication of the diabetes. So that's why it's better to follow up with the physician or the endocrinologist as fixed schedule thing and control your sugars. That will be the
Thank you all the faculties. So if there is no extra question, shall we move to the next session? Yeah. So I would like to thank Dr. Savita, Dr. Kavita and Dr. Charan for their excellent presentation and for a discussion. So moving further, so the next chairperson to for this session will be Dr. Preeti Gholap and Dr. Meghna Chawla. And next session will be nutritional approaches to type 1 diabetes, understanding correction factor and IC ratio. So next.
So I would just like to introduce the chairperson, Dr. Preeti Gholap. She's done her MBBS from KIMS Karad. She's a practicing physician and diabetologist in Pune since 15 years. She's a consultant at Dinanath Mangeshkar Hospital and a co-guide for DNB medicine. But she also has extracurricular interests in singing and acting. So welcome, madam, to our 6th International Summit. And we will look forward to you chairing this next session. I would also invite Dr. Meghna Chawla, who has done her DMB in Pediatrics and fellowship in Pediatric Endocrinology at UK. She's a consultant pediatric and adolescent endocrinologist and diabetologist at Ruby Hall, Pune. She is trained at Royal Manchester Children's Hospital, and she has got several publications in pediatric endocrinology. She has attended several conferences and has international awards in pediatric endocrinology. She's also been awarded the most promising pediatric endocrinologies by Medgate today. She has authored a chapter on abnormalities of stature in a postgraduate textbook of pediatrics by Piyush Gupta. She is also an author for chapter on growth disorders in the e-learning portal of European Society for Pediatric Endocrinology for resource-limited countries, which has been translated into 7 different international languages. She's guided 2 ICMR projects on growth in children. She's also on the editorial board member for European Society of Pediatric Endocrinology. So welcome, madams, and over to you for conducting the next session on type 1 diabetes care, clinical perspectives.
Thank you so much for the kind introduction. Dr. Meghna, should I be talking about Dr. Tejas or next? Yes. Yeah. So I'll introduce Dr. Tejas and next session, you please. Yes. So good afternoon, everyone. I'll be introducing Dr. Tejas Limaye, who is MSc PhD in Health Sciences and a registered dietitian. She's a certified diabetes educator, and right now she's consultant nutritionist, Joint Secretary Pune Chapter IDA. She's affiliated to Diabetes Unit KEM Hospital, Aditya Birla Memorial Hospital, Chinswad, Just for Hearts, Pune, HP MDI HPCL Management Institute, Nigdi, Pune, B Fitness Center, Nigdi, Pune. Her achievements are, she's a first rank holder of Savitribai Phule University, recipient of Inspire Fellowship DST, and total 9 papers published in international and national reviewed journals. So over to you, Dr. Tejas.
Thank you, ma'am. I think my session is pre-recorded, so I'll be available for the question and answers after the session.
Okay.
Everyone, I'm Dr. Tejas Limaye, and today we'll be talking about nutritional approaches to type 1 diabetes. Basically, we are going to see different ratios which are used for insulin dose adjustment. As we all know, type 1 diabetes is quite different from type 2 diabetes. So type 1 diabetes, there is absolute deficiency of insulin, and the onset is generally in the childhood. So mostly these kids are on insulin, and multiple daily injections are generally prescribed to them. As they are on insulin, the diet can be a little liberal for them, unlike type 2. And considering that they are kids, they are still growing, their development is ongoing, we need not restrict some specific nutrients in their diet as such, but any home-based food, homemade food is good for them. But if kids are planning to have such liberal approach when it comes to diet, then yes, definitely a technique called as carbohydrate counting and dose adjustment comes to rescue when a kid can eat whatever he likes, but still he can keep his sugar levels under control. That approach is called as DAPNE, dose adjustment for normal eating. And this approach has been quite popular since the observations and results of DCCT, Diabetes Complication Control Trial, they have come out. So that trial has shown that DAPNE approach helps to lead as normal life as possible, and it helps to maintain blood glucose levels within a healthy range. Okay, it also reduces the risk of long-term complications, including long-term complications of hyperglycemia as well as short-term complications of hypoglycemia. So with the DAPNE approach, one can definitely manage sugars quite well despite of eating normal regular food prepared at home. Okay, so basically now we are talking about dose adjustment, and it has two different dimensions. So when you want to adjust insulin dose prior to a particular meal, you need to consider two things. First is the pre-meal sugar, and second is the food, because both are going to affect the post-meal sugar levels. So if you consider pre-meal sugar level and if it is already high or already low, then you need to use one ratio called as IS ratio or insulin sensitivity ratio, which is also called as correction factor. And if you are going to consider food after considering pre-meal sugar, at that time you need to have another ratio called as IC ratio or insulin to carb ratio. So in this session today, we are going to talk about these two ratios in details, and we'll be taking many examples so that you will be quite well versed with these ratios. So first is IS ratio. IS ratio is the dose of insulin required to bring down a high blood glucose level to desired target range. Okay, there is a specific formula for it, and the formula is based on the type of insulin the person is using. So commonly there are two types of bolus insulins used in case of type 1 diabetes. One type is short-acting insulin, which is also called as regular insulin or R insulin, and it acts, starts acting within 30 to 40 minutes of insulin injection and lasts till around 4 to 5 hours. There is another insulin called as rapid-acting insulin, which is also commonly used nowadays. That is also called as analog insulin, and it is commonly used in kids. So those who eat very little quantity of food, or those who cannot wait for 30-40 minutes after taking insulin shot, they need to eat immediately. For them, such rapid acting analogs are used. They have quite rapid action. So they start acting within 10 to 15 minutes of injection, and they last for only 3 hours after the injection. So for these two different insulins, the IS ratio is different. For short-acting insulin, the ratio is calculated as 1500 divided by total daily dose, which is called as TDD. And for rapid-acting insulin analogs, it is 1800 by total daily dose. So we'll see one example. I'm taking this example for short-acting insulin. So if somebody is on insulin like Actrapid or Insugen R, so for such insulin, this ratio is used. First of all, we need to calculate total daily dose. So total daily dose is addition of all insulin dosages in a day, including basal insulin. So if, for example, somebody has this insulin regime, like 4 units of short-acting insulin before every meal and 13 units of basal insulin, then we add up everything to calculate TDD. that becomes around 25. So 4 plus 4 plus 4 plus 13 is total 25 minutes of TDD is he is taking. And the IS ratio will be calculated as 1500 by total daily dose, that is 25, and the ratio will be around 60. Okay. Now let's see how to use this ratio. So there will be three situations. If you check pre-meal sugar level, there can be three possibilities. First possibility is the pre-meal sugar is low. For example, if it is low and if it is 60, then you need to first check how far is it from your target sugar. So target sugar we generally consider 150 as a golden figure, but targets can be different and you can individualize the targets. In this case, I have taken 150 as a target and sugar was 60. So it was less by 90 or low by 90 compared to his target. Okay. So how to use the IS ratio? You need to just divide this difference between target sugar and actual sugar by your IS ratio. So difference was minus 90. I divided minus 90 by 60, which is IS ratio, and I got my correction factor as minus 1.5 units. So whatever the meal insulin is, you need to subtract 1.5 units from that insulin. In this case, for example, this person was taking 4 units before every meal. So for this particular meal where the pre-meal sugar was just 60, he need to subtract 1.5 units from his meal insulin, that is 4 units. So basically he needs to take 2.5 units for that particular meal when the sugar is low. When the sugar is in the normal range, so somewhere around 150, so might be from 120 to 160, 180. If the sugar is in good range, then may not use the IS ratio and correction factor may not be required because sugar is just near to the target. There is third possibility where the sugar can be high. And when sugar levels are high, for example, if the sugar is somewhere around 330, the difference will be 330 minus 150. 150 was your target. So difference is around plus 180. So extra 180 sugar. And that can be managed by excess of insulin, extra insulin dose. And extra insulin dose can be the difference divided by IS ratio, 180 by 60, that is plus 3 units. So if the person is taking 4 units for the meal and pre-meal sugar is 330, he needs to take 4 units plus 3, that is equal to 7 units for that particular meal. So that means the pre-meal sugar is very important when meal insulin dose is calculated. Now let's go to the second ratio. I hope this IS ratio is now quite clear to all of you. Second is IC ratio, where we are now going to consider the food the person is going to eat in a particular meal. And as you all know, our food has got different components, but food is a major factor which affects blood glucose levels after eating particular food. So there are a whole lot of other factors like activity hormones, stress, medications, illness, but food, whatever food person eats, most of it is converted to glucose at the end of digestion, and that reflects into blood sugar. So that is why we are going to count for food. And when we count for food, we just saw we need IC ratio, insulin to carb ratio. So why are we just looking at carbs and why not other nutrients in the food? We all know that food has 3 macronutrients, carbohydrates, proteins, and fats. But why carbs alone when it comes to insulin dose? Yes, the answer is carbs are converted to glucose faster than fats and proteins. So to count for carbs, you need to have different techniques. But yes, carbs are covered by the bolus dose of insulin, whereas proteins and fats can be covered by basal insulin dose. And whatever bolus you are going to take, that can be calculated using IC ratio. So carbohydrate counting is there around, has been around since 1920s. But previously it was used as a means of restricting carbs intake to match fixed insulin dosages. So previously specific fixed insulin dose was given to patients, which was quite rigid to follow, but still to suit that insulin dose, carbohydrates were counted and particular carbohydrate containing food was offered to the patients to manage the blood sugar levels well. But as we saw before, since DCCT trial results, now we are using DAPHNE approach, which is dose adjustment for normal eating. So just the opposite of previous method. Like right now, the person or the patient is allowed to eat particular food, or the homemade food, the food he likes, or the food the family eats, and according to that, the insulin dose is adjusted. Now, this DAPHNE approach, or carbohydrate counting method, is best suited for MDI, which is also known as basal bolus regime, where there is one basal insulin acting at background, and the bolus dose is taken before every meal. Okay, so here we can count carbs in every meal and adjust the bolus insulin according to the carb content, which will reflect in good blood sugar levels post-meal. So those patients who are on mixed insulins, like mixed-ARD or pre-mixed insulins, for them, this carbohydrate counting and insulin dose adjustment may not work because they are already on mixture of two different insulins. So if you try to adjust one insulin, the other gets adjusted automatically. And it may result in hypo or hyperglycemia unnecessarily. So this IC ratio and carbohydrate counting practice is best suited for MDI. So as we know, MDI has basal at background. The basal should be right first. So first you need to adjust basal, and if the basal is correct, you can then go for adjusting the bolus dose. Now, carbohydrate counting is quite simple if you know the basics right. Okay. So it has two main components: estimating carb content of the food and then adjusting the insulin dose to match the amount of carbs in the meal. So step one is know the sources of carbs. So if you want to count the carbs, first of all, you should know the sources of carbs, or which foods will give you the carbs. So for example, all fruits, dry fruits, juices are going to give you carbs. All cereals and their products are rich sources of carbohydrates. Pulses, beans, lentils, dals are all, they are considered as protein-rich foods, but still they will contain carbohydrates. All roots and tubers are quite heavy in carbs. Milk and milk products, we all know milk contains a sugar called lactose. So milk and milk products will have carbohydrates. All sweets where sugar, jaggery, honey are used are all carbohydrate containing foods, and sweets will have other ingredients like maida, like besan, which will have carbohydrates additionally. So all sweets are quite rich in carbohydrates. There are very few exceptions, like some foods you can consider that they are almost carb free, and you can skip them while you count the carbohydrates in a meal. So those foods are all non-vegetarian foods like egg, fish, chicken, mutton. All nuts and oil seeds can be considered carb free, and lastly, all salads can be considered carb-free and can be skipped. But salads without salad dressings, obviously, these are the exceptions for carb counting. But other foods need to be accounted for when it comes to carbohydrate counting. Let's now go to the next step, where you have to estimate the content of carb. Now we know which foods will give you carbs. Now let's move to how to estimate or how to count for the carbs in a particular meal. So there are different techniques, but there are some problems in India. That in India, over 70% of the meal is carbs. So if you look at the plate, mostly all foods will contain a lot of carbs, and all carb-rich foods we are eating. Secondly, serving size is non-consistent. So if you take one roti can be containing 10 grams of carbs as well as 40 grams of carbs, depending on size and thickness. So serving size is non-consistent. Even size of a katori, size of a bowl, size of a spoon, it varies quite a lot from home to home. So that is one of the problems in giving standardized list to the patients for carbohydrate counting. Thirdly, carbohydrate content of many ready-to-eat foods is not known. Many packaged foods in India still, they do not contain food labels, and those are eaten quite commonly, and the carbohydrate estimation is not possible in such case. Also, there is no precise food labeling. In many cases, there are food labels, but food labels may not be precise. They are not adhering the criteria or the recommendation suggested by FSSAI or FDA. So again, even if you count for carbohydrates depending on the food labels, it may not be correct every time if the food label is not done correctly. But there are still some methods which will help you to overcome the problems and estimate carbohydrates. So there are rough estimates of portion, like your palm can be a good way to estimate. So fist size, palm size, thumb size, finger size. So there are different ways to, have rough estimates of portions. Then carbohydrate counting tables, books or lists are available. Measuring cups and spoons are available. You can use them while educating the patients. Reading food labels and teaching the patients to read the food labels is again a very important phenomenon in carbohydrate counting. And there are now precise weighing scales available. So on those scales, you can predefine or feed the carbohydrate content of a particular food in given quantity, and the scale just weighs the food and then gives you the carbohydrate content of that particular weight of the food. So those scales are also available nowadays. So once you estimate the carbs, now you have to calculate the insulin dose required to cover those carbs. So that's next step, and where IC ratio comes to your rescue. So IC ratio is insulin to carbohydrate ratio, where the number of carbohydrate grams covered by 1 unit of insulin is calculated. And again, there is another formula to do it. So there is a constant 500, and this constant can again be different for kids and adults. For kids, it's generally taken as 400 or even less than that sometimes. But let's consider this 500 formula. So 500 by total daily dose. And here again, you have to consider all sort of types of insulin while calculating TDD. Same example I have taken so that it will be quite comfortable for all of you to understand. So here TDD is 25 and IC ratio is calculated as 500 by 25. That's somewhere around 20. So that means if a person is going to take 20 grams of carbohydrates, he will need 1 unit of insulin to cover those carbohydrates. Okay. So with this, we'll give some more example. So for example, if the person is going to take this kind of a meal, let's say breakfast. So in breakfast, if he is going to eat 2 idlis, 1 katori sambar and 1 apple, then how many units of insulin he will require for this meal? So for that, you need to first count the carbs in a particular meal, just add them up. So the person is taking around 60 grams of carbs. Then divide the number of carbs the person is taking by IC ratio, which was 20. So for this particular meal, this person will require 3 units of insulin. Got it? It's quite easy. Then step 4 is consider pre-meal sugar. Now we are going to see the combination of IS and IC ratio. Now we know that to cover the carbs, you need IC ratio, but to consider pre-meal sugar level, you need IS ratio. So how to use them together? So for example, I'm giving the same meal and the sugar is 150, pre-meal sugar. So target BSL was 150, pre-meal sugar level is 150, current sugar. So the required dose will not change because the sugar is in the target zone, and whatever insulin is required to cover this meal should be taken if the sugar is in good range. So 3 units will be same. What if the sugar is high? So again, same example I've taken. If the before meal sugar or pre-meal sugar is 330, which is hyperglycemia. The target was 150 and the difference was 180 plus 180. So 3 units for the meal, but this excess of sugar should be covered by 3 units extra for the meal. So which was calculated by dividing the extra sugar by IS ratio, and the required dose will be 3 units for the meal plus 3 units for the extra sugar, which will be around 6 units total. Okay. So irrespective of the same meal, the person will need different insulin dose based on pre-meal blood sugar. Let's take another example. Again, similar blood sugar I have taken. So if the person faces hypoglycemia or low blood sugar level, meal insulin is 3 units. But if the sugar is already low, the person will require less insulin. Again, subtract from target, and then you will see difference should be divided by IS ratio. So minus 1.5 units is the correction factor, and required dose will be 3 units for the meal minus 1.5 for low sugar. So total will be around 1.5 units of insulin for the particular meal when the blood sugar is low. I hope it's quite clear. I'm taking just one more case for all of you. So case 2 is again another example I've given. So the insulin regime is 10 units before breakfast, 15 units before lunch, 5 units before dinner, and 20 units basal. So total daily dose will be 50 units. You have to add up all together and then calculate IC and IS. So IC will be 500 by 50. So 10. So to cover 10 gram carbs, this person will need 1 unit of insulin, and IS ratio is 1500 divided by 50 units, so around 30. So that means if sugar is excess by 30 or extra by 30, the person will require 1 unit extra insulin. Okay. So now see what.
Hello. We were exceeding the time limit, so we have stopped.
Thank you very much, Dr. Tejas, for the excellent talk. And now we proceed to another important clinical aspect in management of type 1 diabetes, that is physical activity. And to enlighten us on this topic, may I welcome Ms. Nupur Lalwani, please.
Thank you, Dr. Chawla. Thank you.
My pleasure.
Everyone, thank you for having me here today. My name is Nupur Lalwani. I live with type 1 diabetes. I've had it for the past 26 years. I'm also a certified diabetes educator, and I'm the founder at Blue Circle Diabetes Foundation, which is a non-profit and support group for people with all types of diabetes. I'm very grateful to Dr. Unikrishnan and the entire team at Chelaram, for organizing this and for involving communities and people with diabetes in these important and very relevant discussions and forums. So today I'm going to talk about physical activity in type 1 diabetes. This is quite an interesting topic, especially because I greatly enjoy sport, and I also happen to be a person living with type 1 diabetes. So what you see on the screen right now is the photo of a young girl who lives with type 1 diabetes and recently won a gold medal at a Taekwondo championship. I want to begin this presentation with a really positive note and a hope that people with type 1 diabetes can and must exercise. Of course, we know how important exercise is for everyone. It's especially important for people with diabetes, but I think more than that, it's about doing something you love and being able to achieve things that, maybe you sort of doubted yourself, or maybe you considered that your condition would come in the way. But here's proof, and there are lots of people like this little girl here who are absolutely, smashing their goals, exercising and having a brilliant, life, managing their sugars. It is a challenge, no doubt, but we can do it. So to the next obvious question, can people with type 1 diabetes exercise? And the answer, of course, is a resounding yes. And why not? I mean, exercise, like, we all know, is excellent for everyone. And I think with the support and care and encouragement that our medical teams provide, that our family and friends provide us, we definitely can exercise. Not just that, we can
like you saw in the picture before this one, like little Ovi, you can go around winning medals, you can absolutely smash your goals, achieve your targets, have a lot of fun. Doesn't that sound like something everyone would want to do? So I think the first thing is that, and I say this to a lot of people, the first step is the toughest. You know, it's difficult to take the first step and to begin exercising if a person with type 1 diabetes doesn't already have a regime of exercise. So that is hard, and it's also tough for families and medical teams to encourage these people, because like we all know, type 1 diabetes and exercise can sometimes come with its own host of challenges. So it's difficult, no doubt, but the rewards are worth it. And like you see in this picture right here, this is a picture from last year's IDS Run 2021. If you've been following all the activity that's been going on the social media platforms of Chelaram Hospital as well as Blue Circle Diabetes Foundation, you would know that we have since 2020 we've been working together on doing a virtual run for diabetes, and in the year 2020 we actually had a physical run, which was an incredible amount of fun. And in the next 2 years after that have been virtual runs. So last year was the first virtual run, and this year again is going to be the second virtual run that we are organizing. The toughest thing is really waking up and showing up. Beyond that, everything else can be handled, everything else can be tweaked and modified to suit the lifestyle of the person living with diabetes as well as their family. Exercise, by all means, is the way to go, and it's something that we all need to incorporate in our lives. So a little bit of positive reinforcement really goes a long way. I mean, and I say this from my own personal experience. So I'm a person that has run a lot of marathons. So, typically these days there are a lot of running events, but back when I started about 10 or 12 years ago, the Mumbai Marathon was an annual event that would happen in Mumbai, of course, and it used to be called the Standard Chartered Marathon at that point. It's now called the Tata Mumbai Marathon. And I was always fascinated by running it. And what helped in my case was my own family. My father is a runner as well. So long story short, I've done a bunch of full marathons, and full marathons are 42-kilometer long runs. So you're spending a good chunk of your day on the road with your type 1 diabetes, with yourself, and with thousands of other people. Sounds like a recipe for disaster? It could be. And I want to tell you quickly about how the first time I wanted to run, and I hadn't attempted even a half marathon, that's a 21-kilometer distance. I once spoke to someone, and they told me, why do you want to run? I mean, isn't it just safer if you don't run? Now, as medical teams and as professionals, I think what people with diabetes really need is the support and the positivity that, the reassurance that everything is going to be okay if you take care of your sugars, if you take care of your exercise, your nutrition. You're going to be fine. There isn't going to be a problem. Please go ahead and enjoy yourself and exercise. The goal is to make it a fun activity. Okay, last point there is terms and conditions apply. And of course, we know there are a ton of riders, a ton of things that could go wrong, but don't let that deter you from encouraging your patients or people with diabetes to really go out there and exercise and have a healthy lifestyle overall. So again, now stating the obvious a little bit, but the benefits of exercise are well established, and I don't really need to list them down. We all already know what kind of benefits exercise brings with it. And you see that in the happy smiling faces. So here is a snapshot from the physical run that we did at the at the conference in 2020 at the IDS, and it was incredible. The children, the adults, everybody was so happy. You can just see that that runner's high, or that the surge of endorphins. It's incredible. Apart from this, of course, there are so many physical benefits as well. I mean, there's you're looking at your cardiovascular fitness, you're looking at bone health, you're looking at better outcomes, possibly better outcomes in your HbA1c and your blood sugar management if it's balanced correctly with insulin dosing and food. Of course, any kind of exercise can also be a social activity. When people come together now, thanks to the pandemic, we may not be able to do a physical run all the time, but with virtual events coming into the picture, and people, the common thread being that everybody's running for the same cause, the same goal. Now, whether you run, whether you do yoga, whether you swim, whatever it is that really appeals to you, is definitely something that you should do, or you should encourage your patient to look into and explore further. Needless to say, exercise contributes largely to a healthy lifestyle, and I think also to a certain kind of discipline, which is really essential, and which fortunately or unfortunately, people with type 1 diabetes already have. You wake up in the morning, you check your blood sugar, you take your insulin, you have breakfast, your day is already regimented. And it's so much easier for a person with type 1 diabetes to just plug in that little bit of exercise and let it do its magic, right? We already have a fairly disciplined and regimented life, and this just makes it so much better. So those were all the good things and the benefits of exercise, and this is definitely not something that can be covered in one slide. So we are talking now about the variables that complicate exercise in type 1 diabetes management. And it's not limited to just the slide that you see here. It's a lot more. And I think the biggest one is the fear of hypoglycemia. And I know when I say this, because my family, when I started running, had this sort of fear, and I wouldn't call it irrational fear. Of course, the basis of this fear is very valid. And that's the fear that, the doctor, the family, the parents, the spouse, whoever it is, would naturally have. I mean, you don't want to be in a situation where, you're stuck outside and you don't have your glucose on you, and you have maybe a severe hypo. That would really be a really dangerous situation. But for every problem, there is always a solution. So yes, the fear of hypoglycemia exists, and it is this very fear that stops a lot of people from sometimes taking the first step and exercising. But that's like saying that I can't go out because a tree might fall on me. You cannot not exercise. You have to exercise, but you have to be prepared, and you have to know all the things that could go wrong, and you have to sit and counsel the person with diabetes and tell him or tell her or tell their family that, hey, look, you could exercise, but you may have a hypo. You need to have some kind of hypo treat available with you. So as a small example, as I'm talking here today, I also have with me my glucose right here. The reason that I keep this with me all the time is because it's not because I don't trust myself or I don't trust my management. I do. But these are tools that I need with me, So if I'm going out for a walk or if I'm going out for a jog, I would always carry my glucose. It's okay for me to forget my house keys, but I would never forget my glucose. And I wasn't always this way. So, not every patient is going to be extremely, how do you say, compliant at all points in time. And I think I was that person many years ago. I once went out for a run, and of course I went without my glucose. And I was running and I could feel a hypo coming on. So first mistake, no glucose. Second mistake, no glucometer. I didn't have a way to confirm whether I truly had a hypo or not. Third thing, no money, nothing. So I was outside, I was on the road, I could have fallen unconscious and nobody would know that, she's a type 1 diabetic and she's had a hypoglycemia. So this is what really made me understand. Of course, I theoretically knew that it's important to carry a form of ID, it's important to carry glucose and a glucometer, but it's not easy. Exercising for a person without diabetes also is challenging, but exercising for a person with type 1 diabetes has so many variables and so much going on that sometimes we feel, let's just not exercise, and that's very valid as well. So if you know what could go wrong, if you can track something, you can fix it. So now that I know, I cannot be stuck without glucose or without a hypo treat, I don't step out without my, little glucose tablets right here. So that's one. Another thing that happens when you exercise as a person with type 1 diabetes is that you could have a delayed hypo. Now, this is something we learned by experience. Experience, like they say, is the best teacher. So, with the marathons that I would be running, I would be out on the road, pounding the streets at, 5, 6 in the morning. I would be home before noon and, rest the rest of the day. And I would be so tired, I would then really crash very early in the evening. Now, what happens with delayed hypoglycemia is that even if the physical activity has occurred in the morning, you could still have a hypo late into the night. You could have a delayed hypo many, many hours later. And the most dangerous thing, and what really scares medical teams as well as people with diabetes, is the overnight hypo. You'll be so tired running 42 kilometers that you will not wake up when you have a hypo. And that, again, is very valid. So you may need a little bit of dose titration. You may need, to put an alarm and wake up and check your blood sugars. You may use CGMs. There's a lot that can be done there. The second variable that makes exercise pretty complicated is nutrition and hydration. And I say this because I have tried everything in the book. I have tried glucose gels. I have tried, snacking. I have tried not snacking. I have tried adjusting my doses. And that's a lot of experimentation, but you have to find a happy balance of what works for you. So what's worked for me this far is, really not running when I have, or not exercising when I have active insulin in my body. And that's a great tip, which I discovered by accident. So, I use NovoRapid, and typically the action profile of NovoRapid is about 3 to 4 hours. So I wait for my NovoRapid to wear off, and then I exercise. Or I exercise at a point in time where I don't have active NovoRapid or active bolus in my body. Because what happens is, if I do exercise at that point, it really accelerates, a hypoglycemia for me. And I know this is true for a lot of other people with type 1 diabetes as well. Also, really important to hydrate, carry a water bottle or carry whatever works for you, maybe some juice, extremely important. Environmental factors, and of course this affects everyone, but it definitely impacts people with type 1 diabetes a lot more. So any change in the weather, heat, cold, humidity, altitude, everything, every little thing adds up and potentially complicates your type 1 diabetes management when it comes to exercise. And I would like to give you an example. So I was running, an ultra marathon in another state, and the weather was extremely different, and I could see my blood sugars really, wildly fluctuating. So these are things that you learn when you actually step out into the ground and exercise. Okay, very quickly, insulin titration is very important, which is why fixed doses are probably not the best idea. And I speak from my own experience. The person with diabetes needs to have that confidence that they can adjust their doses as required, depending on the exercise, depending on the food. Of course, there's physical and mental stress, needless to say. Any exercise is essentially a change in the regimen. Okay, and I think these things have to be considered when you're starting a new regime. So it takes time to get used to something, but I think in the long run, we all know how beneficial it is. Another variable, this one is for girls and women, of course, the menstrual cycle also really impacts and affects the blood sugar. So this is something that needs to be kept in mind when you're exercising as well. You could also have, while hypoglycemia is a very valid concern, you could also have exercise-induced hyperglycemia. Anaerobic exercise typically causes hyperglycemia, and it is something that you should know before you either weight lift or before you. So I want to share a quick example here. I do mixed martial arts as well, and I would notice my blood sugar spiking without me having eaten anything, without me having done anything except 30 minutes intense martial arts. So these are things that must be kept in mind. Ketones can occur if you exercise at a high blood sugar. That is something that needs to be taught and told to the person with type 1 diabetes. What kind of technology can really ease the lives of families or people living with type 1 diabetes? On the screen right now, you see a rock climbing event that we had conducted 3 years ago. And this little girl right here with the CGM on her arm. Technology has made our lives much easier. Of course, we know there are CGMs, there are insulin pumps, there are even artificial pancreas systems, smartwatches. All of these things go on and help people with diabetes to manage their conditions better and more easily. They make it so much more convenient for us. The challenge, of course, sometimes is being able to integrate all of these things and to be able to see your readings and the impact of your exercise and food and environment and other things on one platform. So that is still something that needs a lot more work. But I'm pretty sure that we will get there soon, and it's going to help us. Here's a picture of a trek, and 3 of us here on the screen wearing insulin pumps, and how people with type 1 diabetes can live normal lives, exercise, do extreme sport, do whatever it is that they would like to do. It's important to make the most of the technology that is already available to us. Having said that, last but not the least, the technology that is available needs to be more accessible for everyone. It's not, we're at a point where it's not open and affordable for everybody who may want to use it. And this is something that needs to change. Along with this, our diabetes education needs to be upgraded and changed, and people need to understand the various options that they have that are available in the market for them. Sometimes wearables come with their own challenge of being visible markers of diabetes, and which is why I've also put in this point about the stigma. So here's another picture. 4 people with type 1 diabetes, the ones in the green t-shirts, walked 100 kilometers at the Oxfam Trail Walker in December 2019. I think this has been a fabulous example of how technology, community, support from medical teams allows people with type 1 diabetes to live up to their potential. And what you see on the screen here is a map with all our blood sugars remotely being relayed to our friends and family. So there's a lot that can be done. You just need to, have belief in yourself, belief in your teams and your support. And people with type 1 diabetes can truly and really achieve anything that they set their heart to. All right, as I wrap up, it's important to know the basics of how diabetes works, to be able to manage it yourself. Look into technology and, let your patients know that these kind of options exist and they may be beneficial for them. For me, I follow low carb, and I find that to be an excellent sort of supporting pillar along with my exercise. Always trust scientific evidence. I think that needs to be reinforced to people living with diabetes as well. Share your experiences, share your best practices, what works for you, what doesn't work for you. Encourage people to be part of a community, to seek out others like them, and do not be afraid to ask questions. With that, I would like to remind everyone to join us for the IDS Run 2022. This is a beautiful picture. It's my favorite picture from our run in 2020. So this was March 2020, and you can see, the team from Chelaram Hospital. You can see Dr. Krishnan there, and all of us living with type 1 diabetes and our caregivers and families and friends. We had a wonderful run together, and we're going to be doing it virtually this time. So you will find the registration link on the social media platforms of Chelaram Hospital as well as Blue Circle Diabetes Foundation. And do register, and we would love to see your pictures. There's also free t-shirts going out. So this is happening on Sunday, the 6th of March at 7 a.m. Thank you once again.
Thanks, Nupur, for sharing some very interesting insights on how you're managing type 1 diabetes. It was really interesting to know some real-time information from a type 1 diabetic itself. And now we move on to the next speaker. May I request Dr. Preeti to please introduce the next speaker, please.
So our next speaker today is Dr. Ganesh Jevlikar. He is MBBS from BJMC Pune. He is MD in Pediatrics from Government Hospital Mumbai. He's a PDCC from Lucknow. He's a senior consultant pediatric and adolescent endocrinology at Max Hospital, and his prime area of interest is type 1 diabetes and disorders of sexual development. And he will be speaking about hypoglycemia and type 1 diabetes today. Over to you, Dr. Ganesh.
Hi, once again, good afternoon to all of you. And this is something which I presented last year also. So I've just kind of, for some of you, it may be a repetition, but I've just tried to introduce one or two new things and just try and explain few fixed things that have been there in our mind. I'll just start sharing my screen. So we all know that hypoglycemia is the most common or acute complication of diabetes therapy, and any person with type 1 diabetes almost experiences about 2 episodes of hypoglycemia in a week on an average. Its significance lies in the fact that not only that it can cause serious symptoms like unconsciousness or seizures. Now, yes, it is known that hypoglycemias can rarely lead to death or dead in bed syndrome, but this is a rare thing. I have seen one case of a type 1 diabetes with kidney dysfunction who had this kind of a problem, but this is a rare thing. This is not common. So we don't need to frighten people with dead in bed syndrome. There is impact on day-to-day. What is more important is the impact on day-to-day energy levels, mood, headaches, body pains. That just makes life miserable on a day-to-day basis. And there's long-term impact that has been shown in studies on brain microanatomy and cognitive function. And of course, that's why it's a barrier to glycemic control, either the person with diabetes or the family members having fear of hypoglycemia. However, with modern technology, it is possible to have good glycemic control without any increase in hypoglycemia. What's important to know is that normally in a person without diabetes, whenever there is a tendency to hypoglycemia, there is suppression of insulin secretion. and activation of counter-regulatory hormones. In a person with type 1 diabetes, both these things are problematic. Because the insulin has been taken exogenously, they are not able to suppress the insulin secretion. And in the initial years of life, there is glucagon secretion in response to the hypoglycemia. However, there is people with type 1 diabetes tend to lose their glucagon responses to hypoglycemia over a period of 5 or 6 years. So if you have a long duration of type 1 diabetes, they may not be able to secrete glucagon in response to hypoglycemia. Historically, we have been it's ingrained in our brain that if we want a good glycemic control, for example, as in DCCT, that we had when the intensive care had good glycemic control and less A1Cs, they had 3-4 times higher risk of moderate to severe hypoglycemia. So therefore, there was a tendency about keeping the blood sugar values high in infants or younger children or those who are having frequent hypoglycemia. However, this is not true anymore. This is the data from an Australasian cohort, basically. Over the decade of 2000 to 2009, there was a clear decline in the rate of hypoglycemia per 100 patient years from about 14, 15 to almost 8 or 9. So there has been a decline in hypoglycemia with improved glycemic control. So the rate peaked in 2001 and then declined to a nadir of 5.8 in about 2006. And A1C of 7% was not associated with high risk of severe hypoglycemia compared to a A1C of 8 or 9%. So just because your A1C is high, it does not mean that you are not getting hypoglycemia. Rather, I have seen that those who have high A1Cs are the ones who also get significant hypoglycemia. So this is very important to be understood. However, in developing countries like ours, the hypoglycemia incidence continues to be high. This is the data from SGPJ, where 257 patients were prospectively enrolled over 2 years. And at least one episode of severe hypoglycemia, which was defined as coma or seizure or inability to assist oneself, had occurred in about 22.8%. And this was maximum in children under 10. And in adolescents, it was about 22%. And in adults, it was about 14.6%. Coma or seizures was seen in 3.9 episodes per 100 patient years. And inability to assist oneself was in about 10 episodes per 100 patient years. Median A1C of those who had severe hypoglycemia versus those who did not have was not different. Therefore, A1C is not a predictor of hypoglycemia. There was no difference between gender, urban or rural patients, and those who were using NPH or glargine as a part of their regimen, or low or high socioeconomic status. So hypoglycemia was equal in all these groups. So what is the definition? There cannot be a single numerical definition of hypoglycemia. So what has been defined is what is called as operational threshold, which means these are the blood glucose values at which point in time you take an action. So the ISPAD defines clinical hypoglycemia alert as a blood glucose value or a capillary glucose value of less than 70. Even for CGM, the value is same. And clinically important or serious hypoglycemia as value of less than 54, which deserves immediate action. Now that we are using increasingly CGM, we should also be familiar with what is the goal of CGM metric regarding hypoglycemia. So we want less than 4% of readings in the range of less than 70 and less than 1% of the readings in, so this is time below range, in time in severe hypoglycemia or less than 54 milligram per deciliter. Severe hypoglycemia is defined as coma or convulsion or significant cognitive impairment without a specific threshold. Now, in children, often an assistance is required. Therefore, when we are defining severe hypoglycemia, careful history may be obtained to really see if the child was obtunded or what was the reason for support. Was it just because the child is a small child and not able to seek the glucose? That kind of support will not classify as severe hypoglycemia. But if there was a change in sensorium, then so the clinician has to take history to really identify episodes of severe hypoglycemia. We are all familiar with symptoms of hypoglycemia, which happens either because of the autonomic system activation or because of neuroglycopenia, which means the interruption of glucose supply or decrease in glucose supply to the brain. So there can be non-specific symptoms in toddlers, such as temper tantrums or unusual behavior, and the counseling has to be therefore age appropriate. And the preceding glycemic control can affect the threshold for development of symptoms. So if one has a poor glycemic control, they may show symptoms of hypoglycemia at relatively higher BG values. And there's something called as impaired awareness of hypoglycemia, where these people do not display the autonomic symptoms because they've been having repeated hypoglycemia. This can be some sort of an adaptation to repeated hypoglycemia, and it's a reversible phenomenon. So basically, impaired awareness of hypoglycemia means lowering of glycemic threshold for the release of counter-regulatory hormones and generation of symptoms. And there is loss of hypoglycemic symptoms and therefore increased risk of severe hypoglycemia. It's more of a habituated response rather than actual autonomic failure, because it is reversible if you avoid hypoglycemia for a period of few weeks. So in all our visits, we should check for impaired awareness of hypoglycemia using some standard questionnaire. This is a Clark hypoglycemia questionnaire, which is applicable for English-speaking individuals. So there's a set of 8 questionnaires, and a score of more than or equal to 4 suggests that the patient has impaired awareness of hypoglycemia. So this should be screened during the clinic visits. Hypoglycemia happens most of the times because of imbalance between insulin and meals, either because the insulin dose is more or wrong type of insulin or delayed meals, skipping of meals, these kind of things. And very commonly, hypoglycemia is also associated with exercise, which Nupur has just nicely elaborated. If somebody is getting recurrent hypoglycemia, we need to think of comorbid conditions like celiac disease, adrenal insufficiency, hypothyroidism, and not uncommonly psychiatric or psychological problems like eating disorders and factitious insulin intake because of several reasons. Now, how do we manage hypoglycemia? If child or if the person is conscious and able to take orally, we confirm hypoglycemia wherever possible and take 0.3 gram per kilo up to a maximum of 15 gram glucose or equivalent amount of rapid acting carb and check glucose in 15 minutes. Repeat the same dose if blood glucose is less than 70. I always make it a point to tell people to buy the green Glucon-D because there's a difference in the composition of the green Glucon-D versus the orange Glucon-D. So the orange Glucon-D, the glucose content is less as compared to the green Glucon-D. Other suitable replacements can be simple table sugar or powdered sugar, honey, or sweetened juice or cold drink. If next meal is not immediately due, this hypoglycemia treatment should be followed with a 15 gram complex carb containing snack, which could be either a bread or makhana or something like that, or milk. There are a few don'ts in hypoglycemia treatment. One is avoiding over-treatment. Invariably, the hypoglycemias are considered as party occasions, and therefore people over-treat them. And avoiding treatment with things that have fat in them. Most commonly biscuits. Biscuits do not give you immediate increase in blood sugars. They cause a very delayed and very high sugars after which lasts for a few hours because they have fat. Anything which has fat like chocolate, ice cream, all our sweets are not suitable for hypoglycemia treatment. And another common mistake that is done is if there is a hypoglycemia pre-meal, people just skip the insulin dose. That is not to be done. If you're going to eat a meal, you need to take adequate dose of insulin to cover that meal. So I always show this slide to my patients that hypoglycemia is not an occasion to celebrate and try and emphasize that you can have sweets without having to have hypoglycemia also. If the person is unconscious, you keep the person in the recovery position. Do not put forcibly anything in mouth. There is a risk of aspiration. Then if the patient is at home, you can give glucagon injection subcutaneously. This will not come overnight practice. So the person has to kind of practice this during the clinic visits about how to, and they have to go through this drill repeatedly so that otherwise in the state of panic, nobody is able to even open that glucagon vial. If it is unavailable, then common practice is to apply a paste of glucose in buccal mucosa. This is an anecdotal practice. There's no study done on that. If there is no improvement, advise them to rush to nearby hospital and administer IV dextrose. In the hospital, the options include IV dextrose or glucagon. You might need glucose infusion for a few hours to maintain the blood glucose. Intranasal glucagon has been approved and is available in developed countries. A dose of 3 milligrams single dose intranasally is effective in hypoglycemic events in children and adolescents. This just reduces the need for subcutaneous recomposition of the glucagon preparation. Another glucagon called as dasiglucagon, which is a human glucagon analog with improved stability, which improves the shelf life of the glucagon, is also approved and is available as a 0.6 milligram ready-to-use pen, and it can be used in children more than 6 years of age and adults with type 1 diabetes. In acute gastroenteritis, there is a risk of hypoglycemia. If vomiting is the only presentation, you need to check for ketones. The thing that has to be done here is that insulin should not be stopped altogether because there will be a risk of diabetic ketoacidosis. So the blood glucose need to be maintained either by regular carb intake, or if the glucose are still low, then you can give mini dose glucagon given with a U100 insulin syringe. The dose is under 2 years, 2 units, 3 to 15 years, 1 unit per year. For example, 10 units for 10 years of age, and more than 15 years, 15 units. That's the maximum dose to be. Nupur has highlighted the importance of nocturnal hypoglycemia, which is seen in nearly a quarter of people with type 1 diabetes. And a lot of time it goes undetected. So it should be suspected if you're waking up with headaches or altered mood or lethargy, or you are having nightmares, seizures, confusion state during the night, and Smbg phenomenon, which is hypoglycemia followed by morning hyperglycemia. Treatment includes reduction of insulin doses, either the basal bolus or in pump therapy. And sometimes with conventional insulin, you may need additional bedtime snack to prevent a hypoglycemia. Hypoglycemia can be prevented mainly by educating people about hypoglycemia, recognition of symptoms, testing more often, using sensor or closed loop insulin pump therapy can be useful by the low glucose suspend feature, and exercise planning. I'm not going to reiterate what has been already said by Nupur with regards to exercise-induced hypoglycemia. But keeping blood sugars high is not a good strategy to prevent hypoglycemia, and this has to be emphasized to parents. I'll skip this slide in the interest of time and come to the use of technology. Now, this is the effect of CGM in adults with type 1 diabetes, a randomized controlled trial published in JAMA in 2020, where 203 adults at least 60 years of age with type 1 diabetes were selected and randomly assigned to use CGM and standard blood glucose monitoring. And it was seen that median glucose time with glucose levels of less than 70 was 5.1% at baseline and 2.7% during follow-up in the CGM group. So it had declined significantly. You can see in this graph, the blue line represents the CGM group and the orange line represents the standard blood glucose monitoring group. And at all times, the hypoglycemia frequency is less in the CGM group. This just highlights the importance of CGM in prevention of hypoglycemia and management of hypoglycemia also. Also, now the hybrid closed loop pump therapy is available in India, and we are going to listen about it tomorrow. It is being shown to be safe and effective in people with type 1 who have moderate or high risk of hypoglycemia. In this study, which was published in Diabetes Technology Therapeutics, 44 subjects with type 1 diabetes who had increased risk of hypoglycemia confirmed by 1 week of blinded CGM were randomized to 4 weeks of home use of either hybrid closed loop therapy or sensor augmented pump therapy. And the primary outcome was the risk of hypoglycemia as measured by the low blood glucose index or CGM based time in ranges. And there was a significant decline in low blood glucose index on hybrid closed loop therapy. And percentage time spent below 70 milligram per deciliter was also significantly less. So to end my talk, I would say that we have to encourage people to have good glycemic control without having a fear of hypoglycemia. We can use technology in terms of CGM or pumps. It is useful to improve control without increasing hypoglycemia. And most of the times, hypoglycemia is a result of mismatch between insulin and food. And therefore, inquiry about hypoglycemia in all visits, hypoglycemia awareness, etc., should be done in all clinic visits. Treatment of hypoglycemia is done by oral glucose mainly, first choice. Sucrose can be the second choice. And glucagon should be made available to all people with diabetes at home so that it can be used during unconsciousness or seizure. Thank you.
Thank you, Dr. Ganesh Devarikar, for the excellent talk and especially highlighting some very important practical aspects in management of hypoglycemia. I'm sure each one of us who's heard this lecture will go back very well informed of how to manage all kinds of permutations and combinations if any child with type 1 diabetes comes to us with hypoglycemia. Thanks again, Dr. Ganesh, and it was a great talk. And now may I please welcome Jaz Sethi, who is also a type 1 diabetic, for is talking to us on closing the loop in type 1 diabetes. Over to you. Jaz Sethi is the founder and director of the Diabetes Foundation, a global movement to make those with type 1 diabetes feel heard, understood, supported, and celebrated, with a dedicated YouTube channel, monthly meetups, awareness tours, education programs, advocacy drive, and several other creative projects. She was diagnosed with type 1 diabetes when she was 13, and she's currently on pump, CGM, and DIY loop. She also lives with diabetes insipidus. Despite all this, she is IDF's Young Leader of Diabetes for Southeast Asia for 2019 to 2022 term, representing India. The Diabetes Foundation works closely with Diabetes India, RSSDI, and NHS England for developing projects and publications. Jaz is also a certified diabetes educator and did her training with the IDF program. A warm welcome to you, Jaz.
Thank you. Thank you so much. And a big thank you to Dr. Unnikrishnan and the entire committee for the invite. And today I'm going to be speaking about closing the loop in type 1 diabetes. And without further ado, I will share my screen. So I hope you can see my screen. Right. So we're going to be talking about looping 101, and I'm going to go a little bit into the specifications of the nuts and bolts of DIY loop. So what is the current scenario? Like Dr. Ganesh also mentioned, and with type 1 diabetes, we do have a lot of things to take care about. Like we have the pricks and the shots and the highs and the lows and the ups and the downs. And oftentimes I find in the general scenario that we need to fit type 1 diabetes into our schedule, you know, and we need to fit our life around type 1 diabetes. So we need to wake up at a particular time because we know that, you know, the basal will shift, or we need to eat at the correct time because we know that the insulin needs to go in. So what if we had a system that made type 1 diabetes fit into our schedule and not the other way around? So for me, this is the best case scenario, that you continue living your life like you used to, and type 1 diabetes just gets added into our life. And that is the hope and dream. This was made possible with the DIY APS. And what it stands for is do it yourself artificial pancreas system. And truly for me, I believe that it is the future of type 1 diabetes management. And I'm going to be delving a little bit into the nuts and bolts, the hows of this entire system, and how it has personally changed my life living with type 1 diabetes, because I currently am on a DIY APS system. So what are the components of a DIY system, right? What you do need for this is a CGM, so a continuous glucose monitor, or you could also use an FGM with the transmitter so that it becomes a CGM. You require an insulin pump. You require a smartphone, because your smartphone becomes the host. from which you control your pump, you see the app, you make your modifications all from that smartphone, of course, a compatible one, and you need a hardware. So it's a third-party radio frequency hardware which makes the pump and the CGM talk to each other. So in effect, and if I have to very simply put it, a DIY loop system hacks into your pump and your CGM. It makes them talk to each other, and it makes a magical sort of management for those with type 1. So how does the system work, right? The system makes recommendations and takes action to adjust insulin delivery based on the numbers and the models. So what it does is, so if you are going low, the insulin will suspend. If you are going high, it will add on a temporary basal that is going to be higher, depending on all the settings you feed it in, which is things like your insulin sensitivity factor, your insulin to carb ratio, your suspend threshold, which is basically under what value do you want the insulin to suspend. And what it does is, which is very true and unique to the DIY system, is that it makes these decisions based on predicted values and not when you're actually lower there. So that is what the true uniqueness of this DIY system is. So there are two options and two modes with any DIY system. One is called an open loop mode and one is called a closed loop mode. So the open loop is for people who are a little bit more reserved and are not too sure about how the system works. So an open loop, what it does is that before making a decision for you, it will ask you, it will send you a notification, and you can just either say confirm or decline. So what this does is it gives you a chance to understand the nuances of the system. Me personally, when I started, I was like, I believe this system, I trust it fully. I directly went for the closed loop. That is that the system will make decisions without you even knowing most of the time, but it will keep you in range. So this entire sort of, if I have to give you a little history of this entire system, it is a patient-driven movement. It's called the We Are Not Waiting movement. What happened was a couple of years ago, people with type 1, their parents who were engineers, got a little tired of waiting for industry to roll in with approved systems. So they said that, you know, we're going to go ahead and build it ourselves. And the We Are Not Waiting system actually then pushed industry to roll out newer technology faster. So it's truly DIY in nature. There are different options with varied complexities. So there's something called an open APS, which you need to actually make a rig, and you need to fit it in with a Raspberry Pi system, with a battery, with a motherboard, and it works with legacy Medtronic pumps and any CGM. And it can be also set up using any type of computer. We have something called the Android APS, which only works on Android phones. And it works with Dana pumps, it works with the Roche pumps, it works with legacy Medtronic pumps, as well as the Riley Link and Omnipod EDOS. And then you have the Loop, which is a simpler model. It's the one that I use. It's an Apple-only framework that works with legacy Medtronic pumps, Omnipod, Dexcom CGM, some of the Medtronic sensors, or Libre. What you require as the hardware for that is something called a Riley Link, and this is what's in my hand. This is available. So you don't need to build the rig. It comes available, and you just need to code it in. So just to give you a little bit brief about the Open APS, was set up by Dana Lewis and Ben West and Scott Librand, and they support multiple different Medtronic pumps. You would require any computer to set it up. Now, all of these systems, right, you need to build your own app. Since it is DIY, you can't go to the App Store or the Play Store and download this app. You need to actually code it in. It's not that difficult because there's a lot of documentation on GitHubs for this code. So that's with the Open APS. With the Android APS, again, you require any computer, you require Android Studio, and you build your entire app and algorithm through that. And finally, you have Loop, which is the one that I have. You need a Mac with Xcode. And to run Loop, you require Riley Link, an iPhone, a CGM, a Medtronic pump, and it also has an option for an Apple Watch. So I'm going to take you now a little bit personal into what I did personally to get my loop system. So the inputs from the user, that is the settings that we need to feed in manually, are things like ISF, ICR, suspend threshold, override settings, which are basically that for certain types of activities or certain types of scenarios, what kind of an insulin model do you require? So for example, because I'm a dancer, I have a different override setting for my dance. So I require X amount of percentage of less insulin. I shift my target range to be higher. I have an override for very long international flights because I tend to go low on international flights. Insulin model. So are you using a rapid acting model? Are you using a FIAS? So there are different insulin models that the system then uses to calculate your eventualities. And of course, a target range, which is very, very modifiable. So you can have several different target ranges in the day itself. So for my nighttime target range is different. My morning is different because I do go through dawn. My afternoon is different. So according to my day, I customize this for that. And then once you've set in all this, your app is made, your app is on your phone, you have all the systems, the magic begins. And the basal rates start to change every time the system loops. And it's literally quite instantaneous. So the moment everything is sorted, you press go, you see that the system is working like your artificial pancreas. So this is what my personal DIY system looks like. So on the phone, you have your Loop app. My Dexcom is my CGM, my Omnipod is my pump, and the Riley Link is my hardware. So this is what an artificial pancreas system looks like for me personally. For people who use Medtronic pumps, instead of the Omni, there would be a Medtronic. Instead of a Dexcom, there would be a Libre. You would still have a third-party rig, and you would have your phone working like your host. This is a little bit of a screenshot from my dashboard of my app. This is a screenshot from my app. The dotted lines are the values it takes from the CGM, and the dashed lines are predicted values. These predicted values are calculated based on your carb value that you've added on, depending on your algorithm, your ISF, your ICR, how much insulin you have taken, and accordingly it predicts. If you can see on the left-hand side, the screenshot is my insulin history. So you can see that every 5 minutes, my temporary basal changes because it is fighting to keep me in range and working to give me the best possible outcome. So this is a screenshot of how the system actually works. The green loop that you see on the top left corner, that just shows that everything is in range, everything is working, and it is looping. So the impact, right? If I have to get into it, quality of life. I know we spoke about nocturnal hypos, and I was someone who used to go through several nocturnal hypos. So better sleep and decreased nocturnal hypos. Reduced hypos in general. So reduced hypos give you less hypoanxiety. It gives you less severe hypos. I have passed out. I have become unconscious due to a hypo once in the past, which really gave me a lot of anxiety. But with the loop, that's completely gone. It's reduced I don't like using this word, but reduce the burden of type 1 diabetes. So like I said, the APS keeps up with my timetable. And let me give you an example of this. So I used to have the pump and the CGM before as well, without the loop system. And my basal rate from 0.7 used to become 1.4 at 10 a.m. or 8 a.m. in the morning, because that's when I had to get up. Now, let's say that I would want to sleep in one day. I want to wake up at 10 o'clock instead of 8 o'clock. I will get a hypo because I haven't eaten, but my basal rate has shifted. Now I can sleep until 1 and the loop will figure out that, hey, the basal rate needs to not change and give me a temporary basal or suspend my basal so that I don't get hypo. So it truly fits into the person's timetable. And finally, clinical impact. After I started looping, my A1C went from 7.9 to 5.7 in 10 months without severe hypoglycemic episodes. My time in range went from 67% to 93%. And this is taken from my Dexcom Clarity app. So the impact on quality of life and on the clinical aspect of it is both amazing. I'm going to show you some of my graphs now. So this was a typical graph in the day of me before I started looping. Of course, every day was not like this, but I used to, on a very constant and regular basis, have peaking highs and crashing lows. I was time in range at some points of the day, but this is more or less what my life used to look like. After I started looping, this is what my graphs look like. These are taken on different days with different timings. As you can see, it's pretty flat. Of course, this is not every day. I'm still type 1 diabetic. I still get some highs and lows, but 80 to 90% of the time, this is what my graphs look like. The next screenshot I'm going to show you is actually one of my favorite screenshots, and that is the day I began looping. And when I was talking about the instantaneousness of the system, you'll understand what I was saying. So this is the day I began looping. And you can see that immediately, I started looping at 11 p.m. And from there, you can see that it is absolutely flat because the system is fighting to keep me in range. Amazing screenshot, right? I should actually sell this like an NFT or something. I really think that it'll work. So just to sum up and give you a bit, some of the pros and cons, right? Pros for me, genuinely, it's a technological marvel. You can bolus from your phone and your watch, depending on the system you are in. Basal modification, time and range drastically increases. Override settings are great. It adapts rapidly. Since it is not FDA approved yet, this system, it's like an iPhone update that you would have. So as the community gets together and builds more, you can constantly adapt your system and upgrade it. It's by the patient. So there's a user-centric design element, which I truly believe is the essence and crux of the success of the system. And like I said, there's an open loop option for those who are not directly wanting to jump into closed loop. Some of the cons, of course, DIY means that you have to build it yourself. So if you're not too technologically sound, it may be a little difficult for you, but it's not rocket science for sure. It's not FDA approved yet, like I said. Tech trouble at times, it's not a cure. So as much as we would like to believe that, you still need to bolus, you still need to carb count, all that still needs to happen. Red loop at times, which means that your phone, your hardware, and yourself needs to all be in the same vicinity. So you need to make sure that you're all together, otherwise it will lose communication. And there's no helpline, but there is a very active social media group that can answer your questions. I feel like actually they're better than a helpline at times because there's so many people there, there's always some response that you can get. So the nuts and bolts, what do you really need to think about if you want to delve into the system? One, and the most important, is what can you get your hands on? So there's a lot to do with procurement over here. So if you have an Android phone, you would require a certain kind of a pump, you would require a certain kind of a CGM. So the main thing is, what can you get your hands on? You should work with that. How much customization do you fancy? So the Android API system can actually customize a lot more than the loop can. For example, I was not too much for the customization. I'm very happy with how much customization I can do with this system. But if you're someone who really wants to fine-tune every single thing, I would suggest an Android and not a loop. Understand the safety. It's not FDA approved, but yes, if you mess up your ISF or your ICRs, you could potentially get a very bad hypo or a very bad hypo. So be very cautious and careful before starting the system. Understand the form, function, and interaction that you want, and do a lot of research before starting. There's amazing documentation, amazing videos up there. Diabetes has done a couple of videos on looping. So do your due diligence before starting. This is some of just the compatibility and options for these systems. There's an open APS loop and Android APS. A really good friend of mine, Tim Street, who runs diabetic.com, has done a great documentation on the comparing and contrasting of it. So it's something that you can look at if you are interested. We also did a paper that we published on my entire experience of DIY. So if you are interested, you can have a look at that as well. And lastly, if DIY is not for you, be patient because the future is very bright. As we said, the 780G has come out. The Omnipod 5, which is known as the Omnipod Horizon, has been FDA approved very recently. The Tandem Control IQ and the MiniMed 670 are already approved. So be patient because these kind of completely customizable closed loop systems are on the way. I will, however, maintain that the amount of customization you can get in a DIY system will always be more than an FDA-approved version just because of patient safety, which is neither wrong nor right. It just depends on what you prefer for yourself. So yeah, be patient because the future is very bright. And I truly believe that if this system is made accessible for everyone, this is the future of type 1 diabetes management. So the loop does not sleep so that people with diabetes can. It is a part of the We Are Not Waiting movement. It has truly changed my life. And I do hope that this technology becomes commonplace in the future. Thank you so much.
Thanks, Jazz, on these interesting aspects on technological advancements. We all learned a lot from your talk as well. So over to Dr. Preeti, please.
So now I invite Dr. Unni sir and all the speakers for panel discussion.
You can start your panel discussion. I think you can start your panel discussion. Dr. Unnikrishnan will join in. Dr. Preeti and Dr. Meghna.
Yeah. So let me start with a question to Jess. It was a very interesting talk and very something which was a bit new to all of us. So I would like to ask a common man's question to you, and the question is, what would be the total cost of this system, and what is going to be the monthly expenses of a patient who has type 1 diabetes and wants to utilize such systems?
Right. So I do get asked that a lot, and that truly depends on what kind of a pump and CGM you are on, or the ones that you can procure. Setting up a DIY loop system in itself is actually very, very inexpensive. For example, the system that I had, the Riley Link is a one-time investment. It's $150, which you can just buy online. And you would require an Apple app developer license, which is about $99 a year, to build your code. So apart from that, so setting up the system itself is about $150, $200 one-time cost. But of course, it depends on the pump and CGM you are on, whether that's a Medtronic pump, what are the consumable prices of that. That would not change depending on the system of the DIY loop. So setting up the DIY loop is very inexpensive. Yes, you would require a laptop and a smartphone. That is a prerequisite. But setting up the system is about $200 one-time cost. The other monthly expenditures is based on your pump and CGM.
Well, I think it was a wonderful lecture on DIY and also on exercise and type 1 diabetes. I enjoyed both, and of course, Dr. Tejas, fantastic as usual, and Dr. Ganesh, so I have no words. He's done outstandingly well on hypoglycemia management. I just have one question to all of you. Maybe we can start with Nupur and then Jazz and then the others. Each one of you, could you talk about some technology that's going to come up that's going to change lives of people with type 1 diabetes soon? Something coming up soon, anything that you like.
Thank you, Dr. Unnikrishnan. Really enjoyed everyone's talks. I think for me, I now realize the CGM is probably something I value as a really important piece of technology, and currently there are very limited options for most of the people. So it would be nice to have more options so that people can choose from. Yeah, thank you.
Your wish list, Jazz.
So actually, I'm going to go the other way around over here. And I had a very interesting discussion with a friend of mine. And what I would like to see coming up for more of the population of India specifically is needleless pens. And I have seen some research happening on that, because it's always going to be that a majority of our population will be on MDI, as much as we would like them to be on pumps and stuff like that. But to have a more painless, needleless injection for insulin, or like I said, we had a great tryout at the nasal insulin, something like that, that can make administering insulin a lot easier. That would be my wish list.
I think as far as diet is concerned, I would like to wish that even more flexibility, if that could be offered with some technological advances, like some app support for carbohydrate counting, or some scales which are readily available nowadays, which will definitely tell you when you weigh the food, you will know the carb counting. So such advances will definitely have more flexibility and still have a better variety of options in the diet and get good nutrition as well as better sugar control.
Ganesh.
I have two kinds of wishes, basically. First is that some sort of a make in India kind of technology, which is like custom made for Indians, and obviously more affordable for majority of the Indians, so that the access to technology is improved, even with the existing technology. And secondly, maybe to think of managing type 1 in a slightly different way, going through mind's way. I mean, because the technology may add a lot of burden to the to-do list, and it can overwhelm somebody who is already at the brink. I mean, I hope you're getting what I'm trying to say, that like working through the mind. I mean, if the mind is stable, I think everything can be wonderful, as we have seen what Nupur and Jazz have done. And I would really thank you for this is, I think, one of the first time I have seen in a conference that people with type 1 diabetes have such a significant representation. So that is really wonderful of you.
I actually thought of this a lot, and I've always wanted patients to attend our conferences. Many doctors are opposed to it because they say that patients may not like what we're discussing, and patients may get worried and scared. But I think patients at a conference is something that we as doctors should be open to, and we should think of accepting. And I think this is one problem. Type 1 diabetes is a problem that it's so important that people come, because we as doctors learn much more from discussions with type 1 diabetes people than we learn from books. So from a learning perspective, because type 1 diabetes, a person with type 1 diabetes understands their glycemia much better than their doctor does. And that's a fact. And we can go one step further, and it's a learning experience for us. So it's not a question. I always tell people who tell me that patients should not be invited to conferences, I always tell them that it's not only for the patient to learn, it's also for us to learn. We need to see that side of the coin, and I'd like to know Dr. Preeti Golub's and Dr. Meghna Chawla's views on that, because I think this is the first time we also, of course, we've had people with my friends with type 1 diabetes, etc., coming to our conferences. The first time we've opened it up. And what's your view on that, Dr. Preeti Golub and Dr. Meghna Chawla?
Sir, it was extremely interesting to hear some insights of type 1 diabetic people, especially the technological advancements. There were so many things I learned from Jazz's talk. Even as a doctor, I did not know there were so many advancements on DIYs. So definitely, it is a two-way learning experience. And they should be involved in all kinds of discussions. Because I rightly agree with you, sir. I see children right from the age of 1 onwards with type 1 diabetes. And it's really a challenge to manage. Things that I really wish and look forward to is, I hope insurance policies start covering type 1 diabetes. There should be easy accessibility to insulins. We're still very, very far away from achieving what we actually should be doing for the children. So that's my top most priority, that at least some kind of insurance policy should come in for these children, and the government should be more proactive in helping them out.
Dr. Golub.
Yeah, even I agree. It was very inspirational to listen to Nupur being a type 1 diabetes and running lots of marathons. In fact, I sometimes, if I had not heard you, I would have thought if somebody who's type 1 diabetes asked me about running a marathon, I would have been scared myself to allow that patient to run, So such things coming in from the patients directly adds a lot of information, and maybe it is more inspirational to the other patients and to us as doctors also, to allow the patients to, if we would not allow them to. And that's not knowing a lot of things about very good idea.
I think the next step, I don't know, I may be sounding a little too futuristic or something like that, but I think the next step will be to ask people with type 1 diabetes to join us in the consensus statements that we make. Now, we make a lot of consensus statements, position statements on management of diabetes. And all these statements are written by doctors maybe nutritionists, physiotherapists, but we usually do not have a patient representation in this. So my wish is that when we have a consensus statement, we would like at least one or two, maybe Nupur or Jazz or both, to come as authors of the consensus, so that I think that's where we can really make an impact, because then our guidelines that we write will be really grounded. And I always also agree with Dr. Chawla's statement, and just want to open it up to everybody here, is that in India, the sheer burden of diabetes is and the heterogeneity is so huge. I mean, there are patients who can't even afford insulin injection or a single glucometer test. And this is something which, if you look at the UK, for example, I just read Dr. Parthakar saying that 60 to 70% of UK type 1 diabetes have access to CGM, and it's going to be, it's going to be standard of care for everybody. Whereas we in India are, even glucometer is really difficult. So yes, I think there can be a lot of CSR, there can be a lot of charity companies can do, but I think it's time where, organizations also brought it to the notice of our government that, type 1 diabetes, the suffering undergone by people with type 1 diabetes who don't have access to or who can't afford basic technology. So that's where I think, these are some of the next steps. And of course, in the very future, I'd like type 1 diabetes people to also be involved in research, to be involved in research. For example, in the US, the JDR is actually, funded by type 1 diabetes people. So I think these are all areas that this is not true for other diseases, like maybe type 2 diabetes or cardiovascular disease or diabetic kidney disease or retinopathy. Research may not be amenable for people to come in, but this is an area where, for example, when studying monitoring or medications or pumps, I think type 1 diabetes is really amenable to that, and I'd look forward to that. Some thoughts may be a little too revolutionary at this stage. Dr. Ganesh, your thoughts?
I think these are very practical thoughts, and yes, I mean the discrepancy is going to remain for a while, but whatever we can do to minimize it, and having people with type 1 on board for consensus statements. And yes, it is certainly, because increasingly the concept has to shift from we being the leaders to kind of we being a teammate, basically. I mean, so that concept is really good and important, I think.
Dr. Tejas, your views on that?
And I simply find it difficult to cope up with the technology. So I would rather have Jazz or somebody teach us about DIY or other things. It's really tough to read about it and understand.
Yes. Even I feel that participation of patients makes great difference, especially even in patient care where we see no OPD. Even patients can teach other patients to take insulin, to have check their blood sugar levels, to use CGM. That works even better than, counseling by a healthcare professional. So I think their involvement right from the care till the research level and, even further is definitely helpful, and that will be really great if it happens.
So, Jazz, may I ask you a little controversial question? Now, supposing you did the DIY insulin and the artificial pancreas, but won't that break the warranty of the product? And will if something goes wrong, will the company give a free device or replace it? What is the company stance on that?
I don't know, and I hope I never get to that point. But I don't think. I don't think the companies need to know that I'm DIY looping. For them, it's just that it's a procurement of a product, and whether something goes wrong, nothing of the product changes with the system. So that way, we are a little bit on the safer side. But just to add on to what you were saying about patient participation, I think it's so important because, there's a wonderful quote by the WHO which says nothing about us without us. And oftentimes I'm so thankful that you have involved Nupur and me in this kind of a panel. And we do feel very humbled that we get invited to things like this to put this side perspective up there. And I think the one thing and what you said is right, there are projects, there are CSRs, like we're currently supporting 500 children with free insulin. What really bothers me constantly, and the question that irks me, is about sustainability. I mean, this project will get over in a year, then what? So I think the sustainability can only be brought on at a policy level. And I think if there is a fruitful collaboration between HCPs and persons with diabetes, we can truly make some sort of a dent, even at the state government level, if not the central government. But that is the only way. And I agree with you completely. It's the only way that we can have any sort of progress on this.
I think well said, and I completely agree that we need to bring at least the price of a glucometer, the price of a glucometer strip.
Yeah.
Price of course, as we speak, I know that even in countries like US, there is sometimes a shortage of insulin, and I think in countries where there is war or strife going on, children may not get their insulin. So I think what you said is very important. And now let me come to Nupur. I remember talking to Nupur at one of the meetings sometime, and she showed me her HbA1c rate 4.5 or 5, and then she was on a very, very low carb diet. And in her presentation, I remember she showed that there is a defined line between ketosis and, of course, something more advanced. To what extent would you, this is, as we talk, we are being listened to by doctors, GPs, patients, their family members, experts. Could you talk about that fine line a little bit more? Because the lower you reduce your carb intake, the better your glucose is, but your chance of ketosis goes up a little bit. So can you talk about that fine line a little bit more?
Sure, doctor. Thank you. So I know that my chance of developing DK or ketoacidosis really comes into play when my sugars are over 250. And along with low carb, while there is no right or wrong way to manage diabetes, I find low carb to be good for me. It may not be that way for someone else. I find that going above 250 or 200 itself is a fairly rare occurrence. So I know that the chances of ketoacidosis or a medical emergency are very low. Also, like thanks to CGMs and being able to use them, I'm checking my sugar like 50 times a day. So I'm really sort of keeping a very close eye on it. And yeah.
Would you like to comment on that, the keto part? How much supposing at different ages, could you give us some guide as to what is the minimum amount of carbs that people should take with type 1 diabetes, so that, because we don't want them to go into ketosis, at the same time a little bit low carb helps them also.
So was that a question to me, sir?
Yeah, you can also answer, and Dr. Tejas also. Ganesh, you can answer.
So actually, with respect to low carb diet, there are I have 2-3 views. Firstly, I have 1 or 2 families who have been trying low carb diet. It takes immense amount of effort to sustain a low carb diet and cost too. So it does take a lot of cost. Secondly, obviously scientifically in children at least, the long-term impacts on their growth and other things are not yet known. Secondly, the one point is that keeping A1C of 4.5 or 5.5, we don't really know whether it is better than having a A1C of 6.5 or 7% or less than 7% like that. So these are some of the questions. So right now, if somebody is having firm belief in that, I don't kind of discourage them. We say that we will continue to observe the growth and other parameters and other things. There's just 1 or 2 families who are doing that, but most other families who tried found it really difficult to kind of have almond flour or those imported cookies or some other things to be obtained and kept. So in general, on my own, I would say that I would go by standard recommendations to keep carb intake as about 45 to 50% of the total caloric intake, and to obtain them from complex carbs. Indian diets have high amount of carbs, so definitely that kind of needs to be sorted out. But on a practice basis, I do not advise as of now low carb diets. But I'm open to learning.
Well, actually, for vegetarian population,
yes.
It's a great problem. Yeah, comparatively, if a person is vegetarian, then very low carb diets will have very less compliance because of less options and less permutations, combinations. And as Dr. rightly said, that for kids which are still growing, the impact of very low carb diet on their growth is not yet clearly known. So it's better to have a good range of carbs in diet until at least the person is growing. Maybe in the adulthood, low carb or very low carb keto kind of a diet can be a good option. But for kids, even we don't recommend too much of keto and low carb diet.
So in type 2 diabetes, for example, this is picking up quite a bit. And I'd like Dr. Golab to come in and talk to us about her views on, a lot of people are trying this 2 meals and intermittent fasting in type 2 diabetes. Is that something you like in general, Dr. Golab?
So my this is first of all, such fat diets do not last for long. So there are lots of people who really get inspired to follow such diets or maybe a year or so. And once the things get as bad as they were, these patients who are on this intermittent fasting diet get better health as compared to thin and lean diabetics, because as it is, these lean diabetics have a very low insulin reserve, and doing such diets in fact makes them more prone for getting hypoglycemias, as their sugars are very difficult to manage as it is. So from my third most important thing is, lot of patients, what they're doing is eating twice a day. From what a certain person advises, eat whatever you want. So they just go on binge eating in those 2 meals. So there are lots of people who are eating all sorts of junk foods like vada pavs and whatnot during that 2 meal pattern. So that is another certain very severe carb load that we are giving it with such sort of meals. So personally, I do not recommend it to any of my patients, but of course I don't discourage if anybody wants to follow it. It's their choice. But knowing that there is a chance of hypoglycemia, especially if they are on sulfonylureas or on insulin.
So I completely agree with that. And let me just add that I just met Dr. Nupur, and that time she was following the diet, but she was also not following a fat diet. She just cut down the carbs a little bit. So I'd like to just ask both Nupur and then Jazz about, Ganesh has spoken about it, and Meghna, Tejas, Dr. Golab, all have spoken about it. Now, one thing I just want to ask you, at what point, so you're all people, you have type 1 diabetes. So one thing is that you don't mind talking about it, but many type 1 diabetes people don't want to talk about it. Second, not only you don't mind talking about it, you are also giving talks about it. You've gone out to the community, upnowed people with type 1 diabetes as part of your family, extended family, and you're both taken them together on a journey. How did that thought come to you? First, I'll ask Nupur and then Jazz. How did you embark on this journey of doing something for a larger good of people with type 1 diabetes?
So for me, I think I was on a solitary journey as well for a very long time. I had the support of others, but I chose the solitary route. Eventually, I realized that it's not going to work this way. Whatever. At the end of the day, like social animal, we do look for friends and community, and it definitely helps. There are a lot of people in the community who are just lurkers. They are just there, they're looking, they may not be engaging actively, but I know that that's making a positive difference in their life, because being exposed to these discussions, and I know Jazz would have a similar experience to an extent. It doesn't have to be that each person has to engage a lot. There's a lot to be learned by observing others as well, and I think that these communities such as ours play a role in such a thing. Thank you.
Jazz, you know, I was just remembering the photo you put up on Twitter of a little girl in the hospital with an IV line. And then I looked at that picture and said, oh my God, that little girl is now somebody completely different, confident, successful. So from that little child with type 1 diabetes, I'm sure Nupur also, I think since the age of 8, you have type 1 diabetes?
Yes, doctor.
2 years? How many years now?
26 years.
26 years. So Jazz, similarly, you know, from those little children, you've come a long way and you've actually championed the cause of people with type 1 diabetes in the country. So like Nupur said, you're also making a dent in the universe of type 1 diabetes in your own way, both of you. So your thoughts on how you made the transition and why you made the transition.
Thank you so much for this question. So I think like Nupur said, it was a very solitary journey for a long time. I did not know a single other person with type 1 diabetes until I started Diabetes. And I think that's the case for a lot of people in India because we didn't have, I mean, it's just been a couple of years since this idea of support group has been championed. We didn't have these things when we were growing up. And I'm sure Nupur would agree on that. We didn't have like these peer support groups and stuff. What happened with me was that I was very curious to learn more about it because as we know that at least in my hospital and I had a great doctor, but I was never taught about living with type 1. You know, I was told that ye hai insulin, ye hai diet chart, go. But it was never sort of told about how do you manage, how does stress affect your sugars, this, that. So me being the curious kid went onto YouTube and started searching for type 1 diabetes videos. And to my dismay, I found very, very long 3-hour lectures. And for a 13-year-old, it was really not interesting at all. I'm not going to sit and watch a 4-hour lecture. You know, I want something fun to be able to explain. So the idea of Diabetes started off just wanting to create a YouTube channel that can make learning about type 1 diabetes interesting. That's how it started. And then when we said, okay, let's have a meetup of a few people, you know, let's just see what is out there. And I was expecting 5 people to join that first initial Dia meet. And I was like, even if 5 people join, I will be happy. I made personal phone calls to my doctor's patient list saying that, and the first thing I would tell them is, I also have type 1 diabetes. You know, that was my icebreaker. I thought, okay, 3-4 aayenge, main khush ho jaungi. But in that first Dia meet, 25 people showed up. And the need became even more evident in front of me. And then over the years, when we started interacting with different communities, different economic backgrounds, we just found that the hotspots were so much. And we said, whatever we can try to do, even if it affects one person, it's one person affected for the better. And that's how the community has grown.
Thank you. I think this has been inspirational. And before we end, we have just 2 or 3 more minutes. I'd want all of you to come in quickly with one suggestion you have to improve the lives of type 1 diabetes. We'll start with Dr. Preeti Gholab first, and then we'll go to Dr. Ganesh, etc., but to Dr. Meghna, then Dr. Ganesh. So Dr. Preeti, one idea.
I'll have to think about it. I mean, maybe a better to start with better education from grassroots level, so that all the individuals are able to able to do carb counting and accordingly adjust their insulin doses. And as we have already discussed, the economical part of it, because most of the type 1 diabetics are very poor kids. So support by the government and CSRs for their medicines and insulin.
Thank you. Dr. Chawla?
I would love if all the children who have type 1 diabetes can afford at least rapid acting insulin analogs to manage their glycemia better. And it's so difficult because of the costs that they have to bear. So lots of NGOs and lots of things should come forward and help children with diabetes. So that's something that I would really want first.
Ganesh?
Yeah, I would just say that we work on a paradigm shift in our thinking from calling it as a disease to a condition. I mean, and calling somebody as a diabetic patient to a person or a child with diabetes, because I mean, what is disease? I mean, a person with diabetes takes insulin, checks sugar, and I mean, how is Nupur more diseased than me? I mean, I think that that frame shift or paradigm shift is what something I would look for.
Dr. Tejas.
Yes, I wish the stigma associated with type 1 diabetes, if it goes off, it will be really good, because we see our kids facing many problems in the schools, the society. So I wish if people accept it as a condition, like somebody has specs and he uses it. Similar is type 1 diabetes. That person is not producing insulin and he's taking it, that's all. And if that stigma goes off and those unnecessary, advices, similar advices given to type 2 diabetes are always given to type 1 kids. So if that goes off and if there is awareness, it improves in the community itself, it will definitely help ease the people and families of type 1 diabetes.
Nupur.
I just want to echo what Dr. Jivalikar had said earlier about working as a team. It's not about the top-down approach that my doctor told me and I have to follow. It's about taking ownership, discussing with your healthcare professionals. So teamwork, I think, is the key. Thank you.
Jazz, final thoughts.
Yeah, I think everyone has absolutely perfect thoughts in the utopian type 1 future. I think one thing that often gets left out is care for caregivers. At least for younger kids, we don't have a support network for our caregivers, and they are the ones who are taking decisions for the younger kids. So if their stigma can be, disillusioned, if they can get the right information, then it echoes into their children. If they are confident, their kids will also be confident.
I completely agree. So, when you travel in a flight, the air hostess says, or the steward says that, put on your masks before putting the masks on the other person. Similarly, I think caring for the caregiver and also, caring for the person with type 1 diabetes is important. I think I could go on all day like this because this is a subject I'm also equally passionate about, but there's somebody outside my room reminding me that the inauguration is going to start. And for the inauguration, we have Professor Niels Goring. He's the chairman of the Nobel Prize Committee for Medicine and Physiology. And let's remember, insulin has won a lot of Nobel Prizes, the discovery of insulin, right from Banting, Best, MacLeod, Collip, to Dorothy Hodgkin, who described it, to Sanger, who discovers the structure of insulin, to Pavlov, who discovered pancreatic physiology, to Rosalind Yalow, who found a way to measure insulin, probably the only molecule to have been associated with so many Nobel Prizes. And on that note, let me thank all of you for a truly inspirational session. Thank you all. Thank you. Dr. Rajesh is also here. And thank you all. And over to the organizers of the best hall for the event to continue. It was awesome being with all of you.
Thank you so much. Thank you.
Thank you. Thanks a lot.